Avishkar.
And I am Shravani.
Hope you all had encouraging and memorable experience yesterday. So after a highly informative and inspiring first day, it gives us immense pride to welcome you to Day 2 of STETHOBEATZ 2026, a national student-driven academic initiative of Government Medical College Hospital Miraj, an institution with a glorious legacy of 63 years, committed to the shaping competent, compassionate and confident medical professionals.
Over the past days, this platform has transformed into a vibrant hub of learning and skill building. We successfully conducted a wide range of hand-on workshops, including suturing, OBGY and pediatric skill sessions, skill lab training, FMT workshop, wound casting, research methodology, ECG interpretation, radiology, and for our postgraduate delegates, BLS and ACLS training.
Adding to academic rigor, where our paper presentation, poster presentation, and case presentation competitions, where young minds showcased innovation, clinical reasoning, and research excellence.
Today, as we move forward with further insightful orations, we continue our mission of bridging theory with clinical practice, fostering collaboration, curiosity, and excellence.
With great enthusiasm and academic spirit, let us begin day 2 our CME. I request all the dignitaries to kindly come forward on the stage. Dean sir, MS ma'am, please come forward on the stage. Now I request our respected Dean, Dr. Prakash Gurav sir, to kindly felicitate our esteemed orator, Padma Shri awardee, Dr. John Ebenezer sir. Now I request Dr. Nitin Chikordikar sir to felicitate Dr. Prakash Gurav sir.
Now I request organizing secretaries Srushti and Nilesh to felicitate Dr. Priyanka Rathi ma'am.
Now I request Tejal and Omkar, our academic secretaries, to felicitate Dr. Vikas Rokde sir. Now I request Alok and Janvi to felicitate Dr. Shrikant Ahankari sir.
Now I request Athava Shinde and Aditya Pujari to felicitate Dr. Shailesh Bhave sir.
Now I request Aniket and Sumit to felicitate Dr. Rokde ma'am. Now I kindly request all the dignitaries to take the seat in front of the dais as we start the session. Ladies and gentlemen, get ready to witness brilliance, experience wisdom, and be inspired by excellence as we present a glimpse of our distinguished orators. Dr. John Ebenezer Sir, internationally renowned geriatric orthopedic surgeon, Padma Shri awardee, presenting the art of orthopedics now and beyond, a masterclass blending experience with evolution.
After that, Dr. Vijaya Lakshmi Deshmane ma'am, Padma Shri awardee, surgical oncologist and a pioneer in community cancer awareness, presenting breast cancer and community education, an inspiring voice advocating awareness, early detection and empowerment.
Then Dr. Monica Kulori ma'am will be speaking and giving insight about the evolution of cosmetic gynecology.
After that, Dr. Tushar Dhopde sir, MS, presenting modern approach to cardiothoracic trauma, a session that brings precision, preparedness and progress together, redefining emergency cardiothoracic care with a modern perspective.
After that session, Dr. Taru Jindal ma'am, author gynecologist, presenting Bombay to Bihar, my journey of bringing change to the grassroots, a story of courage, compassion and commitment beyond the clinics.
And as a knowledge meets innovation, we present a session that dares to question the future itself, panel discussion, AI versus medicine, where technology challenges tradition, where algorithms meet experience, and where the future of healthcare is debated in real time. This engaging exchange of ideas promises insight, perspective, and a deeper understanding of how AI and medicine will shape the years ahead.
Now for the today's theme of the conference is Art of Medicine Before, Now and Beyond. That challenges us to look at our profession not just as a job but as a legacy. Before represents the soulful foundation of our healing where intuition and physician's touch were paramount. Now is the peak of our scientific prowess where data and technology have given us a godlike precision.
But beyond is the most exciting frontier. It is the synthesis of both worlds where we take the cold efficiency of modern tech and infuse it with the warm, holistic wisdom of the past. It is about treating the patient as a whole human being and not just a set of symptoms on a screen.
Now we hand over the mic to Porus and Anushka.
Good morning everyone. Now I'd like to start today's CME session. So I request Chairperson Dr. Vikas Rokde sir, HOD of Orthopedic Department to come on the stage for the session.
And now, to speak on the bridge between before, now and beyond, we are joined by a man who is the living manifestation of this evolution. It is a proud privilege to introduce Professor Emeritus Dr. John Ebenezer, an internationally renowned orthopedic surgeon, respected geriatric specialist, and the visionary pioneer of holistic orthopedics. Dr. Ebenezer's career is decorated with the highest honors of our land. He is a Padma Shri awardee and a recipient of the prestigious Dr. B.C. Roy National Award, the absolute pinnacle of medical recognition in India. Remarkably, he is the first and only orthopedic surgeon from Karnataka to receive the Padma Shri and the only doctor in India to receive both these national honors in a single calendar year.
But what truly makes him holistic is his extraordinary academic vision. Beyond being a master surgeon, he holds a PhD in yoga and serves as Professor Emeritus of Yoga and Life Sciences. By seamlessly blending ancient yogic wisdom with modern orthopedic science, he has pioneered research-based non-surgical solutions for chronic pain, earning him the revered title, the Hippocrates of India.
His recognition are extraordinary. A two-time national awardee, recipient of MCI Silver Jubilee Research National Award and Padma Mahan Award to 2025. He is the only Indian surgeon recognized as an AAOS international researcher with 70 plus scientific publications to his name. An 8-time Guinness World Record holder and author of over 200 orthopedic books. He is celebrated globally as a legend, yet remains deeply rooted in service, honored with the Karnataka Rajyotsava and Kempi Gowda Award, and known as most trusted orthopedic surgeon in Bangalore. He continues to lead the Stop Arthritis movement, promote affordable, value-based healthcare for all.
Today, he will be speaking on the topic The Art of Orthopedics Before, Now and Beyond. He is a mind-body consultant, a philanthropist and true mentor for the next generation. So ladies and gentlemen, please stand and join your hands together for a big round of applause as we welcome the legendary Dr. John Ebenezer to the stage.
Oh my God, so many things told about me. It has made me nervous now. I don't know how to handle all this. Anyway, good morning all. I was given time from 10 to 11. Already it's 10:30 now. Do you want me to cut shut my talk and speak only for 30 minutes now? No. Okay, fine. Thank you. Thank you. Can you please help me with the slides, please? I'm delighted to be here in Miraj. This is my first visit. And lovely to see all vibrant young faces. How many of you are interested in orthopedics? Please raise your hands. 1, 2, 3, only 4, 5. Maybe 1 dozen. That's all. What rest of you are going to do? Medicine, pediatrics, OBG. So that means orthopedics is not a popular choice. But it is the most happening specialization. Now, orthopedics from trauma to osteoporosis, it's a huge branch. So I think a lot of people should now take up orthopedics as their specialty. I'm going to speak on the art of orthopedics. You people think that art is not meant for orthopedics. Orthopedics is all hammer, screws, saw. There is no art involved. It is not so. It is a medicine. It's a surgical branch where there is art involved in orthopedics. And that is why so many female candidates are now taking up orthopedics, because it is now considered as a very specialized science. Thank you, Government Medical College, Miraj, for the invitation. And my credentials have been told enough for you, so let me go ahead. But the topic is the art of orthopedics, before, now, beyond. So you are used to listening art of medicine, art of surgery, but now listen to what is orthopedics and how that it has shaped the future. There are 2 parts of my talk here. Let me give you the brief outline. The first part will help you to know the road. What is the road you are supposed to take? Road means not those roads. Road means your professional roads. Second, what is the road map? Nowadays all GPS, you know how you go with the GPS, your road map. So for you as a professional, what is your road and road map? For you all, in your career and life, there are 2 things. Career is different, life is different. So the first part will dwell into the 3 areas of orthopedics. That is before, now, after. That is, I call them as CID. C is clinical era, I is investigation era, D is digital era in the future. The second part is to set up a roadmap. The knowledge you gain by understanding the CID will help you do two things. Either you will set up a successful career, or you may end up with a successful life. Successful career, most of the people who are sitting here want successful career. Very few here want successful life. So that is what my second part of the talk will be. Earlier, orthopedics was clinical judgment. Before imaging, we used to make clinical diagnosis. Fracture diagnosis and deformity correction in the pre-CT MRI era. What were the earlier diseases? Even now we have these diseases, but earlier these were the predominant diseases: congenital, developmental, infective, inflammatory, traumatic, neoplastic, metabolic, and degenerative. These were the primary diseases then. Now also we have, but in addition, now there are lifestyle problems, geriatric problems, so many modern problems which are added to the diseases of orthopedics. The evolution of imaging has profoundly influenced orthopedic practice. Conventional X-ray followed by CT, MRI, and advanced intraoperative imaging has improved diagnostic precision and surgical planning. Do you all agree with this? However, prior to these developments, fracture diagnosis and deformity correction were achieved through meticulous clinical examination, anatomical reasoning, and an ultimate intimate understanding of fracture biomechanics. This is something which is now vanishing, the clinical judgment. For the PG orthopedic trainee, revisiting these principles. What principles? The clinical examination and pre-diagnostic era is not an exercise in nostalgia, but a means to refine the judgment, improve decision making, and prevent technology-driven errors. Even in modern practice now, clinical acumen remains the cornerstone. Even in future, without clinical acumen, you cannot become a good surgeon, physician, gynecologist, whatever it is, upon which imaging must be interpreted. How we used to unravel the mystery as students like you, we were also students like you some 4 decades back. What we used to do? No chat GPT, no YouTube, no social media, no checking on the internet before answering the questions from the professor. You don't need to have any knowledge nowadays. If somebody asks you a question, just open the Google, find the answer, give the answer. It was not so in our era. There, we had to listen to the patient, not to the gadgets. We had to do general examination, which is to give us vital clues. Then local examination, also in a methodical manner. Look, feel, move, measure. That means we have to inspect, palpate, and then measure both movements and the length. Special tests need to be done, like Trendelenburg test, all those telescopic test, McMurray's test. We used to be expert in doing all those tests. Then conclude, analyze, put everything in order, then analyze, then come with a probable diagnosis. Then the only investigation what we had was X-ray and lab. That's all. So we had to come to a diagnosis. This was how I learnt my orthopedics. How to unravel the mystery of bones and joint, history, inspection, palpation, you all know. And in the history, doesn't just ask from which place you are coming, what are you doing. That is not the history. The history is present history, past history, and other histories like family history, socio-economic history, personal history, occupational history. So many history we have to take to understand the patient. After history, just simple clinical examination, we diagnose fractures like coolies, even without seeing an X-ray. Just see the dinner fork deformity, do the styloid process test. If both the styloid process are in the same line, 100% it is Colles fracture. Nowadays, if the patient comes with a wrist injury, first thing, we don't even touch the patient. Get an X-ray. And what X-ray will tell, we will tell the patient. It was not so for us like that. Anterior dislocation of the shoulder, spot diagnosis. Just look at that patient. Look at the deformity. Diagnosis done in the casualty. Okay, then we used to take X-ray. Now it is reverse. First I take X-ray. I'm not sure, whether what is this. And I will then do the clinical examination, or I may not do also. I may only offer suggestions. Spot diagnosis of posterior dislocation of the hip. Flexion, internal rotation, adduction. How many of you are aware about this kind of spot diagnosis, spot inspection nowadays? Simple forward bending for the patient is enough for you to make a diagnosis of no major spine problem. Even though the MRI is showing gross disc degeneration and disc displacement. You can look at that MRI there. You can see that, how does this work? Pointer. Like this? Are you like this? This one? No. This one. No, man, it is slide changer. Go back. That's a slide changer.
This one for slide changing, and this is the pointer that it doesn't work on.
Okay, fine, got it. See, if you look at that MRI carefully, you can see two-level disc problems, what we call as disc bulge or disc prolapse. So, seeing that MRI, we will tell patient, get operated. But a simple clinical test, where patient can bend forward and touch the toes is enough to rule out major spine problem. See this, a IVDP case, patient is not able to bend forward, there is a scoliotic deformity, we make a diagnosis of intervertebral disc prolapse. No MRI required. Simple straight leg raise. If the patient can raise the leg up to 90 degrees, sciatica ruled out. Sciatica ruled out. So that is how we used to make diagnosis. The diagnosis of fractures on the bedside with classical signs and deformities in orthopedics used to help us clinch the diagnosis, right? So this was the approach what we followed when we were MBBS students like you. History, the mechanism of injury, so important. You have to ask the patient, how did he fall? We seldom ask this. See, fall on an outstretched hand. The reverse hit by that machine and traveling and holding it, sudden break, patient develops wrist drop, and the nightstick fracture, the policeman assaulting a thief, he takes the beating on the outer part of the ulna. That history, very important. It will give you a clue that it is a ulna fracture, right? And you can see that aviator fracture, the clutch, that person, the foot is jammed between the clutch and the seat. So he gets talus fractures, okay? And here, a fall on the back, scapula fracture. That means the mechanism of injury, very important. You need to ask the patients who come to you, what was the mechanism of injury? Not just look at his swelling and ask for an X-ray. Inspection, very important, which remains the most undervalued yet informative. Limb attitude, alignment, visible angulation or rotation. You can see there's a posterior dislocation of the elbow. You can see that prominent ulna. So that it gives you an idea that it's a dislocation. Skin conditions, see that. The plaster blisters or the wound blisters will help you to understand that it could be a compartmental syndrome, and that is the value of inspection. Wind swept or tackle deformity. If you look at a deformity like this, it is vitamin D resistant rickets. That's it. No other differential diagnosis here. Straight away, one side there is genu valgum, the other side is genu varum. The only condition where you get that is vitamin D resistant rickets. You don't need rocket science to make a diagnosis. You don't need GPT. You don't need YouTube, nothing. Look at the image, you will come to know what it is. This triple displacement, TB knee, the diagnosis, finish. No need for man-to test, no need to do chest X-ray, all that. You see the triple displacement, flexion, posterior displacement, lateral rotation, diagnosis of TB hip is done. Okay? And these are the attitudes you have to look, how the patient presents to you on the emergency room. Flexion, shortening, rotation, all this, the greater trochanter thickness, all this will give you a clue of diagnosis. And then you take the X-ray. It is not reverse. First you take the X-ray and then look at the image. No, look at the patient. It is not like that. Palpation, a great, your hands. You can detect so many information from your hands. Palpation, the way you palpate. The tenderness, grading of the tenderness. Is it 1, 2, 3, 4? So, what is the spasm? What is this? If you see the deformity like this, it's a knuckle deformity, right? Here you can see that there is whatever a fracture, right? There is no other diagnosis that can be made if you look at a deformity like this. So, what I'm trying to tell you is, these simple things, like history, examination can take you to the diagnosis, and it will be most of the times correct. Spondylolisthesis, unmistakable clinical signs. Unmistakable. What are those? Deep transverse furrow. If you look at, maybe your elders, if you look at your house, you can make a diagnosis at home or in a village also. You need not be in a big center to make a diagnosis of spondylolisthesis. Deep transverse furrow, exaggerated lumbar lordosis, positive step sign, severe restriction of forward flexion. Spondylolisthesis. Take an MRI X-ray, your diagnosis is confirmed. Don't take the MRI first and then go back for the diagnosis. That is wrong way of doing things. And greater trochanter. If you look at the greater trochanter, is it broad? It is thick? Is there temperature? Is there tenderness? Is there displacement? Head of the femur, where is it? Where is it? Whether it is in the dorsum whether it is in the groin, whether it is in the perineum. I want to ask you who are sitting here, who might have finished the orthopedic clinical course already, have you done all this in your lifetime? Have you done a telescopic test? Have you done a Trendelenburg test? Functional assessment. Have you done the extensor lag test? Patient is unable to bear weight. Trendelenburg test has to be done. Patient is not able to extend the leg. Diagnosis is quadriceps injury, quadriceps tear. Have you done this? Telescopic test. It tells about non-union fracture neck of femur. You just push the femur and the trochanter hits your palm there and the diagnosis is done. Okay? So, critical analysis of fracture deformity. When there is a fracture, you have to make a critical analysis of fracture deformity. What do you mean by that? Before imaging, deformity analysis. It's a 3-dimensional mental exercise. 1, angulation, fracture angulation. 2, rotation, limb is rotated. 3, shortening. 4, translatory movements. So the mnemonic here is ASRT. Angulation, rotation, shortening, translation has to be done when you encounter a case of fracture. Tomorrow you people will be doing emergency ward duties. 2 days workshop went on here. How to put IV drip, how to revive a patient, how to put a plaster, how to do all that. But first learn how to diagnose. If you do a wrong CPR on a patient who has got fractured ribs due to road traffic accident, you will kill the patient instantly. You try to do mouth-to-mouth breathing without even looking at the cervical spine. Whether in the road traffic accident, the cervical spine is all right. If not, the moment you hyperextend the neck, patient is dead. That means what? That means clinical diagnosis cannot be replaced by anything. How to measure the rotation? Simple great toe, observe the great toe, use a tape from there, and if it is outside that line, plumb line what we call, then there is rotational deformity. So biomechanical basis of the deformity. Muscle forces, gravity, position at the injury, give the biomechanical deformity, developments. So examples, femoral shaft fractures, total rotation, shortening, femoral shaft fracture. Gross shortening, total rotation is femoral shaft fracture. Slight rotation, it could be intracapsular fracture. Total rotation, it is extracapsular fracture. And what beautiful, you should really enjoy making a clinical diagnosis. You can challenge AI. The AI may go wrong, but not your clinical judgments. So that is how God has made. Otherwise, do you think for centuries we have been practicing medicine? How people used to diagnose then? How Hippocrates diagnosed? How Socrates diagnosed? How did they practice medicine? With no AI, nothing. Only observation, only eye, brain. That's it. So we need to get back to that era. after doing all this, X-ray for us, like when we were like you, students. 2 views X-ray, AP, lateral, always told, one joint above, one joint below. You have to take the X-ray. You should not take if there is a wrist fracture. Don't take only this much X-ray. You have to take one joint below, one joint above. And 2 views is mandatory, AP and lateral. Because the entire bone is a cylinder. So you require things like that. Then the deformity correction we used to do. Like, how to reduce a Colles fracture, how to reduce a dislocation. Simple principle of reduction was just undo the whole, the mechanism of injury. That's it. You will be, putting back the joint. So it is a logical sequence and it is not forceful manipulation. You just don't pull and push. Example, Colles fracture, simple hematoma block, and then traction, counter traction methods. Test with the radial. First you do the radial styloid process. The styloid process test, both radius and ulna. You will find that they are both in the same line. Now do the reduction. It will come back like that. Then you are sure that you have replaced the fracture. Simple styloid process test is both diagnostic and therapeutic. You need not take after doing the reduction, you need not ask for a CT scan. Not required. You can do it with simple tests. Technique of reduction of shoulder dislocation. Simple flexion, external rotation, adduction, internal rotation. This is just do the opposite of the movements, then you will get the reduction happening. So, plaster of Paris, POP, the old style POP was our main therapeutic tool then. In fact, this glistening plaster, what I saw in a casualty attracted me towards orthopedics. I was so impressed seeing the plaster. Oh, so nice. I wanted to become an orthopedic surgeon. That was how I got the inspiration. So, what the POP does, maintains the reduction, controls rotation, allows corrective molding and distributed the force evenly. And the PG concept should be, POP acted as a dynamic interface between fracture and healing biology. Nowadays, fractures are being replaced by plates and screws. We put plates and screws everywhere. Plasters we don't use nowadays. And then simple tractions, roll-up tractions, skeletal traction for trochanteric fractures, the gallows traction, what we are seeing there. The gallows traction and the other fractures like fracture femur, supracondylar fracture humerus. We used to use traction then. Now it is outdated. These are all just for historical interest now. So what was the traction doing? Soft tissue biology respected, fracture hematoma respected, gradual alignment restored, used extensively for femoral shaft fractures, pediatric fractures, elderly osteoporotic fractures. So traction emphasized healing through biology rather than hardware. Hardware means what? Plate and screws. So relevance in contemporary medicine, despite advancing image, clinical examination remains mandatory. If I am the examiner of you people, I will ask you only clinical examination, that's all. I will tell you, just demonstrate how you will elicit tenderness. If you are not able to do, I will throw you out of the hall. You may be an expert. You may reel out, all the details of a fracture. But simple test I will ask you to do. Show me how you elicit the temperature. If you cannot do, that means you are unfit to pass. You may become a menace to the society if you go out without proper clinical examination. So, you have to learn this, very important. So, PG training, what is a good physician versus good surgeon? Who is a good surgeon? A surgeon who does surgery in 1 minute, 10 seconds, 15 minutes. Is he a good surgeon? Is he, at jet speed? He operates, he does, interlocking, he does a knee replacement in 15 minutes. Is he a good surgeon? No. What was the definition? When I was a student like you in the pathology hall, there was a big hoarding put. A good physician is one, not who writes big prescription. A good physician is one when he knows when to refer the patient to a surgeon. That is a good physician. And you know who is a good surgeon? A good surgeon is one when he knows when not to operate. Please understand these concepts. All the young minds here are confused lot. They don't know what is a good physician, good surgeon. They think that they are all heroes who do surgeries in 5 minutes, 10 minutes. No, you understand. How the clinical examination, the knowledge, how it helped me. I'll give you a personal example. I was not so fortunate like you all. After my MBBS, my post-graduation, I was posted as a government medical officer in a primary health center called Kikeri in Khanapur Taluk. I went there first day of my posting. I went there. It's a village. Suddenly there was a lot of commotion happening. They brought a lady who was bleeding like a tap. Then they called, sir, please come and look at that patient. I said, I'm an orthopedic surgeon. I don't know anything about gynecology. So you call obstetrics. You call some other doctor. Sir, this is a village. There are no doctors. You are the only doctor available now. Come and see the patient. I was cornered. I didn't know what to do. Then I went into the labor room. Pulseless. Patient pale. Sunken eyeballs. Severe shock. Patient is bleeding. I said, please refer the patient. Hubli was just 30 kilometers away. I said, please refer the patient. Then they said, sir, if we refer the patient in this condition, patient will die on the road. If the patient dies on the road, the whole village will assault you. You will not go alive from here. This may happen to you also. Then I didn't know what to do. Then I asked, okay, call a senior nurse. One A&M was standing by the side. Sir, I am the only nurse here. Then I said, do you know how to cure it? She said, no. That means now I had to save that life, come out. Then I asked her, okay, put the patient on position, or the lithotomy position, whatever position you call that. I've forgotten gynecology now, obstetrics now. And they put the patient on position. I asked for a curette. Then she gave me a curette, which one side was broken. There was only one side which was all right, that too rusted. That was the only option. I had to work fast. I'm losing the patient. Then I started curating. You know how I curated? Without having knowledge, I'm an orthopedic guy. My teacher, Shashikala Hiramet, had taught us in the class, how to assess whether you have done the curettage correctly. She had taught me the steps, and she had told us, you should get grating sensation. Grating sensation means when you grate a coconut, the sensation that you should get. The os should close. Bleeding should stop. Then you have done the curettage correctly. No ultrasounded guided procedures, nothing. Only when I was doing the procedure on that lady, I was imagining the lecture given by my teacher. I was finding out whether I'm getting the grating sensation. I was. Was the bleeding stopping? It was. Did the patient recover? That means, what I'm trying to tell you is, you don't know when you will get an opportunity to use your clinical knowledge. You may be flying in an aeroplane. So many times I'm called, sir, a patient has collapsed. Come here, do the CPR, diagnose. You should have the guts to do it. You can do it only if you have done it. Not on the mannequins, on the patients. Doing on the mannequin is different. Workshop, taking certificate is different. Certificate is different, practice is different. So, this was how I could work in a village, in a remote corner with my clinical knowledge. So, that's what I'm trying to emphasize. Forgotten art. Where is the bedside clinics nowadays? I used to take a lot of bedside clinics. I taught students, evening clinics. For my DNB exams, which was in Kolkata, I had no teachers in the college. We were not taught. DNB students had no teachers only. So, what I did, I started teaching young students like you. I used to take bedside clinics in the night, because the daytime all professors will be there. They will be taking classes. Nobody would come to me. So, I used to take bedside clinic, teach them how to examine a joint, how to measure a bone and all. You know what happened? I became perfect by teaching them. And when I went to the DNB exam, 48 students, only 7 passed, and I was one of them. And I did not know the language. It was Bengali. It was Bengali language. It was in Kolkata. And the case I got was TB hip, tuberculosis hip, and she was a very young girl, 16 years old girl, a male doctor examining a patient without language, there was an interpreter, but it was not helpful, and the whole thing had to be done in 15 minutes time. Long case. It is not given 45 minutes, 1 hour nowadays. The people will not come and tell the diagnosis in your ears. Nowadays, when you are taking exams, you already know the diagnosis. You already know everything. You have to just go and pass, come out, that's all. That also you don't do correctly. Even if you tell you also, they will not do. Because there is nothing inside the brain, no. It's all empty, all shortcut method. I passed in jiffy like that. How? Because I had taught students how to examine a hip joint. I knew perfect. And do you know who was my examiner? Dr. S.M. Tuli, the pioneer, tuberculosis, sir knows. Dr. S.M. Tuli, internationally renowned tuberculosis specialist. 1 millimeter mistake, he is to fail. It is not like that, like nowadays. My son is taking exam, he should not fail. Phone comes from the parents to the administration. I have paid lakhs, crores. He has to pass. So the student comes with all arrogance attitude. He sits like that. So the examiner has to ask the question. He only has to answer the questions. The student will just sit and stare like that. It was not like that in our time. 1 millimeter mistake. When I said there is 2 centimeter shortening, he took the tape. He measured. And he told me, where is the 2 centimeter show? Even if I had got 0.5 centimeter wrong, he would have thrown me out of the hall. Those were the days what we faced. So, battery is running low. Battery is running low. Battery connect करो. 4 लोग बैठे हो, सब इधर उधर बात कर रहे हो, हैं? Connect the battery. Okay, so what is the message for you all here? The message is, okay, become a clinician first, technician next. Simple. This is not rocket science. You understand? Jane do se. You have to become a clinician first, then a technician. Learn the art of orthopedics and not how to take images, right? Foundation of orthopedic wisdom. The art of fracture diagnosis and deformity correction as practiced in the pre-CT MRI era, in my era, represent the foundation of orthopedic wisdom. For postgraduate trainees, mastering these principles ensures safe practice, better judgment, and ethical use of technology. Orthopedics advances when innovation is guided by experience, not when experience is replaced by machine. Why are people nowadays scared to do practice? Why are they scared of consumer law? Why are they scared of physical violence? Why they are scared? Because they don't know. The knowledge is not there. So they want everything to be just handed over in a platform. They don't know how to handle a violent attender. A relative comes he wants to barge and hit you. You don't know how to handle him. Because you have not been trained. You have only learned, how to go and. So this was the era earlier. Is the concept clear? The olden era. The olden era. What was the primary thing in the earlier days? Loud. Clinical examination. Now it should get into your brain. And you should now implement it when you go tomorrow to the wards. Implement this. There are any number of books available. Don't read YouTube, GTP and all. Take the textbooks and read. And understand. And then practice on the patients. Now we come to the present era. What is the present era? Ultra-modern diagnostics. Patient comes to you, you order investigation first. What? CT scan, MRI, PET scan, investigation-centric. We are investigation-centric. We are the slaves of CT scan, MRI. We are not the masters. We don't dictate when we should order MRI. No, MRI dictates us what you should do. So this is the present era. Clinical examination totally replaced nowadays. We rarely do a proper clinical examination. What do we do? Glance approach. Glance approach means what? Just look at the patient, that's all. Look at the patient, over. Clinical examination over. You are like that Rajinikanth robo. If you look at the patient, the brain will act. Then all the diagnosis will come into your, and in a jiffy you will make a diagnosis. The attitude is like that. You have become robos. You look at the patient like this, you have diagnosed everything. Huh? No, it is not so. Present approach, I'll tell you. If the patient comes with back pain, first MRI. The patient comes back and shows the MRI. So many patients have told me, sir, the surgeon will not even raise his head and see like that. He is looking, yes, what is your problem? Back pain. MRI prescription. Then you come back with a prescription. Show the report. He'll show the report. Disc prolapse. Surgery. Go. That's all. 3 questions. Over. So, look, glance approach. Neck pain. MRI. Surgery. Patient comes with knee pain. X-rays. Total knee replacement. Multiskeletal problems. Investigations. All a battery of investigations. Then surgery. Osteoporosis. So many don't know what is osteoporosis. How many know what is osteoporosis here? How many of you know what is sarcopenia? How many of you know what is osteosarcopenia? And how is that reshaping the entire geriatric orthopedics? How many of you know? You don't know. You don't know. So what we do? Investigation. Put the patient on surgery. Patient will come back with one more fracture. Fragility fracture, if you fix, it's a hollow bone. If you put plate and screw in a hollow bone, if you put the nail in this hollow wall, it will come out. Will it come out or no? Huh? Like that, if you put an implant in a hollow bone, it will be in your hands next day. You understand what I'm trying to tell you? Osteoporosis, a big menace, a silent killer, silent epidemic. You know about diabetes, you know about hypertension, you know about IHD. The moment you have this, you run to the hospital. You have osteoporosis, living with it for years, decades, not bothered. One fine day, you get a fragility fracture, then you rush to the doctor. Too late. Already your 1 month mortality is 30% by the time you come to a doctor. Then lifestyle problems. What are the lifestyle problems? All computer professionals, software professionals having neck pain, headache, knee pain, finger pain, wrist pain, shoulder pain, all types of pain. Repetitive stress injury. What we will do? Surgery. Surgery. For what? For what? Lifestyle problem. I had a patient, a young girl like you all. She came with the hand like this. Her fingers were like this. She came to me, sir, for the past 2 years, I am showing to all orthopedic surgeons, sir. They have nerve conduction study, MRI of the wrist, X-ray, lab test, uric acid, urea, all investigations done. Medicines given, everything, but still her hand is like this. A young girl. I was surprised. What she does, she's a young girl, and all investigations normal. Why she is not finding any relief? Then my sixth sense said, let me get back to clinical history. I asked her, you tell me about your lifestyle. Then she said, no sir, I'm a software engineer. That I understood. How you are going to type, God knows, your hand is like this. Then what do you do? I come home, sir. Then what do you do? I sleep, sir. Then what do you do? I see mobile, sir. How do you see mobile? What do you see on the mobile? See movies, sir. How? I lie down, sir, on the pillow, hold the mobile like this, and see the movie. You understood, youngsters who are sitting here? She was lying down on the bed with the pillow. She was seeing the movie like this for 3 hours, every day almost. What happened? She developed a hand like this. And the top orthopedic surgeons with all investigations could not diagnose. Then I told her, madam, your problem is with you, solution is also with you. From tomorrow, from today, you stop seeing mobile while you are sleeping in that position. She asked me, sir, is that the problem? Yes, that is the problem. She stopped. You'll not believe, she was all right within 1 week. She went back home happy. Nothing I used. Nothing. Nothing. Only 2 God-given ears. Use these ears. Right? You listen. That's all. The whole problem in life is we don't listen. Why you go to the family court, so many long queue for divorce. Go to Miraj, Sangli, go to the family court and see. All young graduates, young people like you are standing there for divorce. You know what is the reason for divorce? They don't listen. Misunderstanding, no understanding, misunderstanding. That boy says, I am hungry today. Then this girl says, this fellow comes, he has no better business to do. I am so tired. He is coming asking me to cook food. I don't want to live with such a person. This is our tolerance. We don't listen. We don't listen. That's why God has given 2 ears to listen, 2 eyes to see, observe more, listen more, talk less. Only 1 tongue God has given. But what we do? We talk more, listen less, and see less. We have to reverse that in the clinical examination also. And in geriatric, we just replace, fix, that's all. This is an example of a patient I'm giving. This is a case of fractured T12 vertebra. She got up from the chair, she broke the spine. Spot diagnosis, fragility fracture. That's all. Spine fracture is a huge fracture. Road traffic accident or fall from height is required. But here, she just got up from her sofa, she broke the spine. So, fragility fracture. She went to a major hospital. They didn't even ask, what are you, who are you, from which place. Straight away, MRI and X-ray. MRI, X-ray showed T12 fracture. In spite of MRI, X-ray showing T12 fracture, they made a diagnosis of L1 fracture. L1 fracture. Young graduates like you who joined the ER department made a diagnosis of L1 fracture, and they called the orthopedic surgeon on the phone at home. They said, sir, patient has come with L1 fracture. Okay, ask the patient to come for surgery next day. Vertebroplasty or surgical stabilization. Consultant is sitting at home. The MBBS doctor is seeing in this one. Patient is shell-shocked. Patient is shell-shocked that this doctor is telling me to put plate and screws in the back. Even they have not touched me also. Nina, 71 years old lady, her parent, her husband, all old people and daughters too, they are shell-shocked that in such a big hospital, they made a diagnosis of L1 fracture, actually it's T12 fracture, and asked for surgery. They came to me, and then what did I do? I did a comprehensive diagnosis of osteosarcopenia, fractured T12 vertebra. Then she had no neurological damage, and comorbidity she had 4: diabetes, osteoporosis, hypertension, and anxiety. Co-musculoskeletal problem 4. Then X-ray and MRI to confirm that already it was there. I did not ask for a DEXA scan because DEXA scan, you should know what it is. DEXA scan is used to diagnose osteoporosis because already there was vertebral fracture. And then test for sarcopenia could not be done. I implemented simple non-operative management. Patient walked away. A patient went by flight just last week to Prayagraj without me operating on the patient. Now, you look at that. You look at that, the report, what you people are going to give in future. You see that. If you look at that, you can see there what they have written. Lumbar, I can't read it from here. X-ray, LS spine, L1 fracture. Now you go back and see the image. See, where is it? Is T12 fracture. And with MRI they showing this, the doctor like you makes a diagnosis of L1 fracture. Okay? Right? L1 fracture. And see there, surgical vertebroplasty stabilization. You can see that I have marked it. Advised surgery. No diagnosis of osteoporosis, no diagnosis of sarcopenia, no diagnosis of diabetes, hypertension, nothing. Straight away surgical stabilization. Next day they will take the patient to OT. Put an implant and the patient's lifespan will be cut short. Don't do this. Whatever may be your training, if you don't use your eyes properly, if you don't see the report at least, then you are doomed forever. Vinay, 24 years old guy. When he was at the age of 20, he had low back pain. He went to a hospital, a major hospital, then they did a surgery on him, discectomy. 1 year later, recurrence of the back pain. He went to another major hospital, they did repeat discectomy. Third time, again after 1 year, one more at the age, by the time from 20 to 24 age, he had 3 spine surgeries done for what? For low back pain. And fourth time when they did surgery, he lost the will to live. He said, I'm going to commit suicide. Why? 3 major surgeries on my spine and my back pain is not gone. He came to me. Again, using the God-given ears, I heard his story. He was a software engineer. He got up at 7 o'clock, 8 o'clock in the morning. He used to drive 2 hours in Bangalore to reach his work, sitting for 10 to 12 hours in front of the computer. Then come home tired by 8 o'clock in the evening. Then he was a musician, so practice music and sleep at 12 o'clock or 1 o'clock in the night. This was his lifestyle. So this was a lifestyle backache. And he was in depression. Because of his sedentary habits, he had become obese and all his family was in Assam. So no support. So mentally cooked up, physically cooked up, you did MRI and you operated, you are operating 1, 2, 3, 4, 10, patient will die. That is what we are meant for. You are becoming a MBBS graduate, doctor, you are meant to silently kill the patient or you are here to save the patient. For what skills are nothing I did on him. Simple yoga, Surya Namaskar, physiotherapy, back stretching exercise, lifestyle modification. Now the patient plays drums, guitar for yo-yo sing. You know yo-yo sing? You don't know yo-yo sing? Here, yo-yo sing you don't know? No. Arey, he is the next gen or Zen Z musician here. He is not Mohammad Rafi Kishore Kumar, Mukesh. He is yo-yo sing, Honey Singh. Now they say yes. Honey Singh, yes. Yo-yo Singh you don't know. He is yo-yo Singh because he sings only yo-yo. So he is now a drummer and a guitarist there. One more lady. She had knee pain. They operated. What they said, next day you will walk. Patient went on to the wheelchair straight after the knee replacement surgery. Why? Because patient was not examined. Patient had rheumatoid arthritis, not osteoarthritis. And patient had OA hip, OA spine, OA ankle, everything. So they just replaced the hip, the knee. The hip problem remains. The patient was not able to stand up. So this is another example. So the modern realities are, images are better, mistakes can still be old-fashioned. CT, MRI should not replace clinical judgment. They should sharpen it. Please understand the meaning of the sentence. In today's practice, the key skill is not undergoing ordering advanced technology, but asking the correct clinical question and using imaging to answer it. Diagnostic, is there an occult fracture? Planning, what fragments exist? Deformity correction, golden rule. A perfect CI report cannot compensate for an unstable reduction, misled compartmental syndrome or a multi-rotated limb, mal-rotated limb. That means use CT scan and MRI to sharpen your skill, not to replace your clinical judgment. Fracture diagnosis, a modern stepwise framework. I told you, clinical first diagnosis. First, what is the mechanism of injury? Then do the examination and find out the red flags. What are the red flags? You can see the red flags, the bleeding, all those disorders are the red flags. You have to be alert. Compartmental syndrome, all that, that means it is a serious problem. You have to address that. After a good clinical examination, the modern diagnostic flow chart. This is what you are supposed to do. First, take the X-ray. If X-ray is negative, suspicion is high, order an MRI. If intra-articular, then go for CT with 3D. If soft tissue ligament injury, go for MRI. Polytrauma, CT trauma protocol. So this is the imaging toolbox in 2026. For all this, you should know X-ray is the starting point, even today. For cheap baseline alignment, serial follow-up for healing, essential for deformity correction. After X-ray, it is CT 3D, which is best suited for articular fractures, occult fractures, all that. After plain X-ray, CT scan, then comes MRI. MRI is best suited for what? For occult fracture and soft tissue injuries. Remember all this. And ultrasound in orthopedics. It will help you diagnose the effusion and pediatric occult fracture. And then low dose biplanar imaging, long standing X-rays like this helps you make the deformity analysis. Then intraoperative imaging, use C-arm, O-arm, all that to improve your technical skills in the operation theatre. So if you look at this, right imaging for the right question, high yield table, it is first choice is X-ray, then CT, then MRI, then ultrasound. It is like this, in this order. Don't start with an MRI first, okay? And then modern fracture classification. You should know the fracture classification for what? To clinically prioritize and guide the management. You should know, by knowing the classifications, you should be able to do the treatment. Deformity correction, you have to do the angular deformity, rotational deformity, length, everything has to be attended to. And then do a 3D planning and printing, then correct the deformity. Fixation choice, you got plates, locking plates, IM nail, external fixator, hybrid strategies. You got hexapod frames, which are useful for computer assisted correction. So you should use all these gadgets once you make a diagnosis. Modern adjuncts like navigation, patient specific instrumentation called PSI, guides, robotic AI should help the surgeon in making the correct cuts and correct placements. Okay, patient specific instrumentation. Nowadays we design the implants for the patient so that the anatomical will be there. AI realistic expectation, it is useful for triage in the emergency room, fracture detection assist, segmentation and planning aids. Not a substitute for surgical judgment. AI, you should know the limitation of AI. So quick recap, orthopedics now. X-ray starts the story, MRI, CT finishes it if you ask the right question. CT is best suited for complex cortical, intra-articular anatomy and fragment mapping. MRI is best suited for occult fracture, marrow edema, soft tissue injuries. Deformity correction requires the long X-rays and you have to apply the CORA concept. And then plates, nails, all should be used properly with proper precision. So today's problems are geriatric problems, lifestyle problems. These are two problems. Life expectancy has gone up, so we are living longer nowadays. So more problems of geriatrics. If you look at the lifestyle problem, see the lifestyle problems like workers, musculoskeletal problems, student musculoskeletal problems. These are due to repeated activities. They cannot be handled by AI. They cannot be handled by robotics. And there are so many multiple challenges. What are the 10 challenges of lifestyle problems? It is sedentary lifestyle, lack of exercise, long traveling hours, improper and irregular diets, extreme work pressure, long working hours, work and peer pressure, crumbling family life, they're all nuclear families, habits and stress. A patient has so many problems when they come to you with lifestyle. You cannot treat this patient by surgery, AI or robotics. Then geriatric, there are 10 peculiar challenges a geriatric patient has. What are those? Comorbidities. Patient has multiple comorbidities, co-musculoskeletal problems. A patient with neck pain will have back pain, heel pain, shoulder pain, everything. Co-physical problem, lack of hearing, seeing, all that. Then co-mental issues like depression, anxiety, co-emotional, co-social, co-family problems, co-financial. Geriatric patients don't have money. All the money is taken by the children. You understand? All the money of your parents, children have taken away. Good schools, big colleges, parents, poor parents, they give everything what they have. And when it comes to their life, in the old age, they are left with no money, no children, both. That is the life of senior citizens in this country. So, finance problems, agency problem, government is not interested in old people, insurance is not interested in old people, and then so much of stress. Okay? And then I told you about these multiple co-musculoskeletal problems. And all this, you cannot replace all the joints in the body, can you? A senior citizen has got knee pain, hip pain, neck pain, back pain, shoulder pain. So can you do joint replacements for all? Can you present a picture like this? No. And then this is the latest challenge, sarcopenia, osteoporosis, osteosarcopenia. I think you should give more thesis on this, sir, nowadays, because this is the happening thing. So what I'm trying to tell is modern orthopedic patients suffer as a whole. Physical, mental problems, emotional problems, social problems. So we do localized treatment for generalized problem, not successful. So what are the treatment methods now we are having? Earlier it was drugs, physiotherapy, surgery. Now we have got AI, cloud computing, big data, 5G, robots, VRs, IoTs, others to treat these kind of problems. Molecular and regenerative orthopedics, stem cell therapies, right? We do all that now. Technology-driven digital orthopedics. What defines digital orthopedics? AI-assisted imaging, robotic and navigated surgery, predictive analysis, smart implants, telerehabilitation. Strength, precision is the strength. Limitation, protocol-driven, not person-driven. Digital orthopedics. The rise of AI, strength of AI, rapid imaging interpretation, predictive analysis, surgical planning, standardization, limitation, data dependent, lacks emotional intelligence. It doesn't connect with the patient. It is a machine, robo. Okay, so they cannot understand the patient's values, fears, or goals. So they treat pattern, not persons. So AI answers what is likely, but not what is right. So this is AI. Robotics, same again, enhanced precision and reproducibility, rest all zero. So limitations of digital orthopedics, AI driven, mainly part centric, only knee, back, like that. The limitations of navigation, again part centric. Then limitation in robotics, again part centric. So you are not addressing the patient at all. We are addressing the parts. That is why Ebenezer's holistic regime, a human-centric paradigm, which treats the patient as a whole. Treat the patient, not the pathology. Integrate body, mind, and soul. Prioritize function, dignity, and interdependence. This regime covers what does recovery mean to the patient, what level of function is meaningful, how do fear, belief, and motivation should be handled. So, limitations of technology, I told you. Only model despite technological advancement, global orthopedic faces, rising revision rates. There is no pain after surgery. So, technology is not helping the patients. So, Ebenezer's human-centric approach is built on the principle that orthopedic problems are not skeletal. They are biological, mechanical, psychological, and social simultaneously. That is the core philosophy of Ebenezer's holistic regime. It is not part-centric, it is person-centric. This is a 14 structured approach which I have created. I don't have time to go through all this, but this is a 14 structured approach through which I approach my patient. I have given you one or two examples. So after the past and present, what will be the future trends? The changing global landscape of orthopedics, explosive subspecialization. We go from specialization, subspecialization, micro-subspecialization. For example, tomorrow there may be a specialization like this: right nostril specialist, left nostril specialist, right hand specialist, left hand specialist. You understand? Micro-specialization are creeping in. Industry-driven, image-first decision-making. So these are all the reduced doctor-patient interface. So global orthopedics is undergoing a profound transformation. There will be a big shift in the future from seeing the fracture to understanding the bone. In future, you are not going to see the fracture through X-rays, MRI. You try to understand the bone through this AI. AI will tell you whether there are better decisions. Today we diagnose fractures. Tomorrow we predict failure, simulate outcomes, and prevent deformity before it becomes symptomatic. This is the future. Fracture diagnosis at the future, intelligence augmented, not image dependent. AI will be the first reader, not you. AI will read first, then radiologist will read. Okay? Not the final judge. We should know that AI is the first reader, not the final judge. The final judge is you. You are the final judge. You should be able to interpret AI. Future fracture diagnosis will follow this 3-layer model. Future imaging will be ultra-low dose CT, functional MRI, dynamic imaging, real-time bedside scanning. You can see bedside scanning nowadays, and it will be more diagnosis friendly. So evolution of global orthopedics, mechanical era, implant era, technology era, I have told you all about this. So Ebenezer's holistic orthopedic, the core philosophy is time resistant. At its heart, it is built on so many immutable truths that patient is more than a bone or joint. Healing is biological, mechanical, and psychological. So will it stand the test of time in future? Of course, yes. Because in future, you are going to get more lifestyle problems, more geriatric problems. And that can be handled with a kind heart, not with all this. So future orthopedic surgeon should know about technology, AI robotics, communication and empathy too, geriatric and chronic care principles, ethics, very important, shared decision making and end of life care. The surgeon should evolve from a mobility physician to a life quality steward. So the future, I am talking about orthopedics, but this applies to all branches of medicine. You have to think holistically, use AI judiciously, operate precisely, and rehabilitate compassionately, take lifelong responsibility for the outcomes. So that goes to the future model is integration and not competition. Okay, so quick recap, future focused, fracture diagnosis will become predictive, continuous and AI augmented. Deformity correction will move from static geometry to dynamic function. Digital twins and simulations will precede real surgery. Robots will enhance the precision, not judgment. Biology and regeneration will increasingly replace mechanical correction. The surgeon's role evolves from operator to decision architect. Why evolution matters? Past, we reacted to fractures. Present, we define and map the fractures. Future, we predict, simulate, and then prevent fractures. So fracture diagnosis in the past, I told it was X-ray, clinical examination. In the present, it is CT, MRI, and digital. And in future, it is going to be more of digital orthopedics and how we have evolved. So conceptual evolution is from X-ray, CT to AI. That's how we have evolved. So lessons learned from this 3 years, clinical examination will never become obsolete. Print this in your mind. If you think that, tomorrow you can graduate and work, practice with robots, AI, please drop that idea. No robo AI can replace your clinical examination. Even 100 years from now, you require clinical knowledge. Then only you will be able to control your AI. So these are the pitfalls for, and pearls and the relevance across 3 areas. Orthopedic surgeons of the past, present, and future. In the past era, I told clinical orthopedics. In the present area, it is CT. In the future area, it is robotics, AI. So these are the comparisons, the past, present, and future. You'll find that the past will guide the present and the present will guide the future. That's what the digital orthopedics and the Ebenezer's regime also, if you compare, now the Ebenezer's regime will stand the test of time. So digital, molecular, regenerative orthopedics, technology precision, best, but litigation is high, mistrust is high, physical violence on doctors is high, commercialization is high, service taken over by sales, many doctors are succumbing to extreme stress, human care is more than health care, we fail to understand. This simple Jappi therapy, what I call, is more powerful than your robotics, than your AI. Simple, hug the patient, talk to the patient, listen to the patient, touch the patient, and then hug the patient. Then it works like miracle. You will never be sued. No patient will sue a doctor who will touch, hug, listen. A doctor gets sued when he uses more of AI, robots without touching. You are inviting trouble. It is in your hands, right? So what is Mother Teresa and Amma did? Nothing. Just embrace patient. That's all, people. That's all. She got Bharat Ratna. She got Nobel Peace Prize. Did you ever dream of getting it? So one line conclusion is, technology may define how we treat bones, but Ebenezer's holistic author defines how real human beings are. If you don't talk to the patient, if you don't listen to the patient, if you don't touch the patient, you don't hug the patient, robots will start doing it. In future, when you go, robots will come and hug you. So be careful. That's a human skill. You use it. Don't allow the robots to use it. This is one simple case. Before I end, I want to tell you this case. Just 2 days before this lady came to me, she had that 4-foot pain. You can see that 4-foot pain, what she was pointing there. And for 6 years, she was struggling with this pain. She had gone to multiple doctors. MRI was done for the foot, normal. X-rays, they said there was a fracture, but I didn't see any fracture. Then again, the same logic. I used the ears. I asked her, what are you? She said, I'm a software engineer. Other than that, what are you? She said, I'm a belly dancer. Belly dancer. You know how a belly dancer dances? On the 4-foot, right? 4-foot. She dances on the 4-foot. Practice and dance, performance for the past 10-15 years. Naturally, she gets the 4-foot pain. Simple diagnosis. It is a sesamoiditis. No MRI required, nothing required. I asked her to practice with care. Her problem is sorted out. So what will never change? Pain will not change. Soft tissue healing will not change. Biology will not change. Strong indication is worse than imperfect execution. Ethics and responsibility will not change. The road, this was the art of orthopedics. Hope you have understood something. Have you? Have you? Loudly. Still loud. Wow. Now we apply the same logic to other branch of medicine also. Like medicine, OBG, all that. Past, present, future. Road. Now you know the road. What is a road map? What is a road ramp? There are two roads. To be successful and thriving career, you take one road. To become fulfilling and everlasting life, you take. You are all young graduates like this, from art of orthopedics to art of living. You have chosen the medical profession. This part of the oration is for the entire student community here, not for those who are interested in orthopedics. Why is this needed? You will discover the answer yourself soon. What it was meant to be a doctor then, driven by service, principles, humanity. Best example, Dr. B.C. Roy. What is what is being doctor now? PG struggle, unemployment, long working hours, burnout, violence, legal issues. These are the problems our youngsters. What will be the future of doctors? Only money. Service has gone, right? Everyone here who are sitting wants to be rich, famous, powerful, successful, and immortal. Yes or no? Yes or no? You want to become rich, famous, powerful, successful. Yes or no? Right. So what is success according to you? Money, fame, riches, bank balance, power, position, or happiness, satisfaction, contentment, making a difference? Do you want to lead a successful life or a fulfilling life? Leave a legacy behind. I always say, I have no fear, a person who lives a fulfilling life. So it depends on your choices, what choices you make in life. When you are undergraduate, you are thinking about post-graduation. You want to take post-graduation, and once you conquer that post-graduation, you are relieved. Then you will feel, I have to finish the post-graduation, I have to become a graduation. Then once you graduate, then you start thinking what I should do after post-graduation. Fellowships, training, abroad, all that. And then what you do? Graduation is a big thing for you. Then for a UG, getting into PG. For a PG, whether diploma or masters or DNB, and these are the choices. Conventional choice: graduation, post-graduation, training, fellowship, private practice or job, then teaching post, going abroad, marrying. Right? Unconventional choice. These are conventional choices which all make. Unconventional choice: graduation, then marriage, which happened with me. No post. I got first married after MBBS. How many have got the guts to marry now? Tell me. After MBBS, how many will marry? Do you have the guts? That was the unconventional path. Family, my son was born, then I did PG, then career choice, then training, then fellowship. So after UG, these were the challenges. Now conventional path chosen by many: PG, UG, PG, training or no training, practice, 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 till you go to the grave. Practice, that's all. Earn plenty of money and then reach the dead end. You reach the dead end. Afterwards, you don't know what to do. Okay? So you will get name, fame, rich, success, title, car, site, farmhouse, bank balance, holidays. Then you will not know what to do next, because there is no happiness inside. No happiness, gone. You have got everything but nothing. So to have that good life, you should have core belief system, what we call principle based. It is not money, power, family, ego, position. Core values. I would like to share with you my story where my mother laid my foundation. Life foundations were laid by my mother. When I passed the 12th standard with 17th rank to the state, she threw my marks card into the dustbin. She said, this is only academics. Don't feel very proud that you are going to get an MBBS seat. It has no value. It can only get you a seat, but it cannot make you a successful human being. She told me the story of Mother Teresa. She told me the story of Ida Scudder, who started Christian Medical College, Vellore. She told, you pass the Life University. Life University is different from State University. I was wondering what my mother is telling. I have topped the state. I am going to get a government seat. My mother should distribute the sweets, throw a party. But she is telling, she threw my marks card into a dustbin, and she is telling, you should excel in Life University, not in University of Academics. I thought my mother is abnormal. Abnormal. I went to my father. Everybody is asking, I have topped, got a rank. They are asking for a party. Oh, they are asking for a party. Yes. So give me some money. Mother is not giving. Okay. My father gave me 5 rupees. My father gave me 5 rupees to give party to the entire college. I said, how I can give part in 5 rupees? Oh, you cannot give part in 5 rupees. I said, no, then give it back. So, my core principles changed because of my mother. I went into academics, books, presentation, research, newer treatment methodology, professional bodies, social life, academic publications, community education, then practice, then extracurricular activities, then fulfillment and awards. My priority was teaching for MBBS and PG students. I was extremely popular, teacher. Students used to flock to me. There was so much of jealousy on me. All professors used to be jealous of me. Why? Because students used to crowd me wherever I go. And then I wrote 200 books in orthopedics, single author. Single author. 2 Guinness World Records in book writing. 2 Guinness World Record in book writing. I have a book, MBBS students, since 22 years. I have a book for postgraduate students since 32 years. So many tell me, sir, we have read your book and passed. I don't know how many GMs in Miraj know about my book. I have read about my book. Or they are only reading notes in the, social media. I have no idea. Third priority was academics. Over 400 presentations I have done all over the world. From America to Bangladesh. I have done presentations. Okay. 3 times international TEDx speaker. No orthopedic surgeon in India. Fourth priority, did my PhD in yoga and found out through the research, simple non-orthoplastic treatment for knitting, and this was taken up by AAOS guideline for treatment. I alone know 185 countries follow the guidelines laid down by my research. Fifth priority, social service. My mother had asked me to travel the service-based road to find happiness, success, contentment and fulfillment over 500 orthopedic and surgical camps till date. I went to Nepal during the earthquake in 2015. I was not sure whether I'll come back alive. The whole Nepal was shaking. I did the camps there, surgeries there. See, look at the images there, how it was. And so many hillside camps I did, came out alive. Then I revived 3 major hospitals in Bangalore. One is Sir C.V. Raman General Hospital, which was on the verge of closure. Then they made me the medical superintendent. I converted that into a national award-winning hospital within 1 year's time. 2 sick hospitals, CSI hospitals in Bangalore and Chikbalapura, both 100 years old, verge of closure, converted them into a successful hospital. Then came my 274 days war against COVID-19 as a government officer, nodal officer, with just 1 mask. That's all. No vaccination, no medicine, nothing. I worked for 274 days. I worked in the railway station for 107 days. BBMP, war zones, 167 days. And I did not contract the infection. My yoga teacher was telling, because you do yoga, that's why you didn't contract. But so many yoga people had died with COVID. Okay? Right. See, these were the railway station. I used to monitor all the patients, passengers coming from different parts of the country. And this was the slum work, what I did. And then established professional bodies. That was my 6th priority in life. I became the vice president of the Indian Orthopedic Association, president of the Neurospinal Surgeons Association, founded the Geriatric Orthopedic Society of India, and which is doing wonders now. And my 7th priority was the new treatment methods called holistic orthopedics, which I told you now. And then a new subspecialty like geriatric subspecialty. And I play yoga and I play cricket. I was the captain of my school. See there, I'm bowling. Is it not a good action? Look at that image, I'm bowling there. Where are the young boys here? Is that not a good action, man? Are? Have you gone to sleep? Are you sleeping? It's a good action, no? You know what is my age? 66. Ninth priority, music band. I got my own music band called Inspiration. My son, my wife, my daughter-in-law, my daughter, they have all sung for movies, and I sing even today. There is a Smule app of our classmates, and I have sung so far in that Smule app from COVID time to here in 5 years, I have sung 3,950 songs. Now you ask me to sing any song, in Bollywood I'll sing. Okay? Right. Then last priority was my practice. I got 3 hospitals in Bangalore. So I am not a mean practitioner. You may be thinking this gentleman only writes books, creates Guinness World Records, and he doesn't know anything. Nothing. You come and see my hospital. There are 3. Okay? Then 8 Guinness World Records. Okay? Can you believe that? So what did I gain? This is the unconventional path. Practice, 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 practice. Conventional path. Unconventional path. It got me 400 international, national and state awards. Top 2 Karnataka State Awards, 2 Professor Emeritus Title Awards, Honorary Doctorate, Padma Shri, and I shared Padma Shri with Sri Sri Ravi Shankar, Dhirubhai Ambani, Rajinikanth, Raj Mouli, Sania Mirza, Saina Nehwal, Udit Narayan, Priyanka Chopra. With this ordinary doctor like me was standing with these guys. 72 years of Padma Awards history. Since 1954, Constitution of India has established Padma Award, 1.5 billion now. It works out, the maximum award per year is only 120. It works out to see the percentage there, 0.00000 percentage of getting an award, Padma Award. Total awards till now is around 5,500, I have not updated it. It is 5,511 out of 1.5 billion people in India. Only 5,511 people have got Padma Awards. You can imagine. Now come to the doctors. 18 lakh doctors in the country. Only 330 have got Padma Awards. Karnataka, 1.3 lakh. Now 17. Now including madams and one more it will become 19 now. So only that many. What is our population? 1.3 lakhs. So 2 national awards. Both BC Roy and Silver Jubilee and Padma Shri. Hardly anybody. Okay? Right. So this is the graphical description. You can see where we are. In the Elite Zero company. I am in the Elite Zero company. Right? So, both in the same year, I went to Pranab Mukherjee. The suits are changed. Huh? See there. See a white suit and black suit. Don't say that I put the film and showing 2 awards. You can see there. My suit almost same. But you see Pranab is wearing white. Here, both one single calendar year. Single calendar year. So, these are the other coveted awards. And you know what is the BC Roy Award, which is the highest award in the field of medicine in India? Out of 18 lakh doctors in the country, only 91 have won it. At least Padma, there are 330 people. Here, only 91. And in Karnataka, only 5. So, that means it is still rarer than Padma Awards. BC Roy National Award. Now, it is now removed. I got both. Okay? So, and these are some of the lesser known awards. And I was very impressed with this award, what was given to me by Governor of Punjab. They called me Hypocrites of India. Oh, that was a flattery for me. Okay? Then they said, I have gone beyond Padma Awards. They called me Padma Mahan. Government of Puducherry. And then I am a Karnataka, released my portrait, book, everything. Then I am having 6 times Lifetime Achievement Award. You know what is Lifetime Achievement Award? That means your life is over. If they give you Lifetime Achievement Award, that means your life is over. Stop working, sit at home. But I got 6 of those and they have conferred me a title called Legend. So, the time which I took, now for you, the question is, do you want to scale the summit of your professional career or the summit of life? Both are different. Okay? Now, do you want to be a part of the elite 330 doctors out of the 18 lakh doctors? See, there are 4 people in this conference. See here, myself, Dr. Ravindra, Dr. Smita, and Dr. Vijay Lakshmi. 4 Padma awardees are there in this conference. Such lucky students. Lucky students. There are only 330 in India. You have got 4. Will you be inspired by them? Will you do what Ravindra sir did? Go to the tribal area? Will you do what Vijay Lakshmi madam did? Or will you establish big nursing homes and earn money and die one day with people not knowing you only? You were born and dead, gone. If you want to do practice and still get a Padma award, I am an example. You cannot follow what Ravindra madam and Smita madam did. But you can follow me. Why? Because I am a conventional orthopedic surgeon with practice. Okay? Still having my hospital and still I can get a Padma Award means you also can do it. Without compromising on your, see, Padma Award is means what? They are like a saint. They are like saint. They don't have any aspiration, vairagya. They have lost everything. They just want to, no. You can be like me and get award. You can sing and get award. You can play and get award. You can, write books and get award. So that means I am an example for you that if I can do, so you can do. So next time when I come, will there be some Padma awardees from Government Medical College, Miraj? Yes or no? Or you are not interested? So what, sir? Who wants Padma Award? I want money. I want BMW, Mercedes. Remember, if you get Padma Award, you will be in that 5,500 out of 140 crore Indians. So, do you want to be a part of this Allied 5511? Yes, answer is yes. Then you have to change the approach. You should become a national health impactor. You should learn public health pioneer, medical education leader, social medicine contributor, institution builder, not just nursing home builder. You understand? Okay? Why you need to be there? Why you need to get Padma Award? Because there is only one life for you. ये जिंदगी नहीं मिलेगी दोबारा. एक ही तो जिंदगी है. कुछ करो यार जिंदगी में. कीड़े मकोड़े तरह मत मर जाओ. Don't die like insects. Become something in this world because only once you will live. Unconventional choice, value-based life will lead you to immortality. This was my journey. And finally, you'll come face to face with God. That is the final vivavos. So many vivavos you face as a doctor. But very difficult vivavos you will face last when you're about to enter heaven. God is standing there waiting for you. Then you'll ask, well, welcome to heaven, come. What did you do with my life? He will ask. I gave you life. What did you do? Sir, I became a successful doctor. Next, I earned a lot of money, sir. Next, I was a very popular, my children were very intelligent, they got. Next, he will ask, sir, I went to foreign so many times. Next. Then what next, you will ask. Then what next I should do, sir, you will ask. He will say, you are my child. You are like me. I had sent you to the world to make a difference. What did you do? Nothing. You just earned money, fame, name, wealth, etc. And you come back to me empty-handed. Everything you have left back in the world. What are you carrying? Nothing. So you will fail 100% in that 5 hours. If you don't want to fail, now you make the decision today. So did I succeed in the University of Life? Did I? Did I fulfill my mother's challenge to me? It is for you all to decide. My mother told me this. You should excel in the University of Life. Do you think I excelled? Are जोर से बोल? Okay. So, which way you want to take in the life? The wide successful way, the narrow way. That's the life of fulfillment. That is a biblical parable of Jesus Christ who says, majority people will walk on the highway. Only few people will walk narrow way. So you decide whether you want to walk there or here. Thank you, GMC, Miraj, for the invite. It was a pleasure being here. Okay, I am getting a standing ovation. Where is my boy? Let him take a photo of me getting standing ovation here. Where is that guy gone? I given. Take the photo. These are some of the memorable events of my life, man. You are not taking? They will sit down now. Take quickly. Thank you. Thank you. So please remember this. I have not shown all this to showcase myself. No. I want you to use me as an example to excel in your life. There was no boasting here. There was trying to inspire you people. You inspire. Nowadays, youngsters need this. They need inspiration. So I was trying to inspire through my life. Instead of telling a plain lecture, I was giving my example so that now it is 100% practical. It is not a theory. It is not a lecture. It is a life lived. Right? So now Vijay Lakshmi Madam will further enlighten you, and you will get a double dose of Padma Awards now. Thank you.
Thank you, sir. Now I request Chairperson Dr. Vikas Rokde, sir, to say a few words about the session.
Hello. After this very much inspiring lecture by our Ebenezer sir, who is Padma Shri, he inspired all our undergraduates and postgraduate students. I take this opportunity to appeal my undergraduate and all postgraduate students to come in the wards and don't forget the clinical examination as he emphasized. And you should be a good doctor and you will be successful in your life. Thank you. Thank you, organizers, for giving me this opportunity to chair the session.
Now, I request our chairperson, Dr. Vikas Rokde sir, to felicitate Dr. John Ebenezer sir with the token of appreciation. Now I request Kedar and Abhijit to felicitate Dr. Vikas Rokde sir for this session.
Thank you, sir. On behalf of entire MEDICIENCIA team, I sincerely thank you for that inspiring and thought-provoking session. Today, you beautifully reminded us that the true art of medicine lies in balancing scientific precision with compassion and holistic care. Your words have not only enriched our knowledge but also strengthened our perspective as a future healers. It has been an absolute honor to learn from you, sir. Thank you for your time, your wisdom, and your invaluable guidance. We are truly grateful and blessed that you came here. Thank you, sir.
Now, I request our MS, Dr. Rupesh Kumar Shinde sir, to felicitate Dr. Vijay Lakshmi Deshmane ma'am. It is our immense honor to welcome Dr. Vijay Lakshmi Deshmane ma'am, Padma Shri Awadi, and a distinguished surgical oncologist known for her remarkable contributions to women health. Now I request our organizing secretaries Pranav Kanap and Rachana Salvi to felicitate our MS Dr. Rupesh Kumar Shinde sir. Now I request Nilesh Pakre and Shrushti Jadhav, our organizing secretaries, to felicitate Dr. Anand Patil sir, Professor of Pharmacology from D.Y. Patil Medical College, Navi Mumbai.
Hello, hello.
Now I request chairperson for the next session, Dr. Shrikant Ahankari sir and Dr. Prashant Dorkar sir to come on the stage for the session.
It is my great honor and privilege to introduce our esteemed speaker for this session, Dr. Vijayalakshmi Deshmane ma'am.
Dr. Deshmane is a distinguished surgical oncology expert who has dedicated more than 3 decades of her life to oncology at the prestigious Kidwai Memorial Institute of Oncology, Bengaluru. Beginning her career as a resident in surgical oncology in 1984, she rose through various academic positions to become professor and head of the Department of Surgical Oncology, and later served as the director in charge of the institute. Throughout her illustrious career, she has made significant contribution to the patient care, academic teaching, and cancer research, particularly in the field of breast cancer.
As a principal investigator, she has been actively involved in a global breast cancer project and has played an important role in promoting breast cancer awareness and community education. She has also contributed extensively to academic and professional bodies, having been appointed by the Medical Council of India as an inspector of recognition of MCS surgical oncology programs and serving as the past president of the Karnataka Cancer Society. She currently serves as a chairperson of the board of governance of IIIT Kottayam and IIIT DM Kurnool.
Dr. Deshmane's exceptional service to medicine and society has been recognized with numerous prestigious honors, including the Padma Shri Award in 2025, one of the highest civilian awards of India. Her other recognitions includes the Rajyostava Award by the Government of Karnataka, Sir M. Vishveshwaraya Science Award, Nada Pramukh Kempegowda Award, Devi Award by the Indian Express, Shri Mahavir Ahimsa Award, Swarna Kandiga Award, recognition under World of Women, recognizing excellence by the Hindu, gold medal from the International Study Circle, and being honored as the Woman of the Year by the American Biographical Institute. She has also been conferred the degree of Doctor of Science by Karnataka State Women's University.
Beyond her professional achievements, she continues her commitment to social service as the president of Abalashrama, a non-profit shelter home dedicated to the education and empowerment of the young girls. Today, we are truly honored to have her amongst us to share her valuable insight on the topic breast cancer and community education. I now request Dr. Vijayalakshmi Deshmane ma'am to kindly take over the session.
and down movement. This up and down. Right and left. This is forward. Yeah. Do comfortably, then you will get it.
Yeah, slides to start now.
Yeah, you got it. Forward and backward, huh? This?
This forward, this back.
Yeah, fine. This is okay?
Forward.
Yeah. Yeah. Sir, namaste. Namaste. I thank the organizers for the kind invitation. I thank Dean sir. I thank the faculty and dear students. Breast cancer and community education. This is my topic. Breast cancer is very, very common. Breast cancer is curable. Breast cancer is lifestyle disorder. It is highly expensive. So better we have this community education. Community education is an expert coming to the community and explaining the things in simple terms. That's what I have done. Maybe you can copy this. You know, educate the society regarding breast cancer, which is very, very common. This is for that. This reason I have made this community education. My story to give you in a simple way. I have given my biography books to the Dean sir. It will be available in the library, I think. You can go through that. It is you know, thanking the people who helped us all along till Padma Award. That is what is my biography all about. To give you my story in simple, a very, very short way, I have born in a slum in Kalburgi. Kalburgi is like Miraj, I felt. It is also small town. Kalburgi is border of Maharashtra. My father was a freedom fighter. So he asked me to come the surgeon when I was a child. So I'm here in front of you all. My mother used to sell the fruits and vegetables on the roadside. And myself, my brother Ajay, both of us, we used to help mother to sell the fruits and vegetables on the roadside at Kalburgi. Ours is a family with 8 children, 5 sisters and 1 brother. My brother Ajay became the famous advocate in Kalburgi. And my 5 sisters have done PhDs and they are working in different universities. My mother has done all this with her selling the fruits and vegetables on the roadside. Our family film is produced. The film name is Matangi Divitiye, and we have received the Falke Award for the film. I have built Krishna Mandir with my pension amount at Bangalore. This is the first charity from our family. Thank you all. Coming to the breast topic, maybe you can go to the society and give the awareness, which is very much required. Sir Padma Shri awardee, Previous speaker, he has made my life very, very easy because he has given you all the life requirements, whatever is required for the life, for the living. Uh, we will understand what is breast cancer in a simple way so that you will be able to explain to the other people. So early detection is very, very important, and community education is very important. We cannot afford to screen the patients in our thickly populated country. Maybe education like this is going to help quite a lot. So coming to the cancer facts and early detection of the breast cancer. Cancer is just abnormal growth. You can tell that to the ordinary people. That is all. We cannot talk more about that and confuse the people. And breast cancer, stage 1 disease. Where disease is stage 1 disease, where a lump is confined only to the breast. So if disease is confined only to the breast, we will be able to think of doing the breast preservative surgery. So that is the idea behind the community education. So stage 2 disease is where disease spreads to the axilla. Axillary lymph nodes are involved. Again, stage 1 and 2 both are early disease, both and operable disease. And if we can get and detect the early stage, stage 1 and 2, stage 1 is disease confined to the breast, lump is confined only to the breast, stage 2 where the lymph nodes are involved. So stage 1 and 2 both are operable diseases. Down now. I can manage. Yeah, I can manage. Stage 3 breast cancer is, yeah, no. Stage 3 is whole breast is replaced by the tumor. So majority of the patients we get in India in stage 3. So 70 to 80% of the patients, they present to us in stage 3 disease. This is the picture to show you the mastectomy, where whole breast is removed. This is the picture just to show you the bilateral entity where both the breasts are involved, especially the young lady. She came from Raichur. So just to show that there is something called bilateral entity, and young patients will have very aggressive disease. Whatever treatment we do, nothing helps them as such. So this community education, our aim is to detect stage 1 and 2 disease if possible. This is supposed to improve the survival of the patient. These are the tests we do for the fitness of the surgeries. Fine needle aspiration cytology of the primary and secondary. This has revolutionized the treatment of breast cancer. When I joined Kidway Hospital 40 years back, even the gynecologist used to come in stage 4 disease. That was the scenario. Now things have improved so much. Sons and daughters, they are prepared to spend on the mother treatment. So, and this fine needle aspiration cytology has revolutionized the treatment of breast cancer. If we can do the FNAC, fine needle aspiration cytology of the primary and the secondary if possible, and we will be able to give the diagnosis very next day to the patient, and we will be able to plan the treatment for that given patient. This is the standard treatment available till today for the breast cancer patient. Number one is surgery, number two chemotherapy and radiotherapy and hormone therapy. Hormone therapy has revolutionized the treatment of breast cancer, especially in the elderly age group patients. This is the picture to show that hair loss is possible with the chemotherapy, but it is a reversible phenomena. Breast cancer is very, very common. It is a Western disease, but now it has become our disease. So we have to do work like this, community education. It's very, very important. During pregnancy, a breast cancer diagnosis will be delayed and it carries the poor prognosis. So coming to the community education as such, there is nothing to control or prevent the disease. Only early detection is possible through such programs. Thank you to the organizers. They gave me topic whatever I wanted, then themselves asking me to talk on particular topic. Thank you so much. As of today, there is no promising preventing tools available for the breast cancer. We will look into one important aspect about breast cancer is it's a chronic disease. To become 1 centimeter lesion, it takes 10 years. And God has placed breast superficial. We will be able to detect the breast cancer very easily. Coming to the screening. And before that, we will look into the high-risk group. I come under high-risk group. I lost my mother with the ovarian malignancy. 2 years back, I lost my younger sister with the brain deposits. So people, affected families should take the interest for this community education. This is how abroad people started working on the familial breast cancer abroad, because it was a Western disease. Now it is our disease. We have to take the interest. Coming to the high-risk group, early menarche is one. And again, high-risk group is nulliparity, where there are no issues. Full-term delivery happening only after 30 years. We are so ambitious in life that first delivery occurs because parents, they want the children to settle in life. So usually first full time delivery happens only after 30 years. So Dr. Kalam sir, he used to tell that developed nation will have all the developments, and this is development also. So high risk group again, late menopause. Late menopause occurs in the unmarried status, postmenopausal, late menopause after 55 years. And high risk group again, previous breast cancer. Previous breast cancer, maybe recurrence will occur in the same breast or the opposite breast. So this again high risk group. High risk group again, family history of breast cancer in the first degree relatives, aunt, grandmother, daughter, sisters, cousin sisters, all these people will become the first degree relatives. And radiation exposure, with all this ego, we will, all big leaders will declare the war, and because of bombardment, whatever is happening in the Ukraine now, all this radiation exposure occurs. We will go to the breast cancer symptoms, very, very important. As sir has told, earlier that clinical examination is very, very important. That is very much true in the breast cancer also. So main symptom is lump in the breast. So luckiest portion is 80% of the breast cancers are non-cancerous. So this is the picture to show that benign breast lump. This is the picture to show that the breast is placed at lower level with the lump than the other breast. And breast cancer symptoms, number one is breast lump in the breast, and if untreated, the ulcer formation happens and there will be breast enlargement, skin changes do occur, that is PD orange appearance, and axillary swellings, and retracted nipple also is important symptom. Nipple discharge again a symptom. If the nipple discharge is serosanguineous watery discharge, then we can do the small surgery. Obstructed duct can be taken out. If it is a blood discharge from the elderly woman, one has to rule out the malignancy. Clinical breast examination, very, very important. Hard lump, for my examination, hard lump in the breast we will be getting. Nipple discharge without other lump, and nipple retraction, palpable axillary nodes, and skin changes like PD orange appearance. Triple tests are very, very important to make the diagnosis. One is clinical examination, fine needle aspiration cytology, and mammography. If we cannot come to a conclusion, especially in the patient with family history, we go for the surgical biopsy. Fine needle aspiration cytology, it is a simple procedure, quick, traumatic, and cost effective. If we can do the FNAC today, definitely the diagnosis will be available by next day morning. And then we will be able to talk to the patient and patient relatives what the lump is, whether it is a benign or malignant lump. So mammography is just non-palpable lump can be detected by means of mammography. Early detection methods are screening mammography, breast self-examination, and clinical breast examination. Clinical breast examination is very, very important. Breast self-examination we can do. That is again important. Sitting at home we can do, we can examine ourselves. Young ladies, they can plan the breast self-examination 2 or 3 days after the periods, and elderly woman can mark the particular date and she can examine herself sitting at home. So we can go for the breast self-examination while bathing. We can stand in front of the mirrors, look for the changes. Even lying down position, we can examine ourselves. And any abnormal changes in the breast, we have to consult the doctor. That is lump in the breast, changes in the breast size and shape, changes in the skin, and nipple discharge. Hospital, big hospital like this medical college, we have to consult the doctors. Goals of community education is early detection, early diagnosis, and with the early diagnosis, we will be able to plan the treatment that's supposed to improve the survival. First treatment is the best treatment. With the best doctor will be, they will be able to plan the stage of the stage of the, they can stage the disease and they can plan the treatment. Thank you so much. If you have got any questions, I'll be able to answer you all. Sir, thank you.
Thank you, ma'am. Now I request our chairpersons to say a few words about the session.
Good morning, all. We all should consider ourselves extremely lucky to hear from two Padma awardees back to back. I think it's an honor for all of us to hear the stalwarts in our field. They should, all these youngsters, they should inspire not only for leading a good life, but to become a good doctor. Speaking about madam, breast has become a huge problem in India nowadays. Previously it was rarely seen, but these days breast cancers are very regularly seen and it is becoming one of the most common cancers in Indian females. The problem with breast is not only the incidence is increasing, but at the same time, age of onset is also increasing and we are getting more and more young patients. Madam has already told these are related to our lifestyle changes. But at the same time, diagnosis is easier than other cancers because the organ is readily visible. As madam has rightly pointed out, breast self-examination. Everybody should know about breast self-examination. We all know about CPRs. CPR is very widely known nowadays. And BSE, breast self-examination, is as important as CPR. It saves lives. So I think that is the take-home message for all of us. And this inspiring lecture should inspire the young girls present here to not only go for radiology or dermatology, but go for oncology, go for surgical oncology, go for radiation oncology. So thank you, madam, for taking your time and coming here and enlightening all of us. Thank you. And go for orthopedics. I'm an oncologist, sir, so I will prefer oncology.
Hello. Now I request our chairperson, Dr. Prashant Dorkar sir and Dr. Shrikant Ahankari sir to felicitate Dr. Vijayalakshmi Deshmane ma'am with the token of appreciation. Now I request our Design and Decor Committee, Surbhi and Nisha, to felicitate Dr. Shrikant Ahankari sir. Now I request our OS, now I request Aniket and Sumit to felicitate Dr. Prashant Dorkar sir.
Thank you, ma'am, for that truly enlightening and inspiring session. Your valuable insights on breast cancer awareness and the importance of community education have greatly enriched our understanding and reinforced the importance of early detection and patient awareness in clinical practice. On behalf of the organizing committee and all the participants, I extend our heartfelt gratitude to you for sparing your valuable time and sharing your immense knowledge and experience with us. It has indeed been an honor and privilege to have you with us today. Thank you once again, ma'am.
Now it is my pleasure to invite Dr. Monica Kulloli to speak on the topic, the evolution of cosmetic gynecology, a field that reflects innovation, advancement, and the changing dimension of women's healthcare. We invite you to share your expertise with us, ma'am.
I'll start. And then I'll start cutting. Good afternoon, everyone. Today, standing here in the midst of all the Padma Shri stalwarts, it's actually a mixed bag feeling for me. But one thing I realize is there's a poem by Rabindranath Tagore ji who says, we have been given an invitation on this earth. Actually, the poem goes something like this. We have been given an invitation on this earth with an instrument in hand. And our job is to play upon that instrument to the best possible capability. So friends, I'm standing here, though in the midst of all the Padma Shri awards. The topic today I'm taking is one of the recent innovations which have come in the field of gynecology. And it has been now taken as a subspecialty by the Medical Council, by NMC, and it's now a 3 years fellowship program post-MS OBS Gynae. And few of the medical colleges have already started the course. And today here, Dr. Monica Kulloli stand before you to give a small introduction of what it is all about to the doctors of Miraj and Sangli. So it's beyond function and how it has been evolved. Can I get the slide here? So basically, it's about breaking the silence. It's nothing new here that these conditions were not there. It was always there in the midst of each one of us, in every single individual and every single family. So what's the shift? The shift is, it's purely from the functional gynecology point, we move towards to the holistic, intimate care of every woman. And what are the patient profiles? Who are the patients whom we actually address to? These are the ones who are seeking for the postpartum recovery, because in the present world each one of us want to look the way we were before we got married, because in the world where we are all on the working platforms, we all want to come back to what we were before. So this is one of the key areas, and most important clinical is the menopausal changes. So all these phases in a woman's life are inevitable, and we have to carry it with grace and dignity and make her life more comfortable. So postmenopausal changes, what we all face with atrophic vaginitis and change in pH, everything, all these can be addressed through this, and the personal aesthetic goals which each one of us silently carry with. So why we need to look into this area is to improve our self-esteem, because we all realize the moment we know that we are feeling good from within and from outside, our behavior to the externals, our attitude to the world changes automatically. So it's for the good sexual function, which is the core of the every human race living, and the physical comfort. So as I said, there's the challenges which a lady goes through at every phase. We have a different challenges. In the initial years, we have our adolescence and the menstrual health concerns, which we have to address, learn and adapt to it. And as we move forward in our adulthood, we have the infertilities, then we have our pregnancy handling and all the pregnancy psychosis issues, changing hormones, everything. And then as we move forward towards the menopause, we need to understand, address the GSMs. So it is really challenging, and do we have some tools with us to address all these conditions? So what are the core procedures which we address in cosmetic? They fall under three wide sections of surgical, non-surgical and functionals. And in surgicals, we address all these labioplasties, vaginoplasties, vaginal tightening, perineoplasties, hoodectomies through various armamentarium which we have. And non-surgical things were mainly because of the vaginal tightening and all the sexual functions to improvise or enhance on that. And the functional ones come both vulva, vaginal and cervical rejuvenations. Treatments for urge and stress incontinence have taken a big go in the leap in this area, and GSMs and pelvic floor strengthenings towards. So what are the armamentarium which is available presently with us? These are the divided gross into energy-based devices, functional magnetic stimulations, regenerative medicines with injectables, your MNRFs, botulinum toxins, and the surgical precisions. Let's take it in detail one by one. So what are the various energy-based devices which we have? Let's have a look at them. So we have various lasers, erbium, YAG lasers, CO2 lasers, you have radio frequencies, then you have diode solid state lasers. All these come with a specific wavelengths which attract the chromophore water in the vagina. So with the help of these things, we can address each one of the lasers have its own pros and cons. So we need to weigh, balance and select a patient right. What is more important here is we have to select the patient right with a detailed history and the clinical examination, because one laser is not an answer for all the women. So every woman has a different situation, and we need to address accordingly. So you need to have an armamentarium of all these tools with you to address it. So basically, as I said, these lasers, they work on the chromophore and the specific wavelengths. We have three major chromophores in our body, that's melanin, hemoglobin and water, where vagina has more of water, and all the wavelengths which addresses, the chromophore which absorbs water, these are the ones which we need to use in us. Hemoglobin and all, these are the ones where in proctology, varicose veins and all, where they burn the blood vessels, so they go into that. So selecting this becomes very crucial for us. So basically the mechanism in short of all the lasers which work is for collagen remodeling, maintaining the elasticity, the contracture of the elastin fibers, neoangiogenesis and small nerve densities, to enhance the sensations and vaginal lubrication. So basically vaginal maturity index is brought back to the initial state when we were young. So that is the main intention with which we play around with all these tools. So there are various evidences. All the evidences basically are from the outside India, and now it's been couple of years which the Indian friends of ours have started it, and they've started collecting the data. So we have a long way to go in this area to collect our own data and present it according to our conditions. So few of this, this is one with the DC current technology where electroporation was used. Good improvements have been noted in the vaginal maturation index. Now coming to the next armamentarium of the functional magnetic chair stimulation. This is basically the magnetic stimulation which we are giving to the pelvic floor muscles or the back muscles. This is basically to strengthen the pelvic floor, and all the conditions which come under pelvic floor dysfunction, right from the urinary urge incontinence, your lax vagina, weak pelvis, post-delivery laxity, everything is addressed with this chair by bringing it. This is nothing but a Kegels exercise which we do, but our patients fail to do it regularly, and this even addresses to the extent of first degree prolapses where we don't have much of the surgical options amongst us. So we can go, these are all basically simple OPD procedures. During your working time, you can just hop in and hop out with these procedures in hand, where the actual function is your magnetic, this thing, it's the nerve, it is a nervous stimulation. You bring about the depolarization of the nerves, and then that activates, the action potential activates and the muscle contracture takes place. And what is important, or we differentiate it from the electric stimulation, is electric stimulation basically hits the muscle fibers. Here we hit the nerve fibers. And the deep tissue penetration is also almost to the extent of 10 to 12 centimeters we can penetrate. So various medical applications which addresses, as I already mentioned, all the pelvic floor dysfunctions, rehabilitation in neurology, and even presently they have been trying, in the TMS, with even for the brain also, on the scalp also the stimulations are given which we called as the brain fog. So, and a non-invasive technique for body contouring to bring back the strength in the abdomen, pelvis and back muscles. So, a few studies which were done, even the urodynamic studies, especially for the magnetic simulation, what we give, after 12 to 16 treatments, 2 weeks, bi-weekly is what is the schedule. So at the end of 16 treatment studies, significant improvement has been noted in the urodynamics of the bladder, which really helps us in the urge and the stress incontinence. And as we all know, with age of above 40 years, almost 40% of the women end up with the urge incontinence, and we silently suffer with the embarrassment, and people get locked inside the four walls because of this issue. So few studies again supporting the FMS treatments, where even the SUI and the overactive bladder questionnaires have been significantly improved with the various studies which have been done, like UDI, ICI and all. So now what are the advantages? Simple non-OPD procedures, no downtime, it's a non-invasive body sculpting, it builds muscles and burns fat. The contractions which give almost up to 50,000 contractions are expected in the 30-minute span of the procedure time, and it's the fat which is used to bring about this contraction, so burns fat. So how do we evaluate? End of the day, once we have given them, it's a mixed bag of treatment. It's not like you give them a laser and that is done, or you give them a magnetic stimulation. No, we need to try 2 to 3 modalities to finally bring up the results to a lady according to her condition. So there are various scales for evaluations which are there in front. So with the help of these questionnaires and the scales, objectively we can identify what is her condition so that we can hit the target rightly. And once we have done the procedures, it is a prognostic tool also. So where we know how well she is improving with this, is she getting the results or no. So as every visit she comes, you ask her to go through the questionnaires and see where is she progressing and where is she lacking, so that again we can modify the treatment accordingly. So extensive counseling is mandatory to bring about good results of that. Again, coming to the next tool we have are the regeneratives and the injectables with us. So it's mainly the plasma-rich proteins, then you have hyaluronic acid, exosomes, botulinum toxins. These are all the things which we have in hand. How we play around them is a very interesting thing. So PRP, as we said, because now presently it is being used in and out at every branch of medicine, we are using PRPs. Me as a gynecologist, I am interested ki where do I make the best use of this PRP. So because what is PRP? It is basically, it is fully, it's a reservoir for all types of 7 major growth factors with us. So this brings about the complete tissue remodeling, see, once we put the PRP in place. So in gynecology, our main organ is a vagina, where we have to work around. So how do we make use of this PRP? So it's basically, again, just injecting PRP in the vaginal mucosa. Yes, it will work, but if we have to make it more efficient to work, so how do we work upon it? It is like initially put the patient on treatment. Here electroporation is one technique where DC current is used, and with the DC, once we give a DC current which almost goes up to 40 to 45 degree temperature, it doesn't go beyond that, there all the electric pores are opened. So once the electric ionic channels are open and your sodium potassium channels keep crossing from the extracellular to the intracellular area. So when these pores are open, that is the time when we need to hit it. So after the treatment with DC current, then with these pores open, then you put plasma into it and then give a slight massage or the rub onto it, where all these PRPs are absorbed into it, for which we also call it as a plasma poration. It percolates down into this thing and brings about the regenerations of the cells. Very interesting and very, very good results are there with this. The same technique which we can use is like even exosomes also. Exosomes, which I'll come later, the same we can put exosomes, you can use hyaluronic acid. You have lots of things to play around once all the pores are open. This is a time which we need to address on that to make the maximum out of this PRP. So again, PRP use another is for the pure functional sexual enhancements of all the shots, as O shots and G shots, which is so widely used in this thing, are trademarked, and we need to use them very cautiously so we can very safely come to our Indian version of Kama Sutra shots here, where we can inject PRP into the specific areas. So the science is, again, as I've already mentioned, various growth factors bring about the tissue repairs and the vascular remodeling at the site. Coming to exosomes, very interesting. Now this is a new kid right now which people are experimenting a lot. So this is basically a very tiny 30 to 150 nanometer measured this thing, which is surrounded by a lipid profile. But this comes with a cargo, it has got a cargo of elements which has got your proteins, your lipids and your mRNAs and genetic material, everything inside it. So once the pores are open, the cell releases exosomes into the extracellular. It is carried through your body fluids and then goes to the specific areas to act upon, and this is bringing a real game changer nowadays, which many are trying. We have 3 varieties or sources of it. Autologous, where again it is like a PRP. Initially autologous is now basically, we can't call them as exosome specific, we can call them as super rich PRPs. Because it's like you take the patient's own blood, prepare a PRP, subject it to again a heat treatment, and then they call it as an exosomes, but actually they are super rich PRPs, you can say. Human and animals are being banned. They are not safe, but now the trials are on the plant-based therapies, I think, where the rose, the rose has got a similar mRNA structure like the human, and the trials are going on with that. So now, as I've already taken a bit with the electroporations or the techniques which the DC this thing is used, where reverse depolarization is happening, where all the pores are open, ions are open, the cells are at its most active stage, and that is one where we like salad ke upar we garnish it. So you garnish it with all the agents what you have in hand. You have vitamin C, you have glutathione, you have hyaluronic acid, PRPs, exosomes, everything. So this is one of the important technique, but presently this technique is in the patent phase with only one company of jet plasma. So same electroporation I have already mentioned. So now electroporation and plasma poration. So plasma poration is what you put. You're putting PRP. It is called as plasma poration. Next, coming now to the fillers. These fillers are basically the HA which we use. It's a water magnet, what we all know, and it is extensively present in the human body, mainly in the skin, joints, and your eyes. So this is where HA is used, and this comes in two forms: cross-linked and non-cross-linked format. Non-cross-linked is one which is hygroscopic, almost 1,000 times more. It has the water absorbing ability. So this is where we actually use for all, where we use for the joints and all as a lubricating agent. Then we use in the vagina also. We can inject this. Then we can use it in the shorts also to enhance. And when it comes to fillers, especially the labial fillers where the atrophic labia is present and we want to do filling there, the cross-linked ones, that is which has got more strength. It is like the scaffold around this thing, so it has strength, has the resistance, and we can use the cross-linked variety for the labial fillers. The same difference between both of them. Then now coming to botulinum toxin. One of the most, I feel very attracted to this because this is one drug, which relates, because we come across in our routine OPDs the condition called as vaginismus. This is a condition which silently the couples are suffering. We also come to know that 6 months, 8 months, the marriage has never got consummated because of this one factor of vaginismus. Because they are scared, they feel awkward, whom to approach, what to approach. So here, this is one treatment where we can relax the muscles. This is the bulbococcygeus and the pubococcygeus where we give injections, relax the musculature, extensive counseling is needed. Basically, this we use for the Laments grade 3 to 5 staging. This is useful along with counseling, vaginal dilators and the injections. We can address this condition and definitely the life of the couple goes very good. So we need to address. Again, I said right in and right out, we cannot use these drugs. They have their own side effects and things. We need to counsel, understand. If you go to the FSFI scale, the female sexual functional index, you need to address where exactly is the issue in the process of the sexual intercourse, and that is the entry. The introduction is a problem, then only these drugs act there. So clinical applications, again in our field, we have in the field of urology, where overactive bladders and neurogenic detrusor activity has been addressed very well with great results. In our gynecology, we have for refractory vaginismus, as I mentioned, Laments grade 3 to 5. This works wonders. And again, at the clitoris, we can inject this to improve the sexual functions. In dermatology, yes, for scar management and to reduce the tension, alopecia, everything they have been trying in dermat. Now coming to the last tool, what we have are the peels. Again, these peels are basically for your look enhancements, depigmentations, lightening, skin lightening agents, and these are all which are available presently with us. And we are presently, I am attached to this institute called as NISA, where we are working on this cosmetic light job with all the armamentariums present, and we are addressing the community of it. Thank you so much. Anyone has any questions? Thank you.
We sincerely thank you for such a enlightening session, ma'am. Now I request Sakshi Shinde and Aditya Pujari to felicitate Dr. Monica Kulloli, ma'am.
Now I request Chairperson Dr. Sanjot Kurne sir to come on stage for the session. It is with immense pride, deep admiration, and the highest honor that I rise to introduce a name that resonates with excellence in the realm of cardiothoracic surgery, Dr. Tushar Dhopde. A surgeon of extraordinary caliber, he represents the perfect confluence of precision, perseverance, and passion. In an era where every heartbeat matters, he has restored thousands with a staggering experience of 3,500 plus open heart surgeries, 300 plus vascular surgeries, and over 100 thoracic procedures. Each number is not merely statistics, but life reclaimed and a family given hope.
His academic journey is marked by excellence, MBBS, MS, MCH, and the prestigious FRCS, along with being a gold medalist from Maimar Pune, securing top ranks at LTMMC Science and receiving the PK Sen gold medal from TNMC Mumbai. With advanced training in beating heart, CABG at Apollo Chennai, a fellowship in aortic surgery in Melbourne, and a diploma in ECMO and critical support in Paris. He brings refined global expertise to his practice, specializing in advanced procedures like TAVI, TEVAR, EVAR, complex aortic and thoracic surgeries, and ECMO support, and honored internationally with FRCS, FEBCTS, and FICS. He stands as a true leader and an inspiration in modern cardiothoracic surgery.
And on a personal note, sir, as someone who dreams of becoming a cardiothoracic and vascular surgeon, I truly see you as one of my greatest inspiration. Your journey reminds us that with dedication, discipline, and courage, even the most complex paths can be conquered. Today, we are privileged to hear him speak on a highly significant and life-saving subject, New Horizons in Cardiovascular and Thoracic Surgery. With immense respect and heartfelt admiration, I invite Dr. Tushar Dhopde sir to address the gathering.
Thank you, GMC Miraj, for the kind invitation, and Dr. Jeevan and his team. And thank you, Sanjot. It's a long time, after maybe 25 years, we are on the same podium. Sanjot and me were from the same school. So I just changed the topic last night because the team had asked me to talk about newer things in cardiovascular trauma. It was a little bit surprising to talk on the same thing. Maybe before I begin with, may I ask you how many of you from the student community, the PGs and UGs, have seen an open heart beating, not in the cadaver room in your anatomy lab? How many of you seen an open heart surgery happening? May I have your hands up in the air? So it's virtually 1-0. So maybe let me take you to the fascinating world of cardiovascular surgery. When I might just combine it with Marathi and English. Will that be okay with you, or you want me to be in English? Let's make it interactive, one-on-one. Don't want to bore you with some papers and other things. I just want to show you what is possible in the real world. Will that be okay? Loud, loud. Fantastic. So my father was a teacher. No one in my school, family is a doctor. I am the only doctor in my family. So when I finished my medicine, MBBS, I went to general surgery in Sion, and then I was about to finish. I had just come on a holiday here before my MS general surgery exams. A couple of the senior surgeons over here asked me, what is your aim when you want to start your practice? I said, no, let me do some MCH, because that used to be sounding something different then, because no super speciality existed over here. A few senior super specialists existed. Then I told them cardiac surgery. Then everyone was pulling me, hey man, you can do general surgery, you will earn well out of it, you will make a good name. Why you want to take cardiac surgery? कारण ओपन हार्ट सर्जरीला गेला माणूस तो डॉक्टर पण गायब होतोय आणि सर्जन पेशंट पण गायब होतोय आठवडा. सो यू डोंट नो व्हॉट हॅपन्स टू द पेशंट अँड यू डोंट नो व्हॉट हॅपन्स टू द डॉक्टर. Both of them are in the ICU 8 days later. You don't know what is happening. I was like little bit scared, and then I thought, what is happening? But I was fortunate enough, we in Sion back then had a very beautiful cardiac surgery department happening. So I went there, and I saw that no, it is actually happening. It's not like what it has been projected in our region that okay, open heart surgery not possible. A surgery lasting for about 12, 14, 18 hours, and at the end of the day, the patient is nowhere, the surgeon is nowhere. And you need tons of blood. So no, the things had changed. So just how do I move this? Here, okay? Here. So in cardiothoracic surgery, it's not just cardiac. The scope includes cardiac, vascular, and thoracic. So what all you can have in cardiac surgery? You can have coronary surgery, you can have valvular surgeries, you've got congenital, then artificial systems which include mechanical circulatory supports, artificial heart, artificial lungs, and the newest kid on the block, transplant. In thoracic, you've got lung diseases, pleural diseases, tumors, transplants. In thoracic, the way you operate is changing, it's evolving. It used to be an open surgery first with a long, big thoracotomy. From there, we moved on to video assisted, just like how your laparoscopic appendix or lap cholecystectomies are performed. Now we are doing it robotically. Vascular surgeries, you guys might be doing your duties in your wards, in your casualty. You might be getting patients with limb ischemia, trauma, bone fracture, there is no pulse. What next? So the next thing, the registrar from the surgical unit comes, hey, pulse nahi hai, chala yala amputation lag gaya. No, you can save at least 70 to 80% of them if attended on time. So salvaging a limb is very important than doing an amputation. You've got limb ischemia, it can be acute, it can be chronic. Deep vein thrombosis, you might be having every day, every time, every OP session. Every one of you might have seen deep vein thrombosis. Kai karaycha heparin lawa sodun dya. No, there are very beautiful technical advances happening where you can restore the limbs. Aneurysms, trauma. Now, if you go back to 2025, aorta, the biggest blood vessel in the body, that has now been classified as a separate organ. So, earlier days, when coronary heart surgery bypass was being performed, it was being performed with the heart standing still. You had to stop the heart, you had to connect the patient to a machine, where the machine took over, and then you do the grafting. Now we moved from that. We are doing it on a beating heart. Imagine opening the bonnet of a car, the engine on, and you have to repair the engine. Fascinating. So, can you just play that? There are videos in this. Yeah. You can see this. See, the heart is being lifted up and a bypass being performed. The next video. Yeah. Then we moved on because earlier days it was the vein graft being used more commonly. The saphenous vein, the great saphenous vein, chapter 1 BD Chaurasia book, if you guys read now, or Gray's Anatomy, I doubt people are reading it. So from there we moved on to internal mammary arteries. The arterial grafts last longer. They stay open for a longer period. So this is a patient where you have done internal mammaries. Both the internal mammary arteries have been harvested and they have been joined together. You can see both of them pulsating. So that is how it looks after the grafts have been anastomosed. You can see that one is going. Yeah. So that is how the grafts go in. You can see the forceps pointing in. That's 1, that's 2, that's 3 and 4 grafts. From there, the new things. We had to always keep ourselves updated, compete with the cardiologist, because सगळेजण येऊन सांगतात bypass टाळत angioplasty केली. Wrong thing. Everyone has got a specific indication where you should go for a bypass, where you should go for an angioplasty. So please take home message for you guys. follow the guidelines. Bypass started angioplasty, that is a wrong concept, or vice versa. So now we moved out from a big sternotomy to a small thoracotomy. You can see a CABG being performed. That's a small incision where the bypasses have been performed. You can see this, a 3-inch incision. There are videos. So that is how you stop the heart. You can see the heart beating there. We put ice to just cool the heart so that it can help us operate while the time the heart is not beating. The heart is slowing down now. Then you put a clamp across the aorta. All these cases are done in this town, huh? And the heart is stopped. Now you open the left ventricle. You remove the deceased valve, you put a new valve, and then the heart is beating again on your right, on your left. So that is how the deceased valve looks in the picture on your left. Then you size the valve. That's the valve that has been removed, and that's a new valve that has been implanted. So likewise, you can do it in a small hemisternotomy with a 2-inch incision in the manubrium. So that's a AVR in a 2-inch incision. That's another way of doing an aortic valve replacement in a 2-inch incision. Mitral valve in a 3-inch incision. Now next, we can do aortic aneurysm. Now here on the left, you can see the aorta which is dilated. On the right side of the image is showing a bicuspid aortic valve, where the aortic valve is made up of only 2 leaflets, not the 3 ones. It's one of the most common congenital anomalies. So when you have that, a person in 30s or 40s will come with severe aortic stenosis. They also at the same time will have an dilated ascending aorta. So you have to remove the deceased valve and also the deceased aorta and replace both. So that is how it looks. You change the valve and then put a graft. Then you've got aneurysms. You can see it on the CT scan. Below the 2 kidneys, you can see the abdominal aortic aorta becoming big. You can compare it. It's called an aneurysm. So you open, you expose the thing, you can see the aneurysm there, the big one. You then remove the clot, you open the aneurysm, then you put a graft like that, and that's a follow-up CT. There are videos. So now this boy, 18 years old, came with a ruptured ascending aorta. Now you can see, you're opening the pericardium, the blood's coming out. The patient is already on heart-lung machine, so don't get scared. The ascending aorta had ruptured. All the blood was inside the pericardium. So once you have opened the pericardium, identified the thing, you put a clamp, get a control. On the other side, while the thing's being opened, you can see all the blood being poured. That's been taken back into the machine. So that is how the deceased valve and the ascending aorta was removed, excised, and then we have closed it with a new valve with an ascending aortic graft. That was the patient sitting in day 5. Likewise, an aneurysm of the superior mesenteric artery. So the aneurysm was opened. Video. The patient going on I'm sorry if the video is not playing. So renal cell carcinoma, oncology. So there also a cardiac surgeon can go and enter. Now this chap had a big renal cell carcinoma. The tumor was extending into the renal vein, going into the inferior vena cava, into the right atrium. So that's how you opened up from the manubrium sterni down to the to the pubic symphysis, a big vertical incision. That's the extended specimen with the kidney. That's the big kidney, what's there in the hand. And that is the tumor which was going into the right atrium. You can see the IVC is being now opened there, the blood being sucked, the liver being moved onto the opposite side. And that is the, after opening the IVC, you can see the tumor being removed from the inferior vena cava. That was the patient going home. Pheochromocytoma, young girl, about 14-15 years old. I did this with Ombalkar sir. You might be knowing Ombalkar sir, one of the finest teachers. So he had a girl with pheochromocytoma, pressures uncontrolled, compressing the IVC. That was the tumor. You can see the round thing. That is the tumor which is attached to the inferior vena cava and to the aorta. That's the small inferior vena cava of a 14-year-old girl. From there the tumor is being separated. And that's how the tumor was out. It's stuck to the inferior vena cava. Now cancer of the inferior vena cava, it's called as an IVC sarcoma. So we have opened the thing, the entire inferior vena cava was removed and replaced by a graft with the tumor. So that's how the incision is. The colon's being reflected, the liver is being moved on to complete right liver mobilization. The IVC has been resected from the hepatic vein junction up below the renal vein junction. One renal vein was anastomosed to the neo IVC. You can see that tubular thing, a graft which is there, one with serrated margins. So that is the IVC, and I'll show you the tumor in a minute. So entire IVC was removed and an artificial tube was placed between. The hepatic veins were reimplanted, the renal veins were reimplanted. So that's how you move the liver completely. This is in a live patient, not in a dissection hall. So that entire tubular structure is the inferior vena cava. Look, you can see now? Yeah, so that is the new inferior vena cava. So that's the renal vein which was connected to the tube. And that is the tumor which will now come and sit where it was. This tumor is of the inferior vena cava, complete inferior vena cava. That is the inferior vena cava which has become solid completely. Myasthenia gravis. Patients will have thymoma. Everyone might have heard about myasthenia in the physiology. Ganong. So what we do here is, I think Rokde madam is there, anesthetist. She's gone. We don't put the patient on general anesthesia. We put them on a cervical epidural. Patient is talking to you, opening her eyes, and the chest is open. Can you see the chest open, the lungs coming up completely, and when it comes on this side, you can see the patient is completely awake, talking to you. See there is no endotracheal tube in the mouth, and that is the tumor, what you can see that has been removed. So, as I mentioned earlier, in thoracotomy, we've moved from open thoracic surgery to video assisted. That is how, like a laparoscopy, you do thoracic surgery. This is how it is done. This was a case of a decortication where you can see there multiple loculations being broken and the adhesions being taken off. And the other video you can see the lung coming up, the lung being expanded. This is another video assisted tumor excision, the lung tumor being removed, video assisted. So that is called fluorodesis, where you insufflate talc into it. So that is how 5 millimeter ports, and you are done. Now this is something I wanted to focus on. If I tell you we are able to now do a valve replacement on a daycare basis, how many of you will believe? Open heart surgery न करता वॉल रिप्लेसमेंट लोकल एनेस्थेसियात करता येऊ शकते म्हटलं तर किती लोकांना खरं वाटेल? हँड्स अप प्लीज. झोपलात का? Good morning. Wake up, wake up. How many of you can say yes? Hands up. No. Hands up. But this is being possible. We are doing it. Patient walks to you with a severe aortic stenosis. You give some small local anesthesia in the groin, puncture the femoral artery and do the valve replacement. Patient is walking the same day evening. The next day patient goes home. So that is called transcatheter aortic valve implantation or TAVI. So that is, the surgeon is now moved from the operating room to the cath lab. So the cath lab is not only the domain of cardiologists anymore, the surgeons are also doing it. Now here you can see that the groin is being punctured. I'll take you to the next video also. Now we are the valve is being placed. Now this is how it is done inside the catheterization laboratory. So that is how it looks like. Sorry for the small picture, I've just taken a thing from the console. So you cross the valve. The thing which is moving up is the aortic valve, the new aortic valve. The structure जाळी असलेल्यासारखा असा चौकोन, it is moving across the aortic arch. That is going and sitting inside the previous aortic valve. And you open it up. You check the position. The valve is placed under local anesthesia. This was a patient who had already undergone an aortic valve replacement, a tissue valve, which had deteriorated or degenerated. He needed a second surgery. Earlier days, we were doing it as a second open heart surgery. Now we can do it in the same way. You can see it, the crown-like thing, what you have read in your anatomy books. The same thing is the artificial heart valve, which was there before, which has gone bad, and a new frame-like thing, which is being seen now, is the new aortic valve. So a second valve-in-valve implantation. So that is how you do it. From the groin, this is the valve that is being moved in. If at any moment or any time you get bored, let me know, I'll stop. So that is how the thing goes into the groin, and then you do it. I'll just rush into it because the same thing happens what I had shown you before. So now we are doing mitral valves also like that, under local anesthesia. So that is the earlier degenerated mitral valve, where you put a new thing, a new valve is placed. The new valve, like earlier, it is being pushed in and the new valve is placed. So that's how it looks like, the final new valve, without doing an open heart surgery. Now, you might have heard of tetralogy of Fallot in congenitals. Every pathology or anatomy you might have heard of this. When you do a total correction for a tetralogy, at times the pulmonary valve is not developed in a pediatric age group. So you have to sacrifice the pulmonary valve, and over a period of time there will be a pulmonary regurgitation happening, which eventually hits the right ventricle. So these patients need a valve replacement later on in their life, so as the right ventricle is preserved. Earlier days we had to go in again, and in pediatric you have to do the surgery in a staged way. 6 months one surgery, 2 years another, 10 years third surgery, like that it goes in. So but now 4th or 5th time redos are always complex, and what happens is the mortality morbidities are high. So now for these kind of patients we can implant the pulmonary valve inside the cath lab under local or under short general anesthesia without opening the chest. So like, this is another patient where we have done a pulmonary valve replacement, who had undergone a BT shunt, then a total correction for a tetralogy, and the new valve being placed. That was the final result. You can see the valve there. So TVAR. What does that mean? Thoracic endovascular aneurysm repair. I showed you one case where the abdominal aortic aneurysm, where the abdominal aorta had become big, we had to cut open the abdomen, do a laparotomy, close the things, and put an artificial graft. Now, likewise, how do we do a TAVI? We can do the aneurysm repairs also inside the cath lab through a small puncture in the groin. Now, this gentleman, an 87 years old gentleman, who had a thoracic aortic aneurysm, a big 9 centimeter, that had ruptured into his esophagus, causing a aortoesophageal fistula, and he came to us bleeding, vomiting blood, hypotensive. Now, in 87 years old, putting the patient to a general anesthesia and doing a very complex operation, the results are not that great. So, we took him to cath lab, and then you can see here one graft is being placed inside the thoracic aorta. That is the thing. The picture is not clear, sorry for that. You can see that thing happening. Old man at home. Third year general surgery or MS general surgery, anyone? How do you describe an abdomen? Pulsatile, painful lump in abdomen. What does that mean? S. Das, Hamilton Bailey. Anyone reading it? Can't hear. Awaz. That is the case where you have a pulsatile. Can you see the pulsations? It's a case of abdominal aortic aneurysm. You can see the thing pulsating. This fellow has already undergone a laparotomy. So that was a CT scan. So that's the big aortic aneurysm, and that is the post procedure where we have stented him. So that is how it is done in the cath lab. Now this patient also needed a CABG. We did a CABG in the morning, and afternoon we fixed his abdominal aortic aneurysm. So that is how the graft goes, and it sits in. You can see the Y-like thing completely sitting inside. Now this patient came with a ruptured abdominal aortic aneurysm in the middle of the night. You can't take them and do fix the aneurysm with a hypotensive patient, 60 systolic. It's very, very complex. Mortalities are very high, close to 90%. So that is how we did it. So the thing goes in. It's a wire. He already underwent a CABG before. 86 years old man with a ruptured abdominal aortic aneurysm. Now here on the injection you can see the dye coming out. So that is how the stent graft is deployed. The stent graft opens up and it closes off the aneurysm. So that is how it looks on a post-operative CT scan. This is another case of abdominal aortic aneurysm. See how big it is. The thing was, both the renals are also involved. So we had to put in 2 stents into the renal arteries and then do a endovascular aneurysm repair. It's called as a chimney EVAR. You can see how massive that is. Big calcifications. This short video, how you do it in the cath lab. So no need for a big surgery, post-operative issues are minimal. So in this patient, we had to put in 2 stent grafts in the renal arteries and then see the renal artery being cannulated there. And that is the stent. I'll just rush through the slide. You've seen it before. So that is how it looks. 2 stents in the renals and then endovascular stent graft. There's a fenestration. You can see small holes there. you do holes in the graft and then put a stent through into it. So superior mesenteric, both the renals, inferior mesenteric arteries, or even the celiac can be stented. So that's how it looks. You can see some multiple stents into it. So that's another aneurysm. These are peripheral aneurysms also which come to you. So that's aneurysm in the carotid subclavian region, up in the neck. So that is how it looks, how big an aneurysm it is. The one going up is your carotid, the one horizontal is the subclavian. So again in the cath lab, and you put 2 stents into the carotid and the subclavian, the job is done, no open need. See how it looks. Deep vein thrombosis, I mentioned it earlier. Now we have got beautiful gadgets which can take off the clot. Now this lady had a big DVT from the iliac vein, from the inferior vena cava down to the popliteal vein. Now we have punctured the popliteal vein and then this catheter is going in and the clot is being removed. So that is how you can see on that. You can see the clot being removed. See how big the clot has come out. That big clot come out. And that was the before and after. You can see both the legs, similar things in 15 days. Pulmonary embolism also can be removed like that. So this gentleman had a CA colon with a pulmonary embolism. So he had to undergo a surgery for CA colon. And to remove the pulmonary embolism, we placed this catheter into the IVC, from there into the right atrium, right ventricle into the pulmonary artery, and then removed all the clot so that he is being made fit to undergo a CA colon surgery. This is how the thing goes in. So that's a complete picture cleared. So another case of pulmonary embolism, that is the clot what we removed. Varicose veins. So we deal with varicose veins also, open surgical, laser, radio frequency ablation. Now newer glues have come up, which is just a daycare procedure. Patient walks in, you inject the glue and just leave the thing. Now this 85-year-old lady had come up with this bad varicose ulcer with a vein, varicose vein. So we did a radio frequency ablation for her, and then artificial skin graft or a cadaver skin graft. We have a cadaver skin graft in Miraj as well. The first was in my alma mater, Sion Hospital. The same team has helped develop a skin bank here. So we placed the cadaver skin graft and changed regular dressings with cadaveric skin graft, and that was the result in 2 months. So this is one of the artificial heart supports where your heart is failing. You have got an intra-aortic balloon pump. The newer one on the block is an impeller. It is a pump. So you cut open the subclavian artery, put a graft. From there you put it into the left ventricle. The pump sucks blood from the left ventricle and it throws into the aorta. So entire work of the left ventricle is being taken care by the impeller. So that is how you place it. This is ECMO. So ECMO stands for extracorporeal membrane oxygenation. So what does that mean? Your work of your heart and your lungs are taken care by this by this machine. You rest your heart and lungs, and then you prepare the heart or lungs or both for either recovery, 1, 2, as a bridge to transplant or a bridge to destination. You put into an artificial heart, artificial lung, or something of that kind. At times, the cardiac surgeon is also called up in emergency. So the cardiologists keep doing devices. You might have heard, Chatri takli hai, ASD, chota hole hota, manditun takli hai there. But unless and until they have a surgeon standing by, they can't do the procedure, because if something goes wrong, the surgeon is the one who can bail him out. Now this boy had got a PDA device slipped. That is the heart beating and that is the right pulmonary artery. See the device coming out. So the slip device, retrieving it at times is very difficult. So that is how it comes out. That was the boy going home. And that's my team at Synergy. Thank you very much. Thank you once again for the invitation. Open to questions. And maybe now I can ask how many of you want to get into cardiac surgery? Big number. And there's an informal invitation. I don't know your dean would like it or not. Anyone who is interested can come to my office, come to my operating room, see whatever you want. I'll try my best to teach you out.
Now I request our chairperson to share a few words about the session.
Good afternoon, everybody. I don't know how many of you know that our Western Maharashtra, Miraj was the first place where open heart surgery was done in 1960s. So after that, like Tushar and myself, we are born and brought up in Miraj itself. We have not seen any advances for so long period. But I can proudly say that since Tushar has come back, we have seen a lot of changes, newer advances coming back to Miraj. And I congratulate Dr. Tushar for bringing all the advances in cardiothoracic surgery. Also, after this beautiful, wonderful lecture, I can definitely say that a lot of students will take up cardiothoracic surgery as a branch. Thank you, Tushar. And one more, I would like to tell you that one of our students from GMC Miraj is the highest TAVI operator in UK at present. So this is for encouragement for all the students. It's not impossible. Everything is possible. Thank you.
Now I request our chairperson, Dr. Sanjot Kurne sir, to present Dr. Tushar Dopde sir with a token of appreciation. Now I request Samarth and Pranali to felicitate Dr. Sanjot Kurne sir for this session.
On behalf of the entire MEDICIENCIA team, I sincerely thank you for that inspiring and thought-provoking session. Today, you beautifully reminded us that the true art of medicine lies in balancing scientific precision with compassion and holistic care. Your words have not only enriched our knowledge, but also strengthened our perspective as a future healers. It has been an absolute honor to learn from you, sir. Thank you for your time, your wisdom, and your crucial guidance. We are truly grateful. This concludes the morning session. Please join us for lunch and be back by 2:15 p.m. Thank you. UG students, please proceed for lunch in sequence. Girls will be going first, then boys. I request everyone to finish their lunch within half hour. Panel discussion will start at sharp 2 p.m.
Hello. Check, hello. Check, hello, hello. Check, hello. check, hello. 1, T, hello, check.
Check, hello. Hello, check. 1, 1, T, check, hello. Hello, check. My test, check, hello. Hello, hello. Check, hello. Hello, check, hello. Check, hello. Hello. My test, 1, 1, 1, T, hello. Check, hello. Hello, hello. Hey, hey. Check, hello. Hello. My test, 1, T, hello. Check, hello. Hello, check, hello. Check, 1, T, hello. Hello, check, hello. Check, hello. My test, hello. Check, hello. To kick. hello, check, hello, hello, check, hello,
ग्रेवी में मैं आपको तावा ग्रेवी प्रोवाइड करूँगा, टेस्टी रहेगा, मीडियम स्पाइसी चलेगा।
यार सबकी वेके पिक्स आर स्ट्रेट आउट ऑफ अ मूवी और मेरा व्यू ट्रैफिक। फिल्टर लगा के सेल्फी ले, कैप्शन डाल, स्टक बट स्टिल स्टाइलिश। नो रूल्स जस्ट कूल, कूल बर्ग।
छोड़ गई भाई फिर से।
Just right swipe her best friend, yo.
No rules, just cool, cool bug.
मेरी कामयाबी के पीछे मेरे परिवार का साथ और उनकी दुआएं रही हैं और रहा है एक स्टार, मेरे किचन का स्टार, स्टार रिफाइंड ऑयल। ये हर तरह की कुकिंग के लिए परफेक्ट है, चाहे डीप फ्राई करना हो या सॉटे। ये फोर्टिफाइड है विद विटामिन ए और डी और इसमें है पूफा और मुफा का सही बैलेंस। ये सिर्फ तेल नहीं, मेरे परिवार का हिस्सा है। स्टार रिफाइंड ऑयल, बरसों का भरोसा अब नई पहचान के साथ।
Satisfaction and growth, we focus on both. Located in the vibrant city of Sangli, the Manan Group of Construction stands true to the definitions of trust, quality and innovation in the field of construction. With a rich history of over 12 years, Manan Group of Construction has consistently set new benchmarks for quality and professionalism in the industry. Established on 11th November 2011, our company insists on a customer-centric approach and focuses on the satisfaction of our customers. Our portfolio encompasses a diverse range of projects, including industrial, residential and commercial work, road construction, special structural shade work and much more. We take immense pride in our ability to deliver our services to the specific needs and aspirations of our clients, ensuring that each project is being executed with utmost precision and attention to detail. From the initial design phase to the final handover, we adhere to the highest industry standards, utilizing cutting-edge technology and the finest materials to create structures that are visually stunning and built to stand the taste of the time. With every project we undertake, our dedicated team of professionals strives to bring forth structures that seamlessly blend functionality, aesthetics, and sustainability. The ladder of success that we are climbing up and up every day is because of the concrete support of our exceptional team of architects, engineers, and construction experts who bring their wealth of knowledge The ladder of success that we are climbing up and up every day is because of the concrete support of our exceptional team of architects, engineers, and construction experts who bring their wealth of knowledge and expertise to every project. With their innovative ideas, meticulous planning, and flawless execution, they ensure that each project undertaken by the Manan Group of Construction is a masterpiece in its own right.
आणि अतिशय चांगलं काम या म्हणून कन्स्ट्रक्शनने केलं. एक गुणवत्तापूर्ण काम आणि दिलेल्या वेळेत काम पूर्ण केलं. त्यामुळं आमचा विस्तारीकरणाचा प्रोजेक्ट एकदम वेळेत निर्माण व्हायला पूर्ण व्हायला मदत झाली.
Every one of our employees is a capable leader, and this makes us feel more responsible for their nourishment. Therefore, we conduct employee engagement activities and programs throughout the year. On the 11th of November every year, we arrange a grand program for our employees, wherein we appreciate the achievers and express our. We also recognize the importance.
मी सिव्हिल इंजिनियर उदय पाटील गेले 1 वर्षापासून मनन कन्स्ट्रक्शन सांगली यांचे मार्फत जे 100 KLPD डिस्टिलरीचे काम देण्यात आलेले आहे ते अतिशय चांगल्या पद्धतीने करत असून त्यांचा अनुभवी स्टाफ व टेक्निकल सुपरविजन या गोष्टी अतिशय चांगल्या आहेत. याचीच गोष्टची नोंद मॅनेजमेंटने घेतली असून त्यामुळे त्यांना कारखान्याच्या 7,500 मेट्रिक टन विस्तारवाढी प्रकल्पाची सर्व सिव्हिल कामे ही मनन कन्स्ट्रक्शन सांगली यांना देण्यात आलेली आहेत.
Our dedicated customer support team is always available to address any concerns or queries, ensuring that our clients feel valued and involved at every stage. Framed with the futuristic approach, our mission includes being highly professional in all our deals and thus including the achievement of customer delight. Under the passionate and futuristic leadership of Managing Directors Mr. Sagar Vadgave and Mr. Sudhir Babar, Manan Group of Constructions is reinforcing its position as builders to the nation.
Secret ingredient in the recipe of a successful company is always discipline. With the discipline
into reality as
मेरी कामयाबी के पीछे मेरे परिवार का साथ और उनकी दुआएं रही हैं और रहा है एक स्टार, मेरे किचन का स्टार, स्टार रिफाइंड ऑयल। ये हर तरह की कुकिंग के लिए परफेक्ट है, चाहे डीप फ्राई करना हो या सॉटे। ये फोर्टिफाइड है विद विटामिन ए और डी और इसमें है पूफा और मुफा का सही बैलेंस। ये सिर्फ तेल नहीं, मेरे परिवार का हिस्सा है। स्टार रिफाइंड ऑयल, बरसों का भरोसा अब नई पहचान के साथ।
दिवसभर धावपळ, जबाबदाऱ्या आणि सततचा ताण, कधीतरी मनालाही हवी असते शांततेची एक जागा। अर्बन रिपब्लिक सांगली मिरज जवळ 30 एकरांमध्ये पसरलेलं निसर्गाशी जोडलेलं प्रीमियम गेटेड कम्युनिटी टाउनशिप, 3 एकर्स लँडस्केप गार्डन, ॲम्फी थिएटर, योगा झोन्स आणि 20+ विचारपूर्वक डिझाईन केलेल्या अमेनिटीज, लक्झुरियस 3 and 4 BHK रो हाऊसेस, स्पेशियस वास्तु कंप्लायंट आणि स्कायलाइट फिल्ड होम्स, तसेच फ्युचर इन्व्हेस्टमेंट साठी प्रीमियम प्लॉट्स, प्रोफेशनल ग्रोथ साठी ऑफिस स्पेसेस आणि मॉडर्न लाईफस्टाईल साठी एलिगंट अपार्टमेंट्स, सिटी कनेक्टिव्हिटी सोबत पण सिटी नॉईज पासून दूर, रिटायर्ड लाईफ, पीसफुल वीकेंड्स किंवा लॉंग टर्म लिव्हिंग साठी परफेक्ट ऍड्रेस। अर्बन रिपब्लिक, लाईफ बिगिन्स हिअर।
छोड़ गई भाई फिर से।
Just right swipe her best friend, yo.
No rules, just cool. Cool bus. छोड़ गई भाई फिर से
Just right swipe her best friend, yo.
No rules, just cool. Cool buzz.
यार सबकी वेके पिक्स आर स्ट्रेट आउट ऑफ अ मूवी और मेरा व्यू ट्रैफिक। फिल्टर लगा के सेल्फी ले, कैप्शन डाल, स्टक बट स्टिल
No rules, just cool. Cool bug.
Satisfaction and growth, we focus on both. Located in the vibrant city of Sangli, the Manan Group of Construction stands true to the definitions of trust, quality and innovation in the field of construction. With a rich history of over 12 years, Manan Group of Construction has consistently set new benchmarks for quality and professionalism in the industry. Established on 11th November 2011, our company insists on a customer-centric approach and focuses on the satisfaction of our customers. Our portfolio encompasses a diverse range of projects, including industrial, residential and commercial work, road construction, special structural shade work and much more. We take immense pride in our ability to deliver our services to the specific needs and as
मेरी कामयाबी के पीछे मेरे परिवार का साथ और उनकी दुआएं रही हैं और रहा है एक स्टार। मेरे किचन का स्टार, स्टार रिफाइंड ऑयल। ये हर तरह की कुकिंग के लिए परफेक्ट है, चाहे डीप फ्राई करना हो या सॉटे। ये फोर्टिफाइड है विद विटामिन ए और डी और इसमें है पूफा और मुफा का सही बैलेंस। ये सिर्फ तेल नहीं, मेरे परिवार का हिस्सा है। स्टार रिफाइंड ऑयल, बरसों का भरोसा अब नई पहचान के साथ।
दिवसभर धावपळ, जबाबदाऱ्या आणि सततचा ताण, कधीतरी मनालाही हवी असते शांततेची एक जागा। अर्बन रिपब्लिक सांगली मिरज जवळ 30 एकरांमध्ये पसरलेलं, निसर्गाशी जोडलेलं प्रीमियम गेटेड कम्युनिटी टाउनशिप, 3 एकर्स लँडस्केप गार्डन, ॲम्फी थिएटर, योगा झोन्स आणि 20+ विचारपूर्वक डिझाईन केलेल्या अमेनिटीज, लक्झुरियस 3 and 4 BHK रो हाऊसेस, स्पेशियस वास्तु कंप्लायंट आणि स्कायलाइट फिल्ड होम्स, तसेच फ्युचर इन्व्हेस्टमेंटसाठी प्रीमियम प्लॉट्स, प्रोफेशनल ग्रोथ साठी ऑफिस स्पेसेस आणि मॉडर्न लाईफस्टाईल साठी एलिगंट अपार्टमेंट्स, सिटी कनेक्टिव्हिटी सोबत पण सिटी नॉईज पासून दूर, रिटायर्ड लाईफ, पीसफुल वीकेंड्स किंवा लॉंग टर्म लिव्हिंग साठी एक परफेक्ट ऍड्रेस। अर्बन रिपब्लिक, लाईफ बिगिन्स हियर।
ग्रेवी आएगा, थिक ग्रेवी में आता है, बोनलेस चिकन रहेगा उसमें जो है ना, तवा आइटम किधर भी नहीं है। ये एक बार ट्राई करके देखो, बढ़िया क्वालिटी है उसकी।
ग्रेवी में मैं आपको तावा ग्रेवी प्रोवाइड करूँगा, टेस्टी रहेगा, मीडियम स्पाइसी चलेगा।
छोड़ गई भाई फिर से
Just right swipe her best friend, yo.
No rules, just cool. Cool bug.
यार सबकी वेके पिक्स आर स्ट्रेट आउट ऑफ अ मूवी और मेरा व्यू ट्रैफिक। फिल्टर लगा के सेल्फी ले, कैप्शन डाल, स्टक बट स्टिल
No rules, just cool. Cool bug.
Satisfaction and growth, we focus on both. Located in the vibrant city of Sangli, the Manan Group of Construction stands true to the definitions of trust, quality and innovation in the field of construction. With a rich history of over 12 years, Manan Group of Construction has consistently set new benchmarks for quality and professionalism in the industry. Established on 11th November 2011, our company insists on a customer-centric approach and focuses on the satisfaction of our customers. Our portfolio encompasses a diverse range of projects, including industrial, residential and commercial work, road construction, special structural shade work and much more. We take immense pride in our ability to deliver our services to the specific needs and aspirations of our clients, ensuring that each project is being executed with utmost precision and attention to detail. From the initial design phase to the final handover, we adhere to the highest industry standards, utilizing cutting-edge technology and the finest materials to create structures that are visually stunning and built to stand the test of the time. With every project we undertake, our dedicated team of professionals strives to bring forth structures that seamlessly blend functionality, aesthetics, and sustainability. The ladder of success that we are climbing up and up every day is because of the concrete support of our exceptional team of architects, engineers, and construction experts who bring their wealth of knowledge and expertise to every project. With their innovative ideas, meticulous planning, and flawless execution, they ensure that each project undertaken by the Manan Group of Construction is a masterpiece in its own right.
आणि अतिशय चांगलं काम या मनन कन्स्ट्रक्शनने केलं. एक गुणवत्तापूर्ण काम आणि दिलेल्या वेळेत काम पूर्ण केलं. त्यामुळे आमचा विस्तारीकरणाचा प्रोजेक्ट एकदम वेळेत निर्माण व्हायला पूर्ण व्हायला मदत झाली.
Every one of our employees is a capable leader, and this makes us feel more responsible for their nourishment. Therefore, we conduct employee engagement activities and programs throughout the year. On the 11th of November every year, we arrange a grand program for our employees, wherein we appreciate the achievers and express our immense gratitude to each and every person who joined our hands to uplift Manan Constructions more than the previous year. We also recognize the importance of fostering strong relationships, may it be with our clients or with our suppliers, subcontractors, professional associates and customers.
मी सिव्हिल इंजिनियर उदय पाटील गेले 1 वर्षापासून मनन कन्स्ट्रक्शन सांगली यांचे मार्फत जे 100 KLPD डिस्टिलरीचे काम देण्यात आलेले आहे ते अतिशय चांगल्या पद्धतीने करत असून त्यांचा अनुभवी स्टाफ व टेक्निकल सुपरविजन या गोष्टी अतिशय चांगल्या आहेत. याचीच गोष्ट ची नोंद मॅनेजमेंटने घेतली असून त्यामुळे त्यांना कारखान्याच्या 7,500 मेट्रिक टन विस्तारवाढी प्रकल्पाची सर्व सिव्हिल कामे ही मनन कन्स्ट्रक्शन सांगली यांना देण्यात आलेली आहेत.
Our dedicated customer support team is always available to address any concerns or queries, ensuring that our clients feel valued and involved at every stage. Framed with the futuristic approach, our mission includes being highly professional in all our deals and thus including the achievement of customer delight. Under the passionate and futuristic leadership of Managing Directors, Mr. Sagar Vadgave and Mr. Sudhir Babar, Manan Group of Constructions is reinforcing its position as builders to the nation.
Secret ingredient in the recipe of a successful company is always discipline. With the discipline, dedication, and the determination, we strive towards the quality outcomes. Our team of the well-experienced managers make our administrations more efficient and effective.
Jai Hind. We at Manan Group focus on creating more and more job opportunities. We keep our working environment happy and care for each and every staff member just like a family member. It is our aim to construct the best quality construction with our excellent team and create more happiness among our customers. And we strongly believe step by step holistic growth of our company. Thank you.
We visualize a world where our structures inspire and contribute to the betterment of society and the environment. Whether you are seeking a residential heaven, a commercial marvel, or an architectural masterpiece, the Manan Group of Construction is the name to trust in. With expertise, commitment to excellence, and passion for innovation, we are here to transform your vision into reality and build a better tomorrow. From foundation to completion, Manan Group of Constructions will serve you with only the best and the most satisfying experience.
मेरी कामयाबी के पीछे मेरे परिवार का साथ और उनकी दुआएं रही हैं और रहा है एक स्टार। मेरे किचन का स्टार, स्टार रिफाइंड ऑयल। ये हर तरह की कुकिंग के लिए परफेक्ट है, चाहे डीप फ्राई करना हो या सॉटे। ये फोर्टिफाइड है विद विटामिन ए और डी और इसमें है पूफा और मुफा का सही बैलेंस। ये सिर्फ तेल नहीं, मेरे परिवार का हिस्सा है। स्टार रिफाइंड ऑयल, बरसों का भरोसा अब नई पहचान के साथ।
दिवसभर धावपळ, जबाबदाऱ्या आणि सततचा ताण, कधीतरी मनालाही हवी असते शांततेची एक जागा। अर्बन रिपब्लिक सांगली मिरज जवळ 30 एकरांमध्ये पसरलेलं निसर्गाशी जोडलेलं प्रीमियम गेटेड कम्युनिटी टाउनशिप, 3 एकर्स लँडस्केप गार्डन, ॲम्फी थिएटर, योगा झोन्स आणि 20+ विचारपूर्वक डिझाईन केलेल्या अमेनिटीज, लक्झुरियस 3 and 4 BHK रो हाऊसेस, स्पेशियस वास्तु कंप्लायंट आणि स्कायलाइट फिल्ड होम्स, तसेच फ्युचर इन्व्हेस्टमेंटसाठी प्रीमियम प्लॉट्स, प्रोफेशनल ग्रोथ साठी ऑफिस स्पेसेस आणि मॉडर्न लाईफस्टाईल साठी एलिगंट अपार्टमेंट्स, सिटी कनेक्टिव्हिटी सोबत पण सिटी नॉईज पासून दूर, रिटायर्ड लाईफ, पीसफुल वीकेंड्स किंवा लॉंग टर्म लिव्हिंग साठी परफेक्ट ऍड्रेस। अर्बन रिपब्लिक, लाईफ बिगिन्स हिअर।
ग्रेवी आएगा, थिक ग्रेवी में आता है, बोनलेस चिकन रहेगा उसमें जो है ना तवा आइटम किधर भी नहीं है। ये एक बार ट्राई करके देखो, बढ़िया क्वालिटी है उसकी।
ग्रेवी में मैं आपको तावा ग्रेवी प्रोवाइड करूँगा, टेस्टी रहेगा, मीडियम स्पाइसी चलेगा।
छोड़ गई भाई फिर से
Just right swipe her best friend, yo.
No rules, just cool. Cool bird.
यार सबकी वेके पिक्स आर स्ट्रेट आउट ऑफ अ मूवी और मेरा व्यू ट्रैफिक। फिल्टर लगा के सेल्फी ले, कैप्शन डाल, स्टक बट स्टिल
No rules, just cool. Cool bird.
Satisfaction and growth, we focus on both. Located in the vibrant city of Sangli, the Manan Group of Construction stands true to the definitions of trust, quality and innovation in the field of construction. With a rich history of over 12 years, Manan Group of Construction has consistently set new benchmarks for quality and professionalism in the industry. Established on 11th November 2011, our company insists on a customer-centric approach and focuses on the satisfaction of our customers. Our portfolio encompasses a diverse range of projects, including industrial, residential and commercial work, road construction, special structural shade work and much more. We take immense pride in our ability to deliver our services to the specific needs and aspirations of our clients, ensuring that each project is being executed with utmost precision and attention to detail. From the initial design phase to the final handover, we adhere to the highest industry standards, utilizing cutting-edge technology and the finest materials to create structures that are visually stunning and built to stand the test of the time. With every project we undertake, our dedicated team of professionals strives to bring forth structures that seamlessly blend functionality, aesthetics, and sustainability. The ladder of success that we are climbing up and up every day is because of the concrete support of our exceptional team of architects, engineers, and construction experts who bring their wealth of knowledge and expertise to every project. With their innovative ideas, meticulous planning, and flawless execution, they ensure that each project undertaken by the Manan Group of Construction is a masterpiece in its own right.
आणि अतिशय चांगलं काम या मनन कन्स्ट्रक्शनने केलं. एक गुणवत्तापूर्ण काम आणि दिलेल्या वेळेत काम पूर्ण केलं. त्यामुळं आमचा विस्तारीकरणाचा प्रोजेक्ट एकदम वेळेत निर्माण व्हायला पूर्ण व्हायला मदत झाली.
Every one of our employees is a capable leader, and this makes us feel more responsible for their nourishment. Therefore, we conduct employee engagement activities and programs throughout the year. On the 11th of November every year, we arrange a grand program for our employees, wherein we appreciate the achievers and express our immense gratitude to each and every person who joined our hands to uplift Manan Constructions more than the previous year. We also recognize the importance of fostering strong relationships, may it be with our clients or with our suppliers, subcontractors, professional associates and customers.
मी सिव्हिल इंजिनियर उदय पाटील गेले 1 वर्षापासून मनन कन्स्ट्रक्शन सांगली यांचे मार्फत जे 100 KLPD डिस्टिलरीचे काम देण्यात आलेले आहे ते अतिशय चांगल्या पद्धतीने करत असून त्यांचा अनुभवी स्टाफ व टेक्निकल सुपरविजन या गोष्टी अतिशय चांगल्या आहेत. याचीच गोष्टची नोंद मॅनेजमेंटने घेतली असून त्यामुळे त्यांना कारखान्याच्या 7,500 मेट्रिक टन विस्तारवाढी प्रकल्पाची सर्व सिव्हिल कामे ही मनन कन्स्ट्रक्शन सांगली यांना देण्यात आलेली आहेत.
Our dedicated customer support team is always available to address any concerns or queries, ensuring that our clients feel valued and involved at every stage. Framed with the futuristic approach, our mission includes being highly professional in all our deals and thus including the achievement of customer delight. Under the passionate and futuristic leadership of Managing Directors, Mr. Sagar Vadgave and Mr. Sudhir Babar, Manan Group of Constructions is reinforcing its position as builders to the nation.
Secret ingredient in the recipe of a successful company is always discipline. With the discipline, dedication, and the determination, we strive towards the quality outcomes. Our team of the well-experienced managers make our administrations more efficient and effective.
Jai Hind. We at Manan Group focus on creating more and more job opportunities. We keep our working environment happy and care for each and every staff member just like a family member. It is our aim to construct the best quality construction with our excellent team and create more happiness among our customers. And we strongly believe step by step holistic growth of our company. Thank you.
We visualize a world where our structures inspire and contribute to the betterment of society and the environment. Whether you're seeking a residential heaven, a commercial marvel, or an architectural masterpiece, the Manan Group of Construction is the name to trust in. With expertise, commitment to excellence, and passion for innovation, we are here to transform your vision into reality and build a better tomorrow. From foundation to completion, Manan Group of Constructions will serve you with only the best and the most satisfying experience.
मेरी कामयाबी के पीछे मेरे परिवार का साथ और उनकी दुआएं रही हैं और रहा है एक स्टार, मेरे किचन का स्टार, स्टार रिफाइंड ऑयल। ये हर तरह की कुकिंग के लिए परफेक्ट है, चाहे डीप फ्राई करना हो या सॉटे। ये फोर्टिफाइड है विद विटामिन ए और डी और इसमें है पूफा और मुफा का सही बैलेंस। ये सिर्फ तेल नहीं, मेरे परिवार का हिस्सा है। स्टार रिफाइंड ऑयल, बरसों का भरोसा अब नई पहचान के साथ।
दिवसभर धावपळ, जबाबदाऱ्या आणि सततचा ताण, कधीतरी मनालाही हवी असते शांततेची एक जागा। अर्बन रिपब्लिक सांगली मिरज जवळ 30 एकरांमध्ये पसरलेलं निसर्गाशी जोडलेलं प्रीमियम गेटेड कम्युनिटी टाउनशिप, 3 एकर्स लँडस्केप गार्डन, ॲम्फी थिएटर, योगा झोन्स आणि 20+ विचारपूर्वक डिझाईन केलेल्या अमेनिटीज, लक्झुरियस 3 and 4 BHK रो हाऊसेस, स्पेशियस वास्तु कंप्लायंट आणि स्कायलाइट फिल्ड होम्स, तसेच फ्युचर इन्व्हेस्टमेंटसाठी प्रीमियम प्लॉट्स, प्रोफेशनल ग्रोथ साठी ऑफिस स्पेसेस आणि मॉडर्न लाईफस्टाईल साठी एलिगंट अपार्टमेंट्स, सिटी कनेक्टिव्हिटी सोबत पण सिटी नॉईज पासून दूर, रिटायर्ड लाईफ, पीसफुल वीकेंड्स किंवा लॉंग टर्म लिव्हिंग साठी एक परफेक्ट ऍड्रेस। अर्बन रिपब्लिक, लाईफ बिगिन्स हियर।
ग्रेवी आएगा, थिक ग्रेवी में आता है, बोनलेस चिकन रहेगा उसमें जो है ना तवा आइटम किधर भी नहीं है। ये एक बार ट्राई करके देखो, बढ़िया क्वालिटी है उसकी।
ग्रेवी में मैं आपको तावा ग्रेवी प्रोवाइड करूँगा, टेस्टी रहेगा, मीडियम स्पाइसी चलेगा।
तुझसे GMCM इवेंटला या यानी राडा फिक्स मेडिसिन और म्यूजिक दोनों थोड़ा थोड़ा मिक्स MMC पॉइंट्स फर्स्ट टाइम 2+6 यानी टोटल 8 दिस इज STETHOBEATZ 26 22 फेब से 28 फेब तक स्किल लैब से लेके कॉन्सर्ट वाले स्टेज तक हाइप ये बनेंगे न्यूज़पेपर वाले पेज तक याद ये रहेगा तुझे तेरे लास्ट डेज तक पॉजिटिविटी लाइक कैथोड वर्कशॉप से सीख ऐसा मौका अब तू ना छोड़ डेलीगेट पास ले ले सिक्योरिटी ना तोड़ हाउसफुल शो क्योंकि आने वाला संजू राठौड़ बस एक हफ्ता रख ले खुद को बिजी सीखने मिलेगा चाहे यूजी हो या पीजी फ्यूचरिंग कास्टिंग BLS CG वर्कशॉप में आजा फिर लगेगा सब कुछ इजी MEDICIENCIA X STETHOBEATZ GMCH Miraj full elite MEDICIENCIA X STETHOBEATZ heartbeat ये मेरी बोले break the heat MEDICIENCIA X STETHOBEATZ GMCH Miraj full elite MEDICIENCIA X STETHOBEATZ heartbeat ये मेरी बोले bring the heat
छोड़ गई भाई फिर से छोड़ गई
GMCM इवेंटला या यानी राडा फिक्स मेडिसिन और म्यूजिक दोनों थोड़ा थोड़ा मिक्स MMC पॉइंट्स फर्स्ट टाइम 2+6 यानी टोटल 8 दिस इज STETHOBEATZ 26 22 फेब से 28 फेब तक स्किल लैब से लेके कॉन्सर्ट वाले स्टेज तक हाइप ये बनेंगे न्यूज़पेपर वाले पेज तक याद ये रहेगा तुझे तेरे लास्ट डेज तक पॉजिटिविटी लाइक कैथोड वर्कशॉप से सीख ऐसा मौका अब तू ना छोड़ डेलीगेट पास ले ले सिक्योरिटी ना तोड़ हाउसफुल शो क्योंकि आने वाला संजू राठौड़ बस एक हफ्ता रख ले खुद को बिजी सीखने मिलेगा चाहे यूजी हो या पीजी फ्यूचरिंग कास्टिंग BLS CG वर्कशॉप में आजा फिर लगेगा सब कुछ इजी MEDICIENCIA X STETHOBEATZ GMCH Miraj full elite MEDICIENCIA X STETHOBEATZ heartbeat ये मेरी बोले break the heat MEDICIENCIA X STETHOBEATZ GMCH Miraj full elite MEDICIENCIA X STETHOBEATZ heartbeat ये मेरी बोले bring the heat
छोड़ गई भाई फिर से
Just right swipe her best friend, yo.
नो रूल्स जस्ट कूल बर्ड
यार सबकी वेके पिक्स स्ट्रेट आउट ऑफ अ मूवी और मेरा व्यू ट्रैफिक फिल्टर लगा के सेल्फी ले कैप्शन डाल
कुठेपर्यंत म्हणणार आहेस तू सांग फक्त मला.
टेस्टेशनचं तू घेतो का पौरुष? माझ्याकडून नाही जमणार आहे. हे बघ, हे आपण अल्टरनेट बोललो. मी पण म्हणते डायग्नोस्टिक, हे पण अल्टरनेट बोललो, बट कॅन मशीन होईल. त्यानंतर तू म्हण कॅन अल्गोरिदम हे, परत मी म्हणते कॅन हे, आणि परत इथून
नाही ते सगळं कर मग तू सगळं म्हण.
अरे हे
मी डायरेक्ट
डायग्नोस्टिक म्हणले ना मी की बट वी आस्क कॅन तू फक्त एवढंच म्हण पौरुष, फक्त
मी
एवढी
तिने पण म्हणतो बघ म्हणायचं.
नाही अल्टरनेट म्हणायचं. तू फक्त एवढं म्हण कॅन अल्गोरिदम आणि इथून ईज पासून कंटिन्यू
का पिच बदलते अगं सांगले स्टार्ट कर.
Good afternoon, everyone. Respected dignitaries, esteemed doctors, and future torchbearers healthcares. We now step into a conversion that could redefine the very soul of medicine, a battlefield of brilliance, a dialogue of disruption, a moment where the future confronts the present. AI versus medicine. Today, machines can analyze millions of data points in seconds. They can predict diseases, assist surgeries, and transfer diagnostics. But we ask, can a machine hold a patient's trembling hand? Can an algorithm understand fear in mother's eyes? Or can code replace compassion? Is artificial intelligence the next evolution in healthcare?
Or does the heart of medicine still beat in human empathy, experience, and ethics? This is not just a panel discussion. It is a clash of perspectives, a fusion of innovation and intuition, a glimpse into the future that awaits us all.
Prepare for ideas that challenge, arguments that ignite, and insights that inspire. Because now we don't just discuss the future, we witness it being shaped. I now request our respected moderators and esteemed panelists to kindly come forward and take their places on the dais.
Dr. Rajendra Bhagwat sir, Dr. Ravi Rawal sir, Dr. Yogesh Wagh sir, Dr. Anant Patil sir, Dr. Suresh Patil sir, Dr. Vaibhav Bhingardeve sir. I now request our organizing secretaries Pranav Kanap and Rachna Salvi to felicitate Dr. Rajendra Bhagwat sir, HOD of Medicine Department. I now request Sonvedi and Om Shri to felicitate Dr. Ravi Rawal sir, HOD of OPGI Department. I now request Jagdish Pawle and Atharva Jadhav to felicitate Dr. Yogesh Wagh sir, HOD of Respiratory Medicine Department.
I welcome Dr. Ravi Rawal sir, HOD of OPGI Department, and I now request Sonvedi and Om Shri to felicitate Dr. Ravi Rawal sir, HOD of OPGI Department.
Now I request Sadia and Shruti to felicitate Dr. Yogesh Wagh sir, HOD of Respiratory Medicine. Now I request Prathamesh Gangatire and Aditya Varve to felicitate Dr. Anant Patil sir, Professor of Pharmacology from D.Y. Patil Medical College, Navi Mumbai. Now I request Yash Ambore and Saloni to felicitate Dr. Vaibhav Bingardeve sir, Professor of Department of Radiology, GMCH. The stage is set, the question is powerful, the minds are ready. With great honor, I now hand over the mic to our moderator to lead this future-defining conversation.
शासकीय वैद्यकीय महाविद्यालय मिरज रुग्णालय सांगली या संस्थेतील सर्व विद्यार्थी, सर्व पदव्युत्तर विद्यार्थी आणि या कार्यक्रमासाठी उपस्थित असलेले सर्व अध्यापक, याशिवाय आजच्या या पॅनेल डिस्कशनसाठी मुद्दाम मुंबईहून आलेले डॉक्टर आनंद पाटील आणि डॉक्टर रावळ सर, डॉक्टर भिंगारदिवे सर, डॉक्टर योगेश, the other day it was Mahashivratri, and one of the teenage boy, उसकी मम्मी ने उसको जो साबूदाना खिचड़ी बहुत अच्छी लगती है वो दी, उसने खाई, and then he started fight with his mummy. Mummy, what you have given to me? मम्मी बोली, अरे साबूदाना खिचड़ी है, तुम्हारे ही मैडम ने एनर्जेटिक फूड है, अच्छा है। वो बोला गलत है सब। वो बोला गलत है। ये देखो इसमें क्या लिखा है, ऑल फेक एंड ब्लैंक कैलोरीज, वनस्पति हाइड्रोजनेटेड ऑयल, नो न्यूट्रिएंट वैल्यू। ये सब कहाँ से आ गया? AI has entered in our household, AI has entered in teenagers world. All of you are MBBS or postgraduate students. You might have learned that there is a system of mentor. You all may be having one mentor. So what is mentor? He is actually a parent. You have your own parents. Once you enter a medical college, you have another mentor. Last month, there was a big survey nationwide. What that survey was telling, that undergraduate students of all the big metropolis cities in our country, they are practically invaded by AI. Means they are taking help of AI in their day-to-day work, day-to-day problems, day-to-day health problems. And at the end, that survey says that AI has become another parent for this generation. So AI has become your another parent. What does it signify? This signifies that it is a time which has come that all of us should see at it seriously. It was John McCarthy in 1956, see 60 years back, he had introduced the word artificial intelligence. What does it mean? It means science and engineering creating intelligent machines. And this intelligent machine is either supervised, not supervised, or semi-supervised by human beings. And in October 22, the real revolution started when generative pre-trained transformer was introduced. That is called GPT. It is generative pre-trained transformer. And as far as our area is concerned, it was the diabetic retinopathy which was first thought of usefulness of AI in diabetic retinopathy, then in certain skin malignancies, even in cardiac MRIs, CT scans where pancreatic malignancies were diagnosed without histopathology. Now we go to how it exactly works. Level 0 means no AI, no AI. Standard clinical practice without AI tools. That's what we are doing at present. Full decision-making authority is human being. Level 1, AI has role of suggestions, and clinicians, whether it is a physician, surgeon, orthopedic, OBGY, anybody, he tries to note it, he tries to understand it, but the decision again is with human being. Now stage 2, AI decides under our supervision. AI takes now decision, but under our supervision. So human interference is there. Again, control of the system is in human beings. And now stage 4, stage 3, where AI decides no supervision, there is a backup from our side. Means if anything goes wrong seriously, then we can intervene. But the final authority, final decision making is by AI. And the stage 4, AI decides everything, no human backup, no supervision, all 100% role is of AI. Now, how does it work? Rules we have framed, and the machine facilitates knowledge by using statistics and probability. But rules we have made. Now, for all of your interest, what is exactly in 2025, what has happened? Because that is the last year. One app has come, the name of that app is Cure. It has diagnosed respiratory, neurological imaging, and you will be surprised to note that our National Tuberculosis Control Program, where our WAC sir is working, RNTCP program, all the district hospitals in our state where there is no medical college but district hospital is there. There that app was introduced, chest radiographs were taken, they were diagnosed by AI, anti-tuberculosis treatment is given. No radiologist has signed those reports. No radiologist. There is another app, Niramai, where breast malignancies are detected. Edoke Lunit CNS imaging, Anda Health. It gives very primary information where you can ask so many questions and you get lot of answers from out of it. You can just go through it. Sleep quality, heart rate, body temperature monitoring, some provocative reproductive health management, personalized insights. And who are the target users? Women seeking data-driven health management and fertility awareness. So it has reached to that level. Now, does it have very much usefulness? Telemonitoring, diagnosis, disease detection, treatment planning. It can predict the things, it can give you risk factors. And the most important thing, which is drug related, where we are fortunate enough to have a good discussion on by Dr. Anand Patil, which is called drug development, drug discovery, drug delivery, right from manufacturing of the drug to the patient level, how AI takes part. So you now got some good advantages and good pictures of what it can do. But it can have some problems also. Your privacy of your data is lost. This is one of the most important things. There is no security for this in our country at present. It can misdiagnose, it can underdiagnose. Why? Because there are a lot of demographic differences in our country. Suppose in Canada, they have different opinion. And what about the patient's own mind? AI will never give any importance to what patient superpose, not likely to improve. AI will give you multiple answers. But in today's context, are those answers are to be applied to our patients? When we were doing post-graduation in Wanless Hospital 40 years back, there were two schools of thought. One, Dr. C. Thomas, and second, Dr. Sortur. Both are our teachers. Sortur sir used to fight with the patient till last point. Patient may die, patient may not die, survive, but he used to fight till last. And Dr. C. Thomas has a very different approach. He used to give help, his expertise, and he used to say to the halt, now let this old man have natural course of peaceful way. Natural course of peaceful way. Similar situations are there.
I am being offered free insurance, and then they told me that you are a health conscious person. And I said, how do you know this? They said, then when we track your health through your health app, it seems that you have been exercising thoroughly, you have been walking rigorously, and you have been maintaining all your vitals. And then I asked, how do you know all these things? And they said, we have been monitoring your health app. And I asked him, where is this? He said me, it's there in your phone. Till then, even I didn't know that I am being monitored. And how is this possible? It is possible only because of the introduction of somebody who has been monitoring you. Fine. Now this aspect, now it is very necessary for us to remember that somebody is watching us all the time, whether you sleep or not. Even the time you sleep, how much hours you sleep is being monitored by somebody unknown to you. And this is how artificial intelligence has invaded and intruded in our normal lives. And as sir has said in his presentation, that this infringement of, I would say, privacy and the data privacy that is being leaked through all such gadgets which are around us really is a worrisome factor, which I really wanted to come on later. But as this incident just I remembered, so data infringement and privacy of such data is really a worrisome factor. Although all said and done, let us move on to the subject of OBG. As we say, obstetrics and gynecology, AI has really a significant role as far as this subject of OBG is concerned. Let us now make use of AI for the betterment of patient care. As sir has said, let us make use of AI and not allow AI to override, not allow AI to take total control, but for the benefit, how we can make use of this in obstetrics. Yes, definitely, as is been seen that the major threat is for imaging specialties, here also in OBG, prenatal imaging does have a significant role in monitoring the progress of pregnancy. Hence, prenatal screening has become very much vital, not only in diagnosis, but also in management. So nowadays, ultrasound machines have come up, which are AI-enabled machines, AI-powered machines, where screening or even taking frames of an obstetric patient, taking specific sections of the fetus, AI helps in better taking sections. AI helps in advising regarding good frames, good cuts, good sections, whether these are good for assessment, whether these are good for diagnosis. And yes, of course, when you take cut sections through 3D enabled and AI enabled, AI powered machines, they of course help more in better diagnosing, where human error was possible when the quality of imaging in the first generation and second generation machines were there. But now with availability of 3D and much better machine, now which are enabled with 3D, a better diagnosis is possible with such machines. But definitely the visual impressions which have been there from the lower generation machines, definitely nowadays when you get a AI powered machine, diagnosis is definitely going to be much better. So here we can definitely make use of AI enabled machines for better diagnosis of congenital conditions in fetuses. Also in obstetrics, as obstetrics is more about pregnancy, labor, delivery, availability of machines which can monitor labor remotely. See, initial old days when we were residents, we saw our teachers hearing fetal heart sounds with a fetoscope. And I really don't know whether anybody has seen a fetoscope now. I used to see my teachers using fetoscopes, but now my generation started using stethoscopes for hearing fetal heart sounds. May it be antenatally, may it be during labor. But now Now when I see my students, in addition to stethoscopes, my students started making use of Doppler machines, handheld mini Doppler machines for hearing fetal heart sounds. Now, moving ahead, with the use of AI, we can have certain Doppler machines which can be used remotely. Now, with all the data that is being fed into such machines, making use of such data, certain complex fetal variations, fetal heart rate variations can be easily diagnosed. Now, humanly, it is not possible to hear each and every fetal heart sound throughout labor, which spans for say 15 hours, 20 hours and 24 hours. It is really not possible to hear each and every fetal heart rate variation. So stethoscopes then came Dopplers, but remotely when you start feeding data to such machines, fetal heart rate variations could be easily diagnosed, and with available data, where human errors or human incapacitation of not being able to hear fetal heart sounds through each and every minute, such machines can be of help in diagnosing early fetal distress. Number 2, diagnosing fetal acidosis early, and at the same time preventing fetal asphyxia and fetal morbidity after delivery is possible. And really such type of machines are now being used in tertiary centers, although still statistically the difference is not yet been proved to be significant, but such machines are in use, and I really hope that in future fetal distress would be diagnosed early. Also in obstetrics, later on, with the help of such machines, certain other conditions can also be of help, where AI enabled tools are available. Like now we are in an era where we are making use of patient data like ethnicity, age, height, number of pregnancies, and so many other geographical and patient related factors. We use them along with ultrasound findings and put it in a software to come out with certain risk assessment strategies, where we predict that this patient may be a potential candidate who can give birth to certain malformed or congenitally anomalous babies, such as Down syndrome, for the example just to quote for you all to understand. Such predictive analysis can be much more be of strengthening if you use AI enabled data, where more and more when data is being fed to such machines, a more predictive value, a more positive predictive value can be achieved, and a better diagnosis can be made with the help of data that is being fed to such machine. So predictive value in diagnosing certain congenital anomalies in early pregnancies, where termination is easy, termination is safe, can be achieved. We are also hoping much to give better results in obstetrics later on, maybe a decade down the line, where the predictive value of such pregnancies with the help of AI tools can be possible. Many other roles in obstetrics are being devised but still not in use. But definitely in gynecology, also there are many more avenues where AI can definitely help us, like in the world of oncology. As sir has said, oncology is one section where we need to sometimes go invasive to diagnose that it's a malignant thing, not a benign thing. Such invasive procedures such as a peritoneal tap or a biopsy or a invasive procedure that might be required today for diagnosis can be better diagnosed with certain non-invasive techniques in AI, such as we have certain colposcopes that are now being AI enabled. We have certain imaging modalities, may it be again CT or MRI again, can definitely have much more predictive role in diagnosing malignancies than era which was using certain invasive methods for diagnosis, such as a peritoneal tap or a biopsy for diagnosis. Such oncological cases can be better managed with AI enabled machines. Definitely also one of the fields that is being upcoming now is the reproductive medicine. Reproductive medicine is more of a embryology based, where embryologists did have a definite role, and definitely embryologists were ruling this era. But now with the availability and advent of AI enabled machines and microscopes, a better selection of a more viable embryo is nowadays possible because of the accuracy and certain human bias which is always there when you see the history of a patient. Your bias in clinical practice sometimes overrules, but in embryology, where a microscope, initially when a simple microscope, then an electron microscope, but now with NI enabled microscope, selection of embryos which can be much more viable is definitely possible with an AI enabled. And last but not the least, I would say gynecology, yes, definitely, where preventive aspect of oncology comes, as I have said, such screening methods where when we were screening for cancer cervix with pap smears, but now with AI enabled colposcopes and handheld machines, easy availability of such things have made diagnosis in OBG definitely. But although all said and done, AI, and I assure you, sir, that when we are using AI in the field of OB and GY, definitely the level 1 and level 2 can be the one which can be of help to us, because when we deal with patients who are in labor, we need a lot of compassion, empathy, and a human touch, as we need a lot of cooperation from patients being in labor. Definitely AI can be of help until level 1 and 2, yes, but this human touch, until and unless it's there in the field of OBG, things may not be that very easy when we allow AI to overrule us. Many more things are upcoming, but this implication today, in today's world, is definitely going to help us. But definitely there are certain worrisome things like data breach and privacy, security of the data which we feed to the AI machines to get a proper, these algorithms might sometimes go wrong. Instead of assisting, we can sometimes overdiagnose, and that risk is definitely there. So we have to take a very calculated decision, at least when we deal with obstetric patient. Thank you.
Thank you, sir. From this audience, I have one or two points to ask you, and you will be in a better position to tell. All of you know that medical termination of pregnancy and sex determination are controversial all throughout the world. You may not be aware or not. In European countries, in States of America, and in Scandinavian countries, MTP and sex determination laws are entirely different than our country. They are totally different. So, Rawal sir, can you imagine a situation where AI will interfere, particularly in the treatment of medical termination of pregnancy, uses of drugs, hormones, or whether in sex determination, AI will have some different role to play with?
Definitely, sir. As in such countries, there are no definite governing laws. Patients are encouraged and they are told the sex of the fetus right in the 5th month or 6th month of pregnancy, so that they can come up with certain ideas for personalized care in European and American as well as Latin American countries. But the law, due to the sex ratio infringement is different in our country. Yes, with better imaging, sex determination can be much more earlier possible with such machines, and which may be definitely of help, in certain X-linked diseases where you need the diagnosis of sex, where today we have to go for invasive procedures like amniocentesis or chorionic villus sampling to determine the sex. Because in certain X-linked diseases, in previous babies, you need to terminate pregnancies with specific gender. In such cases, AI is definitely going to help us to diagnose the sex of the fetus early so as to be able to terminate the pregnancy early. Even the PCPNDT law allows under certain clauses to determine the sex, and in these situations, it is definitely going to be of definite help. As far as countries, third world countries and India is concerned, such AI-enabled machines are now coming up, which are definitely going us to enable us to diagnose the sex of the fetus early. Other than this, I don't think there is any other use. Yes, nowadays, where we come across evolving anomalies, everybody must be aware that the government of Maharashtra has formed medical boards for termination of pregnancies which are beyond 24 weeks of gestation. Why this scenario arises? Because termination of pregnancy becomes necessary in non-viable fetal anomalies which are diagnosed late. Why these are diagnosed late? Because of evolving anomalies which evolve as the pregnancy progresses. May it be after 20 weeks, such as certain gut anomalies and certain cardiac anomalies which are better visualized and better diagnosed in the later half of pregnancy. Hence, this law has come up and government has formed medical boards. But with now AI-enabled machines, this can be diagnosed in a earlier gestation age where termination of pregnancy is much more safe.
Any questions from your side? I request Dr. Anand Patil to have his opinion. Drug and drug-related laws also. Side effects and other problems of drugs, where AI will be playing role.
Yeah. So thank you so much for the tone that you have set up, and also Professor of Gynae gave us a background about how AI would be useful in gynecology. I'll give you the perspective of pharmacology, but before I give the perspective, let me compliment and congratulate you for deciding this topic. The reason why, because recently in Delhi, we had this meeting of AI Impact, India AI Impact. And with this background, we are holding a 2-hour symposium. That's a commendable. Secondly, in medical education, I don't know how many of you know, yesterday, the National Board of Education, especially for medical sciences, they hold a Guinness Book of Record. They were trying to hold a Guinness Book of Record because the AI also is coming in medical education. So all teachers in all throughout India, they were asked to register and they were given a specific code so that we all go into Guinness Book of World Record. So this becomes very important milestone for us. Now coming back to the use of AI in pharmacology, and I think we are the most important ones and we are the most evolved ones for using AI in medicine. The reason being, everybody knows, those who are past second year, the drug, when it comes into the market, it takes about 15 years. And these 15 years are divided into laboratory research, animal research, clinical research, then we have post-marketing surveillance. Now, if 15 years somebody has to spend, is quite a significant amount of time. And most of the times, the first phase is about how to screen the molecules. And we all know that if 10 to 15,000 molecules are screened, one molecule comes onto the market after 15 years. Now, with the use of AI, with the availability of the drug molecules and the libraries, this process can be significantly cut short. The second thing would be, suppose now I have so many molecules and I have to maybe modify a structure, which is called as a structure-activity relationship. Just slightly modifying which chemical is going to help me in improving efficacy, which chemical is going to help me in improving safety. Their AI is going to play a significant role, and which is already been playing a role. Then comes the phase of clinical research. Now in the clinical research, we have phase 1, phase 2 and up to phase 3. Then the drug comes from the market. Now right from selecting the sites for clinical trial, which investigator is doing good, who can finish the trial early because they have the data sets of all the clinicians who have worked in this field. So they can predict which site can give you a maximum number of patients. Similarly, especially for the diseases which are rare in condition, now getting a specific person for the participant in the clinical trial, we have 10, 15 inclusion criteria. Now when you have the database of patients, you can easily predict this site can give me this particular patient who is eligible to for all these criteria. Because it's all machine learning that can be used for selecting the right patient population. Then when the drug is marketed, one of the most important thing is because the RCTs are done in a very controlled manner. And the rare side effect, the food-drug interaction, maybe drug-drug interactions, they are most of the times missed in the clinical trials because they are very short period trials. Now AI is playing a significant role in finding those drug-drug interaction, drug-food interaction because of the pharmacovigilance. Signal detection has been fantastically be used by the European agencies, the FDA and even the DCGI. So every now and then we get the alert, this medication is responsible for this adverse event, so use this carefully, and this is all the thanks to AI. Now coming to these concerns that were raised, one of the concerns that was raised was the data safety, data security. Again, I don't know how many of you know, Government of India has come up with a law which is called as the DPDP Act. DPDP Act 2025 has been released and hopefully it will be implemented soon. DP stands for Digital Personal Data Protection. Now under these clauses, there would be some policies which will soon be released and we'll come to know because we are following the Western path and data privacy has been already been discussed and that will be taken care by the DPDP Act. Now coming to certain things which are maybe how ethically and responsibly we can use AI, because the Siri and Alexa already have entered the houses and we are already been using AI. Now the question is, who should AI use us or we should use AI is the question. AI is already using us, so better that we also start using AI but use it ethically. And I think if you have the reform called as the REST form, R stands for there should be regulations, how to use AI, when, where and how. So R component will be taken care. E would be ethical. So we have to be very responsible when you are using the AI, whether you are using in radiology or gynecology or pharmacology. Ethics becomes very important. It should be used scientifically and it should be solution driven. It should not be used for the sake of using it. And finally, sir was talking about the trustworthiness. So REST is the regulations, ethics, scientific, solution oriented and trustworthy. Now just to give you a background, what is meaning, sir was talking about the reliability and trustworthiness. Now I'll give you an example, simple example. Suppose you have a weighing machine and you have weight of 80 kg. And every time you measure the weight, the machine says weight is 60 kg, but your weight is 80 kg. So we can say that machine is reliable, but machine is not valid. Now for AI also has to follow the same thing. AI has to be reliable also and AI has to be valid also. Now to make this reliability and validity, we have to train the AI so much that keep feeding the data. Again, sir was talking about the geographical differences. So do we have that much of data coming from India so that we can blindly trust the AI? So it's going to be there and we have to make use ethically and rationally and will be there as US and Europe. So these are my views on the drugs. Thank you.
Thank you, sir. One small question AI generated drug candidates. You have, so I think these boys and students should be very much interested to know what is exactly meaning of this particular thing. And all of you, sir has, in the initial part of his discussion, he has indirectly told you that in your examination, theory examination, there will be 100% at least a small note on AI. Because he was talking about National Board of Syllabus and Examination and all those things. There is a central body in Delhi which is at present discussing the why NEET score of PG from -40 was brought to this and that. So be prepared with this, and all these sirs are paper setters in your university exam.
Just to complement to what you're saying, sir. Yesterday there was a news in the newspaper. IIT Nagpur now is using AI for paper evaluation also, because there might be a bias. If I give marks versus if sir checks the paper, if the AI is fed with certain keywords, the biasness might be removed, and IIT Nagpur is going to start this use of AI for paper evaluation. So now again, AI generated drug basically making use of AI, and there are regulations from the FDA where the AI can be used, because AI is not just the drug development, it can be even for monitoring. There is something called as the IoT. IoT stands for Internet of Things. So we have the variables, and sir was giving example that when he got a call, this is basically the variables that we are going to, this is called as the IoT. So FDA has specific rules where AI can be used and where AI cannot be used. So there cannot be completely AI generated medicine. AI can help you for screening the molecules, giving you the best option, this possibly the molecule which can go into lead compound very quickly. But as of now, we have to follow the same steps of phase 1, phase 2, phase 3 preclinical research.
Side, sirs. One more question. How should academia, industry and regulators means state government, central government, all those regulatory bodies, law, collaborate to accelerate a responsible AI-driven drug discovery?
Yeah, I think this is a very important question, because AI cannot be used in silos. If I am using AI, the regulator also should be aware about that particular process. The clinician also should be aware, and there should be basically a regulation. And before we go to regulation, unfortunately, we are still illiterate about the use of AI. AI is using more us than we are using AI. So what is important is to educate the clinicians, the researchers on the data literacy. The basic important thing that is required is use of statistics and use of data. So once this literacy is made aware among the clinicians and the stakeholders, then we can go to, because pharma and regulators, they already are ready. Pharma is much more ready than the regulators and the clinicians. So we are very behind. So we have to take an initiative. Unless we have structured programs which are given to the clinicians to understand the use of AI, and then pharma can invest an amount of money. Regulators are okay to take the leads, but are we ready? And once we have the policies in place, then AI would be there, because at certain places this AI has already been used. But to make it a mass scale, I think awareness is still lacking.
Thank you, sir. Now, OBGY and Sir Rawal sir has also discussed some surgical aspects of this. Now I introduce Dr. Yogesh Wagh, who is a physician, pulmonary medicine and tuberculosis, to take part in this. This is his field, is equally important in this AI because the imaging techniques and respiratory medicine, they run hand in hand. So if you consider that aspect, I think Dr. Yogesh Wagh will have a better say in all these things.
Very good afternoon, all of you. I think Bhagwat sir has already given us a very nice presentation, and all my panelists, senior panelists, has discussed everything regarding why the AI is good and what are the bad things you can have about the AI. So Bhagwat sir has already told you can take AI as your assistant. Why I am telling? Because you will lose your thinking power. If you use AI at least for 2-3 years, if suppose anyone message you, good morning, you will ask AI, what should I reply? So this is I'm really, everyone is asking, if you want to, for anything letter you want to give to the office, you are just timing, kindly give me letter and subject. The letter will come. Nothing, you are not using your brain. So this is the most important, and I can assure you the practice makes man perfect. After my PG, these are after finishing my PG, whatever I am doing in government medical college, individually, that was my experience, and that experience I build up. So that experience matters. Okay, I will give you one example that one of the patient was there, which was referred from one chest physician to me, that his breathlessness was not going on, and he might be having MDR tuberculosis. He was having cavity also. So he was just 25. He is just 25-year-old, and his breathlessness was unexplained. He was having X-rays, mild pleural effusion was there on the right side, and saturation was 92-94. So as per clinically, I thought yes, his previous 2D echo was normal, and all other parameters was normal. So I thought something is missing. I did the pleural tapping. Despite the patient is breathless, and so I thought something is there which I am missing. So I did his D-dimer test. So D-dimer came out to be positive. After D-dimer came positive, I do what will be the next investigation we should do. I did his CT pulmonary angiography, and in his CT pulmonary angiography, there was a segmental and subsegmental, acute to chronic subsegmental thrombosis was there. So I thrombolized him. After thrombolysis, after giving the loading dose of streptokinase, after giving him maintenance, he was having giddiness. So first thing I thought was he might be having gastritis, but his giddiness was increased. So foremost thing is that the patient might have an intracranial bleed. So I stop it immediately, and there is ongoing thrombolysis because previously I already given him a thrombolysis. Patient later on, after 24 hours, he becomes stable, and after that I do not start him on again the streptokinase. I just hold and start him on rivaroxaban 15 mg PD. Patient is all right. What if I continue the treatment? The patient might probably serious, in worst case, the patient might have an intracranial bleed. The patient relatives will take action against me. They might go to the court, and if I suppose I take what you can support of AI, can the court or judge give me that yes, the treatment is streptokinase, give streptokinase loading dose, and then followed by a maintenance dose? It is a clinical judgment that I stop the thrombolysis, and that is the saved. So clinical judgment is the most important. The AI will give you what are the steps, what is the drug, what is the complication, but your clinical judgment is the most important thing. That, and even if you in the court, if you say my clinical judgment says that this is the thing, so you are the boss, you are the expert, you have the expertise. You can't take the any what you can say, support of these apps or everything. Okay. Again, the next important thing is we have in the respiratory field lots of you can say invasive procedures like bronchoscopy, thoracoscopy, endobronchial ultrasound, lots of procedure, pulmonary function test and everything. So this needs expertise, and expertise can do the procedures like this, and practice makes man perfect. So after a clinical or lot more procedures, if you did that, whatever the you can say clinical work after 10 to 15 years, the AI will never do any such kind of procedures. It is the only person or physical person where you can do any. Even our Dean sir is, respected Dean sir is here. I welcome Dean sir. He is a surgeon. Surgery, AI will give you steps, but it is the clinical judgment of the surgeon how I should do a surgery. Understand? Another thing is that AI will never tell you how to see the patient's signs, what are the patient's symptoms. It is your patient and doctor relationship. So AI don't have, Bhagwat sir told, don't have emotions. It is the patient's emotions that you can see and take or evaluate the history of the patient. So history taking is an art. Whatever the patient tells you, and you will come to the diagnosis and give the treatment accordingly. Another thing is whenever any acute condition comes, like patient is having pneumothorax, acute severe exacerbation of asthma, COPD, at that time you have to give the treatment immediately. Another thing is ventilator settings. AI will guide you whether you have how much PEEP to be given as per the body weight, or how much tidal volume to be given to the patient. But what about his patient recruitability? Whether the patient is under sedation, whether the patient is having underlying lung pathology, that is you know. Another thing is that X-ray, whatever the AI currently giving is the Western data. If you give suppose one X-ray, the AI will give you diagnosis like sarcoidosis or anything else which was there in the Western country. Even it might give a tuberculosis, but what about silicosis? So this is the Western data which is more in the AI. So Indian data are, I think, lesser. So you have to think the diseases, the Western diseases are a lot more different and Indian diseases are different. So you have to think clinically, and I think clinical judgment is the supreme, and take the assistant. You should take AI should be your assistant only. That's it. Otherwise, and use your brain only, not the AI brain. Thank you.
Sir, one question before sir could wind up. I have one question. India is a country ridden with poverty, where communicable diseases such as tuberculosis, we have been fighting it for decades now, but still we are into a phase where invasion of technology, may it be CBNAT, may it be anything for diagnosis, with availability of so much more newer drugs available for treatment of multi-drug resistant tuberculosis, where do you see role of AI, where we will be able to reach a stage of eradication of tuberculosis? For both of you.
Okay. I think where AI could be of use, personalized medication. When I say personalized medication, depending upon your whole history. Suppose patient of multiple drug resistant tuberculosis comes to sir. He has such a big file. He has been treated with so many drugs, so many complications, so many maybe comorbidities. So if you have a data to suggest that for this particular category of patient, which would be the right regimen. So if you have that much of a data, probably the machine learning might be able to suggest what drug would be possibly useful for this particular patient. But ultimately judgment will remain with the sir. But AI will certainly help you to at least give options. This drug might be useful and that drug might not be useful.
Nowadays we have drug regimens, and each drug regimen has a major side effects. And that side effects we have to deal, and according to that we have to replace that drugs. If suppose linezolid can cause a peripheral neuropathy, cycloserine induced psychosis is there, even kanamycin, now the drug is we are not using, can cause auditory toxicity. Each and every drug has side effect. So that why there is a difficulty in eradication of tuberculosis, because India is you said already poor socioeconomic class. Other than that, we have lots more diabetes, then spacing in the female, particularly 2-3 years. You can have say that the spacing should be required in between so the spacing is the less. So these are other conditions where the tuberculosis, hidden latent tuberculosis is more.
Quickly add to the comments what his sir was mentioning. Two things. Number one was, should we use the AI for drafting the letters? And I would come with the, rather than no, I would say yes. The reason why I would say yes is because clinicians currently are having an issue of burnout. If I can spare my 15 minutes and have a good nap, if AI can give me a draft letter which is a good quality and well written letter, why should I unnecessarily keep my brain and keep writing it? That's the perspective. Second thing is, in the era of the evidence-based medicine, now if I am maybe concerned, there are two options that I see in this patient, this drug versus this drug. Now I'm left with no concrete answer, which drug should I use? Now I recently attended a seminar by the Wiley publication, and they are coming out with a software called as a cloud-based application. And with this question, whatever has been published in the Cochrane database, all systematic reviews will be analyzed, and you will be given an answer between these two drugs, which is the best drug, because then nobody can question you, because this is based on the evidence, and this is evidence coming from the Cochrane database, which is a completely unbiased database. And they demonstrated that the work manually, if I screen the Cochrane database, I might require 200 days, which can be done in 2 minutes by that software. So here I think AI has a significant role to play.
Yes, even I would like to add a point into this, where today in the era of clinical subjects, where counseling plays a counseling where it plays a major role, now speech to text converters as well as video counseling, where are being used for as consents for surgery, data keeping and writing notes has been replaced with the use of AI, and this help of AI can, I think, really revolutionize data keeping in medicine.
Thank you, sir. Up till now, we have discussed myself, Rawal sir, Patil sir, Wak sir, and we were about to discuss surgery, and the surgeon has arrived. Dr. Guru sir, he is our dean. Welcome, sir. And all of you know sir as a dean of this college, but I know Dr. Guru sir as an excellent gastrointestinal surgeon. I have seen him working in Wanless Hospital, Miraj Rognalay, Sangli Rognalay, all the three areas. So I welcome him. As now sir has arrived, I have a small question for him and opinion from him. AI has invaded our clinical practice. Today only, you might not have read, Noble Hospital Group from Pune, they have introduced a network of robotic surgeries. So I have a small question for sir. How you look to role of robotic surgeries in coming years, and whether it will replace the things or whether it will our conventional work in that way. Sir, please.
Thank you, sir. Basically, I am a surgeon of era where there were lot of open surgeries were there. Our teacher used to teach us, bigger surgeons will take bigger incision. But later on, I am converted myself to the smaller incision and gone to the keyhole incisions or keyhole operations. So there is a lot of revolution has gone in the general surgery lot of minimal access surgeries were there. Laparoscope has came, laparoscope has revolutionized lot many surgeries as far as abdomen is concerned you can do with laparoscopic surgery, gallbladder, appendix, even cancer surgeries also can be done. Right hemicolectomy can be done, left hemicolectomy cannot done. APR can be done easily by laparoscopy and all. Later on, the people they used to go ahead for robotic surgery. Wherever you cannot approach, your approach is not going into that particular field where you can have a robotic surgery. Robotic surgery being very clean cut surgery, the clean surgery you can say, but who is operating robo? Robo is operated by a human brain. Who is operating that particular robotic instruments and all? It is the surgeon who is sitting in the console and operating with his hands. So it is I will say it is a brain assisted surgery robo is doing. Robo itself cannot do any kind of surgery because it is not having a brain. They don't know what to cut. They don't know what to not to cut. And your brain has to decide, this is an artery, this is a vein, this is nerve and all other things. So all these things I will, as per my knowledge, whenever laparoscope has came, we people used to do laparoscopy also, but who is the good laparoscopic surgeon? The person who is a best general surgeon in open can do best laparoscopic surgery. That is my opinion. And who is a robotic surgeon? Robotic surgeon also, I will say, he has to have general surgery knowledge, anatomical knowledge, perfect anatomical knowledge is required. So you have to go to the basic of first year where the anatomy is very, very important subject. As per my knowledge, robo cannot replace human brain. AI cannot replace human brain. As today morning we have listened lot many lectures. I was there and it was a beautiful lecture, orthopedic lecture, you must have been heard, every people. And clinical examination is very important. Clinical diagnosis is important. Once you know the perfect clinical diagnosis, you can operate either by laparoscopy or by robo or by general surgical techniques. Thank you very much.
Thank you, sir. So, sir has also taken a line that AI should be assistant, not our boss. And I hope when you arrange similar functions next year, it should be not AI versus medicine, AI and medicine, so that we don't want any rivalry. And there's nothing like that. Now we come to our last part of AI discussion. It is the radiology which has maximum percentage of work in AI generated GPS systems. So I request Dr. Bhingar Dive to have his own talk or opinion and discuss the few elements which are there. Dr. Bhingar Dive, sir.
Good afternoon, everyone. First of all, I thank the organizing team for inviting me as a person taking discussion. Let us make it a two-way communication. Okay, everybody is using Google. Everything you want, you get. You are using Google. Okay. Today also I use Google and I search for diagnosis. I get images. Okay. First thing which I get in my day-to-day practice, I will see for image, what the image represents. There will be 100 images, 1000 images, there will be few articles, okay? Of that, the one image which is matching with my picture, the one which is on my screen, be it ultrasound, be it an MRI, or be it been a DSA, latest modality which we have received in our college, digital subtraction angiography. First of all, radiology is a image-based science. Radiologists have got a picture-based memory. That's why their cerebellum has got lot of sulci and gyri, because every time a good radiologist, what he will do, he will imagine that image with his brain and memory, that whether it is fitting with that, with whether it is fitting like that, as like surgery, or Wag sir as Rawal sir has told, with their experience, that lot of things they will, how they have approached, how it is changing, it is depending on their vast experience they have gained, and what they are doing, they are using simple similarities which can guide in their treatment. So coming to my role, when my residents also today, when I go to OPDs, our scanning rooms, I ask them some questions. One of the junior or the one standing behind is start using ChatGPT or Google. Okay, he is able to answer my questions for some time. But at the end of the day, or when we are finalizing the report, I will asking what differentials you will want. What differential you want to give to this patient. Have you asked history? Then he stumbles. Okay? That is the point where he has not taken the efforts. He has read in haphazard things. Many times what people are missing in radiology students or residency is proper history taking. Anatomical knowledge is also lacking. So what they see, list of the differentials, how imaging will spread, how it will look, what AI says, what Google says, what article says. I think, Bhagwat sir, what I say, ki it is just gathering information and putting it in front of you. So it is ultimately you have to decide what to pick up from that and what to leave. That will be the most promising. For related to image-based science, that ultrasound, CT, MRI, there will be just comparison of the images. Other important field is, sir as said, fetal interventions, fetal imaging, obstetric imaging. At that time, fetal interventions you have to do. But AI can't replace the fetal imaging. I recently, 1 year ago, I have gone in one big conference, National Conference of Radiology. They have told me, ki, sir, we have interested very good ultrasound AI-based machine. And on the screen only, they were showing one image. It was popping, sir, see what we have made that automatically you can get where are the fibroids. 3-dimensional fibroid picture was coming. So I asked, how do you know that these are fibroids only? Then she kept a mum. Ultimately, you can use that picture, where the fancy things, companies, sorry sir, but marketing. This AI has got a little relation with marketing also. You are supposed to decide up to what point you are going behind them. And if you are not competent with your basics, then you can't even make use of AI. That is the biggest reality. Few days ago, I went for a court call in our institute only. At that time, during discussion with a senior judge, they were telling that, see what AI has telling. It is putting. So court has also started taking references from AI. So it is very important step for you also, for your practice also, to make a chart that what AI can give, what AI is suggesting. One or other day, after 10 years of practice, or some doctor say, sitting in court of law, can have AI go against him, and it can be used as a evidence against him that, see what AI is telling. Our country is going in that fashion. Okay. Ultimately, make your basics powerful and take help of AI. but AI will be your only assistant. You have to do a lot of hard work, and since AI has arrived, your work has more increased. Okay, so be careful while using all these techniques and new modalities. Thank you so much.
Thank you, Vaibhav. In your field nowadays, interventional radiology, and particularly in Tata Memorial Hospital, lot of procedures are being done in interventional radiology as far as malignancies are concerned. So, do you see AI related or AI's role in such situations?
First of all, considering the volume load to Tata or bigger institutes, screening of the cases, important things can be done. For that, it can be used. But ultimately, shortlisting of them, it will not be possible with AI. It can help reduce your burden and unnecessary clutter, but final decision can't be relied. Or even shortlisting also, you have to sit there yourself.
Can interventional radiology has reduced the work of surgery people?
Considering India's large population, I don't think that it has done it. Still, lot of things, lot of cases, lot of surgeries, and we are also dependent on surgery. Surgery also dependent. One thing what I think that taking help of things, chemoembolization of the tumor, reducing the size of the tumor, using the DSA, using cytotoxic drugs, limited scope of time they can help, but I don't think that it can totally replace or like it has reduced the work. Definitely it will not going to happen. Ultimately, radiology is child of surgery only.
With radiology being the most threatened branch by AI, and now as you said, sir, where radiology now being not the most favored, एक विद्यार्थ्यांच्या मनातला प्रश्न विचारतो, should we opt for radiology or not?
At least 10 people should answer this one. I'm on the ground. Please circulate this mic. Nitin? Genuine opinion, okay? I want honest. At least 10. More are more welcome. Few faculties are also sitting. They will also help.
Anyone from? You want to answer? Anyone from this side? You have to just answer. You have to opt for radiology or not.
Come on, answer. I will make you stand. And then you have to answer.
Don't be afraid of Dean, sir. He is coming here as a surgeon.
He is coming as surgeon. Okay. I will start with my friend, Abhay sir. Okay. Please have an opinion.
Hello. Sir, it depends mainly on the interest of that student. Okay. AI and radiology, that may be, according to you, that may be competitive, but whole depends on interest of that student.
Okay. Yes. Yes, madam. Yes.
So, for now, AI has not yet replaced doctors.
So I will definitely be going for forensic radiology for SS.
Good. Very good. Very good answer. Last corner. Last corner. Few people with blazers. One of them, please. नहीं, एक करें.
Now AI cannot replace the doctors totally. So we means doctors are the masters of the AI. So yes, we should definitely opt for radiology.
Very good. Sit.
Now, any questions from your side regarding all the topics and all the people who have contributed to it? माईक मागे द्या.
Good afternoon, sir. How would you define the current role of AI in modern medicine, in your perspective?
Modern medicine.
Yes, sir.
In today's medicine, which we are practicing, patient, sit down. Patient approaches us at two places. One is OPD and second is directly indoor way, that is admitted patient. When the patient is admitted, either in intensive care unit or hospital setup, his clinical examination and vitals are to be stabilized. So in this process, whatever we are doing at present is more than sufficient. Now the patient is coming in OPD for consultation. Here, detailed history. Modern medicine means not only medicine. I have talked in between also that obstetric gynecology, pediatrics and psychiatry, these are the three branches where rapport with patient, doctor and family is the most important thing, and that AI has practically no role to play. So in these three subjects and even in other subjects, detailed history, you will say that AI doesn't know history. AI also knows history. AI has data of millions of history sheets with the AI. But it is not personalized. When the patient comes in front of you, you have eye-to-eye contact, you talk to him, he talks to you, his relatives talks to you, and then you proceed for examination. So, history and opinion forming from history cannot be replaced by any other newer system. That has to be there. Now comes clinical exam. And here I will tell you, AI has already scored in the sense that my age practitioners or my age clinical examinations and newer generation practitioners, newer generation clinical examinations are lagging in clinical examination. I will give you a very interesting example. 2 years back, I have joined this institute with a gap of some years. And on the first day in medical board, I was examining one patient. And you know, in medical board, I need an assistant. Usually a senior resident which has passed just now MD examination. I ask him to see the patient and tell me the findings. When I saw the patient, examined him, I thought this is a good case for cardiology. He had good murmurs, he had abnormal heart sounds, and that my senior resident has missed them. He has not bothered to see that because inspection, palpation, percussion and auscultation, this sequence followed by ECG, followed by echocardiography, followed by so many investigations. This sequence we have lost. To be frank, we have lost. People come to us directly with sonography reports, directly with MRI reports. In neurological examination, many times AI generated MRI reports are not required. Why I will say, I am telling you very confidently, because there are certain conditions like Parkinsonism, they are very common, Parkinson's disease. If you examine the patient in details, if you examine the patient's detailed history and you don't go for MRI, still you can be in a position to diagnose that condition accurately. I am talking the word accurately. And his MRI may turn out to be normal, may turn out to be very minimum basal ganglia or many very minimal extrapyramidal role involvement. So, as far as clinical examination is concerned, there is no substitute for this. But I accept that pathological investigations, radiological investigations will help in the differential diagnosis of a particular case. And here AI have definitely good role. Then comes management. And in management, I have told 4 stages, 0, 1, 2, 3, 4. Out of them, level 2, human being is the top, is the main. So we will always go up to level 2, take the help of AI, but we will not allow him to dominate. I don't know how many of you read English novels, Marathi novels. You should. Medical students, medical undergraduates, medical postgraduates, actually you have got a very good all India merit, because those boys are coming from North India, South India, everywhere. So the literature, novels. Do you know a name called Noel Yua Harari? At least one of you? Yeah. He is the strong antagonist of AI. He has written a novel. He forecast AI will destroy everything. We are not talking about only medical field. Up to atomic wars, he is postulating the things. We will not take part in that. But I will conclude my words with Harare's statement. What he says, a human brain knows that with the knife we can slice out tomato. But if you hand over the knife to AI, one day he will slice your neck to the extent. Thank you.
Good afternoon, sir. My question is, what was your first professional experience with AI in healthcare? Hello? Sir, my question is,
Please repeat your question loudly and clearly.
what was your first professional experience with AI in healthcare?
So I can answer that question. We did a study in 2000 and we published it in one of the PubMed Index journals. We worked on a software called as TBOT, and it was a software for assessing and using the dermatological images. And we put the around 298 images into that software, and that software asked to give us a diagnosis, which is the diagnosis of these 298 images. And then same images, we gave it to dermatologists. And we asked them, you rate the diagnosis of those 298 images. And the observations were there, 3 conditions: alopecia, fungal infections, and eczema. The AI could diagnose as good as the dermatologist. So apart from radiology, I think dermatology also has difficult times because people might already diagnose, and the AI can suggest them treatment also. So that was my personal experience. And then we wrote several articles on skin related. Even we wrote article on the use of AI in the diagnosis of skin cancer. My wife is an engineer. She worked on using AI for predicting diabetes. So we used the machine learning algorithms. We compared the existing algorithm versus the new algorithm, and we could find that the new algorithm that we developed has a little better potential for predicting diabetes based on certain parameters.
On the same note, I would like to add, as we are moving in the next era, is we have been using a lot of algorithms for prediction of outcomes in pregnancy. So technology has been used widely along with ultrasounds and certain patient parameters to predict what would be the outcome in a specific pregnancy. So with the infringement of such things, we have come across many positive reports in patients for genetic anomalies. Hence, pregnancies were terminated, and when retrospectively they were studied with the help of autopsies and certain histopathologies, unnecessary intervention was then indicated and pregnancies were terminated where they should not been terminated, only on the basis of invasion of technology in medicine has reached up to a stage where unnecessary intervention has led to unnecessary terminations, and we don't know when we incorporate AI into this what is going to happen. So it has to be limited until only to the diagnostic stage only.
Thank you, sir.
Good afternoon, sir. Sir, yesterday we had a lecture on cyber psychiatry where sir explained to us the concept of an avatar, where he conducted remote diagnosis and treatment of his patients through his avatar. He was not involved. So my question is that possible with the help of AI, where we diagnose and interact with patients remotely in other specialties of medicine?
I think to an extent it is possible, but again the authenticity and the onus depends upon who is using the AI, because the onus cannot be left to the avatar, because who has used it, that person has to own the responsibility of it. So there are concepts called as a digital twin. So based on my experiences, somebody can utilize my own. For example, if I'm speaking hundreds of conferences, AI can predict what I can speak in next conference. And instead of me being there, my dummy is created there and he is speaking on my behalf, because AI has been trained on my background and everything. So that is possible.
One thing I want, what you are speaking, it be justifiable in court of law will be the biggest challenge. Remember this.
Thank you, sir.
As we conclude with thought-provoking discussion on AI versus medicine, I extend my sincere gratitude to our esteemed panelists for their insightful perspectives and powerful exchange of ideas. A special thanks to our moderator for guiding the engaging conversation with clarity and balance. Now proceeding towards the felicitation, I now request Gnaneshwar Godke and Praveen Kadam to felicitate our Dean, Dr. Prakash Gurov sir.
Now I request Aditya Adsur and Soham Suryavanshi to felicitate Dr. Rajendra Bhagwat sir with token of appreciation.
I now request Rutuja Shinde and Priya Gherade to felicitate Dr. Ravi Rawal sir with the token of appreciation.
Now I request Alok Patil and Amruta Patil to felicitate Dr. Yogesh Wag sir with token of appreciation.
I now request Vaibhav Malage and Rishikesh Tote to felicitate Dr. Anand Patil sir with token of appreciation.
Now I request Atharva Jadhav and Soham Sinha to felicitate Dr. Vaibhav Bhingar Deve sir.
Thank you. Thank you.
Hello.
Hello. Thank you so much all the panelists. That was such an insightful session. Now I request our chairperson, Dr. Ravi Rawal sir, Dr. Ravi Rawal sir, to present on the stage.
Good evening, everyone. As we continue with our theme, the art of medicine, before, now, and beyond, we move to a story that captures the very soul of medical resilience.
If before was about the raw calling of the service and now is about the specialized expertise, then our next speaker represents the beyond, the relentless spirit that pushes a healer to serve even when their own path is clouded by the greatest storms.
It is a profound honor to introduce Dr. Taru Jindal ma'am, an alumna of the prestigious Lokmanya Tilak Medical College and Sion Hospital, Mumbai. Dr. Taru ma'am is an MS in gynecology, a lactation consultant, and the founder and the lead of Vaginismus program.
Her impact has resonated far beyond our borders. In 2019, she was honored as the most inspiring woman of the year at the Global Women Achievers Award. She is also a recipient of the Karmavir Chakra, a noble honor instituted by Indian Confederation of NGOs in the association with the United Nations.
What makes her story truly beyond the ordinary is her incredible personal fortitude. During her mission, even when navigating through health challenge that tested her own endurance, she remained an unwavering pillar of strength. She chose to lead with quiet resilience, never allowing her own struggle to hinder the service to the nation.
But her journey feels less like a CV and more like an inspiring movie. She chose to leave the comfort of the Mumbai for the rugged, underserved landscape of the rural Bihar. Her transformative work in the reviving a district hospital, turning systemic despair into the beacon of the hope, is the chronicled in her moving book, A Doctor's Experiment in the Bihar. And so the topic of the oration is Bombay to Bihar, my journey of the bringing changes to grassroots.
A TEDx speaker and a tireless advocate for rural healthcare, she reminds us that the art of medicine is the art of being a warrior for your patients regardless of the odds. Ladies and gentlemen, now we invite women of the extraordinary grit and grace. Let us welcome Dr. Taru Jindal ma'am.
Hello.
नमस्ते। आज पूरे दिन के टॉक्स के बाद मुझे लगता है थोड़ा सा आप बोर हो गए होंगे, तो मैं क्लिनिकल कुछ नहीं लेने वाली आज। तो आज का टॉपिक थोड़ा पब्लिक हेल्थ से रिलेटेड है। मैं गायनेकोलॉजिस्ट हूँ, मैं बॉम्बे में रहती हूँ और मैं हमेशा बॉम्बे से बाहर निकलना चाहती थी। मैं चाहती थी कि मैं ऐसा कुछ काम करूँ जो हमारे विलेजेस को अफेक्ट करे। तो मैंने साइन हॉस्पिटल से MD कंप्लीट की गायनेकोलॉजी में, और ख़त्म होते साथ उसी महीने मुझे एक प्रोजेक्ट के बारे में पता चला जो बिहार में था और बिहार में जाके काम करना था। तो मुझे लगा, और तभी गैंग्स ऑफ वासेपुर रिलीज़ हुई थी, तो मेरे मम्मी पापा एकदम डर गए। वो गैंग्स ऑफ वासेपुर देख के उनको लगा पता नहीं बिहार में तो सिर्फ एब्डक्शन होता है, रेप होता है, यही होता है। तो मैंने ये देखा था कि बॉम्बे में भी लोगों के बहुत सारे थॉट्स हैं बॉम्बे के बारे में, लेकिन मुझे पता है कि वो एक बहुत सेफ सिटी है। इसीलिए मैंने प्रेजुडिस नहीं रखा और मैं बिहार जाने को तैयार हो गई। तो मेरी जो आज ये छोटी सी स्टोरी है, मैं कोशिश करूँगी जल्दी कवर करूँ क्योंकि आप लोग सुबह से बैठे हैं तो घर जाना चाहते हैं। लेकिन मेरी ये जो 2 साल की बिहार की स्टोरी है, जो मैं सिर्फ 3 महीने के लिए गई थी वहाँ पे, लेकिन मैं वहाँ पे 2 साल रह गई क्योंकि मैं वापस ही नहीं आना चाहती थी। मेरे घर वाले मुझे वापस बुला रहे थे लेकिन मैं वापस ही नहीं आना चाह रही थी। तो मैं आपसे शेयर करना चाहूँगी कि सिर्फ 2 साल में एक 29 इयर्स की लड़की ने वहाँ के लोगों के साथ क्या अचीव किया। ये नहीं चल रहा है, अच्छा। आप मूव कर सकते हैं क्या स्लाइड? ये सेकंड स्लाइड है? ये सेकंड स्लाइड है क्या? ओके ओके। तो आप किसको देख सकते हैं? बिल एंड मिलिंडा गेट्स। आजकल इनके बारे में बहुत कुछ पेपर्स में लिखा जा रहा है, इसलिए मैं उसमें नहीं जाऊंगी। बट उस टाइम पे ही वॉज वेरी इंस्पिरेशनल टू अस, क्योंकि उन्होंने डिसाइड किया था कि मैं इंडिया के रूरल एरियाज़ के हॉस्पिटल्स को बदलूँगा। तो बिल गेट्स ने बहुत सारा पैसा बिहार के डिस्ट्रिक्ट हॉस्पिटल्स को अच्छा करने में लगाया। तो केयर इंडिया और डॉक्टर्स फॉर यू के साथ मिलके उन्होंने प्लान किया कि हम यहाँ के डिस्ट्रिक्ट हॉस्पिटल्स को बदलेंगे, राइट। और उन्होंने बिहार को चूज़ किया क्योंकि बिहार के सबसे ख़राब इंडिकेटर्स थे और बिहार के बारे में हम ऐसे सोचते थे, राइट। तो उन्होंने सोचा कि अगर कहीं काम करना है तो बिहार में काम करना है, और इसके लिए उन्होंने पूरे देश भर से डॉक्टर्स को इनवाइट किया, गायनेकोलॉजिस्ट और एनेस्थेटिस्ट को, कि आप आके बिहार के हॉस्पिटल्स को बदलो, यहाँ के डॉक्टर्स को ट्रेन करो और वहाँ पे अभी भी वर्टिकल सिजेरियंस होते हैं जिसमें वर्टिकल इंसिशन लेते हैं, और वहाँ पे अभी भी स्पाइनल एनेस्थीसिया कोई नहीं देता है क्योंकि किसी को आता नहीं है, तो वो लोग वो क्लोरोफॉर्म देके वो वाला एनेस्थीसिया देते हैं सिजेरियन में, राइट। तो उन्होंने इनवाइट किया डॉक्टर्स को, तो मैं वहाँ पे चली गई और ये ना स्लाइड्स मूव करने में मुझे प्रॉब्लम हो रही है, आप एक कोई भी स्लाइड मूव कर लीजिए। तो ये मेरा पहला दिन है चंपारण में। आप लोग ने चंपारण के बारे में सुना होगा, जहाँ पे गांधी जी का सत्याग्रह शुरू हुआ था, नील सत्याग्रह। ये मेरा पहला दिन है वहाँ के रेलवे प्लेटफॉर्म पे। मुझे बिल्कुल नहीं पता था मेरे साथ वहाँ पे क्या होने वाला है या मैं वहाँ पे क्या देखने वाली हूँ। मुझे लगा डॉक्टर्स को सिजेरियन सिखाने में कौन सी बड़ी बात है, राइट। नेक्स्ट स्लाइड। तो ये मेरा पहला दिन है वहाँ के डिलीवरी रूम में। डिलीवरी रूम के बाहर की फ़ोटो है ये। दुनिया भर का बायोमेडिकल वेस्ट, सिरिंजेस, नीडल्स, प्लेसेंटा वहाँ पे ऐसे ही फेंके हुए थे और उसके ऊपर डॉग्स खा रहे थे उसको। नेक्स्ट स्लाइड। ये वहाँ का ऑपरेशन थिएटर है जिसमें एक ओटी बाबू वहाँ पे बनियान पहन के सिजेरियन कर रहा है। जो गायनाकोलॉजिस्ट है वो तो है ही नहीं वहाँ पे, और मैंने उनसे पूछा आपने ओटी क्लोथ्स क्यों नहीं पहने हैं, तो उन्होंने बोला बहुत गर्मी है। और आप देख सकते हैं कि वो पेशेंट की सास भी ऑपरेशन देख रही है, सब लोग चप्पल पहन के वहाँ खड़े हैं। तो एक ऑपरेशन थिएटर और एक रूटीन रूम के बीच में वहाँ कोई फ़र्क ही नहीं था, राइट। ओके तो जब मैंने ये देखा, और मैं देखती थी कि रोज़ बहुत सारी मैटरनल डेथ्स होती थी, बच्चा और इन्फेंट बेबीज़ की डेथ्स होती थी। जैसे ही बच्चा आता था एम्बू बैग नहीं मिलता था किसी को, अगर एम्बू बैग मिल रहा है तो उनको रिससिटेशन करने को नहीं आ रहा है। एवरी डे आई सॉ मदर्स एंड बेबीज़ डाइंग देयर इन फ्रंट ऑफ मी। मुझे ध्यान है साइन हॉस्पिटल में अगर एक भी मॉर्टेलिटी हो जाती थी तो हम लोगों को वहाँ पे मैटरनल मॉर्टेलिटी की मीट में खड़ा होके आंसर करना पड़ता था, पर यहाँ पे होता ही जा रहा था। और डॉक्टर्स अपने प्राइवेट हॉस्पिटल्स में बैठे थे, दे वर नॉट कमिंग फॉर डिलीवरीज। ये सारी डिलीवरीज वहाँ की दाई करवा रही थी। तो मुझे रियलाइज़ हुआ कि अगर इसे बदलना है तो मुझे उन लोगों के साथ शुरुआत करनी होगी जो यहाँ पे हैं। जो यहाँ पे नहीं है मुझे उनको नहीं देखना है। इसीलिए मुझे वन सेकेंड सॉरी, ये मेरा, तो मैंने डिसाइड किया पहले दिन तो मैंने सोचा मैं यहाँ से चली जाऊँगी, मैं भाग जाऊँगी, मैं नहीं देख सकती है, मैं तो साइन हॉस्पिटल से पढ़ के आई हूँ तो मैं ऐसी जगह काम नहीं करूँगी। लेकिन फिर धीरे धीरे बैठ के मैंने सोचा अगर मैं भी भाग गई तो यहाँ पे हेल्प कौन करेगा, तो जो भी है उसी के साथ काम करना है। तो हमने शुरुआत की, मैंने उस दिन बैठ के नोट्स बनाए और मैंने ये प्लान बनाया कि सबसे पहले रैपो बिल्ड करेंगे। बाहर से आके कोई उंगलियां दिखाता है ना तो अच्छा नहीं लगता है, इसीलिए उनके साथ काम करके रैपो बिल्ड करेंगे। सेकंड, उनको अपने काम से इंस्पायर करेंगे, अपने वर्क एथिक से इंस्पायर करेंगे। और तीसरा, लीड बाय एग्जाम्पल। मैंने सोचा कि ये गांधी जी की जगह है, यहाँ पे सत्याग्रह की शुरुआत हुई थी, तो लेट अस स्टार्ट श्रमदान, जहाँ पे हम अपना लेबर देख के वॉलंटरीली किसी सिस्टम को हेल्प करते हैं। तो मैंने लोगों को बुलाया कि हम ऑपरेशन थिएटर साफ करेंगे। 2 घंटे में हमने सब ऊपर चढ़ के सब जगह के ब्लड के स्टेन्स, ऑपरेशन थिएटर टेबल आप देख सकते हैं। ये ओटी असिस्टेंट है जिसने पहली बार अपने पैसे से एक वाइट पेंट खरीदा और इस ओटी टेबल को पेंट किया, जिसके ऊपर बहुत सारी मक्खियाँ भिन-भिना रही थी। उस दिन मुझे लगा कि रियली चेंज की शुरुआत हुई है कि क्योंकि आज किसी ने गवर्नमेंट की तरफ हाथ ना डाल के अपने साथ काम, मतलब अपने आप काम करना शुरू किया है। फिर हमने इंफ्रास्ट्रक्चर के साथ साथ ट्रेनिंग शुरू की। आप मानेंगे नहीं, ये सारी औरतें लेबर रूम और ओटी में काम करती थी, लेकिन इनको फीटल हार्ट रेट कभी किसी ने लेना नहीं सिखाया था। और आप इमेजिन कर सकते हैं ऐसी कंडीशन में बेबीज़ का क्या हो रहा होगा। तो हमने बहुत बेसिक चीज़ों से शुरू की कि फीटल हार्ट रेट कैसे देखते हैं, पैड्स कैसे बनाते हैं, राइट, क्योंकि उनको पैड्स भी बनाना नहीं आता था और वो औरत की साड़ी फाड़ के उसी को यूज़ कर लेते थे। वहाँ की जो स्वीपर थी वो ज़्यादा से ज़्यादा डिलीवरीज करती थी, लेकिन आज क्योंकि हमने सफाई का काम शुरू किया तो उसने अपना फाइनली सफाई का काम शुरू किया और डिलीवरीज करना बंद किया। वहाँ के जो क्या बोलते हैं उनको, इंफ्रास्ट्रक्चरल इंचार्ज थे, वो बहुत इंस्पायरिंग थे। तो मैंने उनके साथ काम शुरू किया और आप बिलीव नहीं करेंगे ये सारे इंस्ट्रूमेंट्स, कॉर्ड क्लैम्प्स उन्हीं के स्टोर रूम में पड़े थे लेकिन यूज़ नहीं हो रहे थे। तो हमने स्टोर रूम में जाके लिटरली सब जगह हाथ मार के चीज़ों को बाहर निकाला और इन्होंने बोला कि ये चोरी हो जाएंगे इसीलिए हम यूज़ नहीं करते। फिर हमने अकाउंटेबिलिटी फिक्स की, हर शिफ्ट के एंड में हम अकाउंटेबिलिटी फिक्स करते थे, हम खुद रह के सीजर्स को काउंट करते थे और हमने चप्पल मंगाई। वहाँ पे लोग चप्पल भी यूज़ नहीं करते थे क्योंकि उनको लगता था चोरी हो जाएगी, राइट। तो हमने चप्पलों को काट के वहाँ पे रखा ताकि लोगों को पता चले कि ये ओटी की चप्पल है। 3 महीने के अंदर, सिर्फ 3 महीने के अंदर ये जो ऑपरेशन थिएटर ऐसा था वो ऐसा हो गया। और इसके लिए कोई बाहर से नहीं आया था, जो वहाँ की टीम थी उन्होंने ही ये काम किया था। तो मेरे लिए बहुत इंस्पायरिंग था क्योंकि वहाँ के फ्रंट लाइन न्यूज़पेपर्स में फ्रंट पेज में ये फ़ोटो छपी थी, क्योंकि उनके लिए ये सबसे पहली बार था कि उनका जो डिलीवरी का हॉस्पिटल है वहाँ पे स्किल्ड लेबर केयर अवेलेबल है इंस्ट्रूमेंट्स के साथ। जब हमने ये काम किया, कहते हैं ना कि जब तुम रियली कुछ करना चाहते हो पूरी कायनात तुमको हेल्प करती है, तो वहाँ पे उसी महीने एक नए डिस्ट्रिक्ट मजिस्ट्रेट का तबादला हुआ। इनको हम डीएम सिंघम बोलते थे बिकॉज ये इतने डायनामिक थे कि इन्होंने अपनी प्रीवियस पोस्टिंग्स में बहुत सारे बदलाव किए थे। तो मैं जाके सर को उनके कलेक्ट्रेट में मिल के आई। मैंने यही प्रेजेंटेशन जो आपके सामने कर रही हूँ मैंने सर के सामने किया था और मैंने सर को बोला था सर लेट्स गो टू द हॉस्पिटल्स। ये वाली विजिट रात को 12:30 बजे की है, जो सर ने एक तरीके से एकदम से धावा बोल दिया था डिस्ट्रिक्ट हॉस्पिटल पे, और मैं सर को पूरा हॉस्पिटल दिखा रही थी जहाँ पे टाउट्स थे, औरतें ज़मीन पे लेटी हुई थी। तो सर ने सब कुछ देखा। उसके बाद हमने एक प्लान बनाया कि हॉस्पिटल स्टाफ, एनजीओ और डिस्ट्रिक्ट एडमिनिस्ट्रेशन, इन तीनों की मदद से हम एक प्लान बनाएंगे इस हॉस्पिटल को बदलने का। ये हॉस्पिटल मतलब जिसने सत्याग्रह की शुरुआत की थी पूरे देश में, इस जगह ने, मोतिहारी चंपारण, तो वहाँ पे हम हॉस्पिटल का सत्याग्रह शुरू करेंगे। तो हमने तीनों अलग अलग स्टेक होल्डर्स को यूज़ किया और यू वुड नॉट बिलीव, मोदी गवर्नमेंट जब पावर में आई थी तब उन्होंने 2015 में एक कायाकल्प अवार्ड रखा था जिसमें सारे डिस्ट्रिक्ट हॉस्पिटल्स का कंपटीशन स्टेट में करते हैं वो हर साल, और जो सबसे अच्छा है इंफ्रास्ट्रक्चरली उसको कायाकल्प अवार्ड मिलता है। आप बिलीव नहीं करेंगे 2015 और 16 2 साल मोतिहारी डिस्ट्रिक्ट हॉस्पिटल को गवर्नमेंट ऑफ इंडिया से कायाकल्प अवार्ड मिला। ये ऐसा हॉस्पिटल था जहां लोग बोलते थे कि कुछ नहीं हो सकता इस हॉस्पिटल का, यहाँ पे सिर्फ घूसखोरी होगी, यहाँ पे सिर्फ औरतों की डेथ्स होगी। लेकिन ये एक रोल मॉडल हॉस्पिटल आज पूरे बिहार में बन गया है और यहाँ पे ट्रेनिंग्स होती हैं। यहाँ पे अब एक मेडिकल कॉलेज खुल रहा है, तो बहुत सारे बदलाव हुए वहाँ पे। तो मैं तो अभी मेरी ये फर्स्ट जॉब थी आफ्टर एमडी, तो मेरे लिए ये बहुत इंस्पायरिंग था टू सी कि 1 साल के अंदर एक ऐसा हॉस्पिटल जहाँ लोग बोलते थे सब बकवास है, यहाँ कुछ नहीं हो सकता, 100 साल से सब बकवास है, ऐसी जगह पे बदलाव आया और कायाकल्प अवार्ड हुआ। तो मेरे लिए इट वाज अ किक, इट वाज अ बिग किक कि अगर 1 साल में ये हो सकता है तो अगर मैं और बिहार में रहूँगी तो क्या हो सकता है। तो मैं बॉम्बे वापस आई थी, लेकिन फिर मैं वापस बिहार चली गई क्योंकि मेरे अंदर एक नशा हो गया था चेंज का कि देखते हैं और क्या हो सकता है। तो इस बार मैंने एक विलेज को चूज़ किया क्योंकि मैंने देखा कि चलो मैंने इंफ्रास्ट्रक्चर हॉस्पिटल को कैसे बदलते हैं देख लिया था, क्या मैं गाँवों को बदल सकती हूँ। तो ये एक गांव है जिसका नाम है मसाढ़ी। ये मसाढ़ी गांव पटना डिस्ट्रिक्ट में ही है, लिटरली 13 किलोमीटर्स अवे फ्रॉम द सिटी, और वहाँ पे 70% होम डिलीवरीज हो रही थी। सैम और मैम, आपको मालूम है सैम और मैम, severe acute malnutrition or moderate acute malnutrition was more than 60% in the village, right? तो मैं वहाँ पे दाई बनने आई थी। मैं वहाँ मैंने एक ऐसा हॉस्पिटल शुरू किया। ये आप देख सकते हैं, ये एक डोनर ने हमें अपना घर दे दिया था कि आप इसको हॉस्पिटल बनाओ। तो मैंने सबसे मॉडर्न तरीके से हॉस्पिटल कैसे बना सकते हैं आप नीचे देख सकते हैं, जहाँ पे लोग घर पे ज़मीन पे डिलीवरी कर रहे थे उनके लिए मैंने ये बनाया। और क्या हुआ मेरे साथ, 1 महीने तक मेरे हॉस्पिटल में कोई नहीं आया। और मैं फिर जाके उनके साथ रोज़ सुबह ओपीडी के पहले बात करती थी कि आप आ क्यों नहीं रहे हो। तो उन्होंने बोला कि सदियों से औरतें घर पे डिलीवर करती हैं, तो आपकी क्या ज़रूरत है। तब मुझे समझ आया इनको तो मेरी ज़रूरत ही नहीं है, तो ये ज़रूरत कैसे डेवलप करूं। तो ज़रूरत डेवलप करने के लिए हमने सामूहिक गोद भराई का एक प्रोग्राम रखा, जिसमें हमने माताओं को, प्रेग्नेंट औरतों को और उनकी सासों को बुलाया और वहाँ पे हमने खेल मस्ती के साथ, श्रृंगार के साथ, गानों के साथ बीच बीच में एंटीनेटल केयर क्या होती है, और वो हमने खेतों के साथ हमने एग्जाम्पल्स देख के उनको कन्विंस किया कि प्रेगनेंसी केयर क्यों इम्पॉर्टेंट है। और सेम डे हमारे कुछ रजिस्ट्रेशंस हो गए एंड आफ्टर दैट वी हैड आवर फर्स्ट डिलीवरी इन द हॉस्पिटल। और मुझे ये भी पता है कि वो लोग इसके लालच के लिए आए थे। हम लोग ने बच्चे के क्लोथ्स रखे थे तो वो इंसेंटिव के लिए वो लोग आए थे। लेकिन जो भी हो, हमने उनको इतना अच्छा एक्सपीरियंस दिया हॉस्पिटल में कि दे जस्ट वांटेड टू कम एंड बी विद अस इन द हॉस्पिटल। इतना रिस्पेक्ट, इतना प्यार उनको अपने घरों में भी नहीं मिलता था। माल न्यूट्रिशन प्रोग्राम आप दे सकते हैं, ये हमारे विलेज स्क्रीनिंग पोस्ट। और मैं तो गायनेकोलॉजिस्ट, मैंने कभी इन चीज़ों में काम नहीं किया था, लेकिन मैंने रियलाइज़ किया मैं गायनेक बाद में हूँ, मैं डॉक्टर पहले हूँ। तो जो भी कंडीशन मेरे सामने आती है मुझे उसे अटैक करना है। तो आप ये देख सकते हैं सिवियरली मालनरिश्ड बच्चे, इनके सर बड़े हैं और बॉडी बहुत छोटी है, और ये बहुत कॉमन था उस एरिया में। तो हमने एक माल न्यूट्रिशन मैनेजमेंट ऑफ एक्यूट माल न्यूट्रिशन का प्रोग्राम शुरू किया और मुझे बहुत उसमें पढ़ाई करनी पड़ी। ये एक 5 साल की बच्ची है जो अपनी ज़िंदगी में कभी चली भी नहीं थी, कैन यू इमेजिन। और वो हमारे प्रोग्राम में एनरोल हुई। ये सिर्फ 3 महीने के बाद उसकी फ़ोटो है। तो मेरे लिए ये एक बहुत बड़ा किक था कि मेरे ओपीडी में उसने सबसे पहले स्टेप्स लिए। जैसे हम लोग सब यंग थे, हम सबको बच्चे नहीं हुए थे, लेकिन हमारे लिए ये हमारी पहली बच्ची थी जिसको मेहनत करके हमने पहले स्टेप्स दिलवाए थे। ये भी आप देख सकते हैं, दूसरी बच्ची, सिर्फ 5 दिनों में आप फ़र्क देख सकते हैं। 5 दिनों का फ़र्क है ये। अगर हम अच्छी न्यूट्रिशन दें तो सिर्फ हफ्तों में फ़र्क हो सकता है। वहाँ पे वो सारे के सारे किसान थे, लेकिन वो खुद पौष्टिक सब्जियाँ नहीं खाते थे, वो बेच देते बाहर जाके, तो उनको माइक्रोन्यूट्रिएंट डेफिशिएंसीज बहुत थी। तो हमने डिसाइड किया कि हम कम्युनिटी फार्मिंग करेंगे। तो हमने कुछ वेल्दी फार्मर से उनकी ज़मीन ली और हमने बोला हम रोज़ सुबह फार्मिंग करेंगे। तो रोज़ सुबह ओपीडी के पहले हमारी टीम और पूरा गांव मिलके फार्मिंग करता था, और जो भी पालक, मेथी, मूली निकलती थी वो हम अपनी ओपीडी में रखते थे। तो मल्टीविटामिन के साथ हम सब्जियां भी देते थे लोगों को। हमारे पास नर्सेज नहीं थी। हम इतने डीप गांव में थे कि हमारे साथ काम करने को कोई तैयार नहीं था। तो मैंने देखा कि कुछ औरतें जो अपने बच्चों को लेके आती थी ओपीडी में, वो बहुत स्मार्ट थी। तो मैंने उनको बोला तुम नर्स असिस्टेंट बनोगे क्या। तो हमने नर्स असिस्टेंट की ट्रेनिंग शुरू की और वहीं से हमने अपनी नर्सेज क्रिएट की। तो आप ये देख सकते हैं, ये जो लेडी है ये अपनी ही सास का बीपी ले रही है, या ये औरत 4 आदमियों को स्नेक बाइट के ऊपर काउंसलिंग कर रही है। ये बहुत बड़ी बात है, टू सी मेन सिटिंग एंड द वुमन स्टैंडिंग, राइट। और ये हमारे फर्स्ट नर्स असिस्टेंट्स थे। इन्होंने फाइनली आगे जाके जीएनएम और एएनएम की पढ़ाई कर ली है और अब ये फॉर्मल नर्सेज बन गए हैं सारे। नेक्स्ट स्लाइड। नेक्स्ट, अच्छा मुझे ही करना है, सॉरी। कम्युनिटी से कनेक्ट करना बहुत ज़रूरी था, क्योंकि लोग मुझे एक एक्सटर्नल फैक्टर की तरह देख रहे थे कि ये बाल कटी हुई औरत इंग्लिश बोलने वाली कहाँ से आके हमको चीज़ें बता रही है। तो कम्युनिटी से कनेक्ट करने के लिए हमने गोद भराई की, हम इंडिपेंडेंस डे, रिपब्लिक डे के फंक्शंस रखते थे, और मेरा 2 साल वहाँ पे फाइनली कंप्लीट हो गया एंड आई केम बैक टू बॉम्बे क्योंकि मुझे ब्रेन ट्यूमर हो गया। बिहार में रहते रहते मुझे हाइपोथैलेमस ट्यूमर हो गया था और पैन हाइपोपिट्यूटरिज्म हो गया, तो मुझे वापस आना पड़ा। और जब मेरी कीमोथेरेपी चल रही थी तब मैं बिहार के बारे में सोचती थी और मुझे रियलाइज़ हुआ, थैंक गॉड मैं चली गई। अगर मैं इस समय नहीं जाती तो शायद मैं कभी भी नहीं जा पाती। जैसे मेरे में आज वो फिज़िकल स्ट्रेंथ नहीं है कि मैं ये काम आज जाके कर सकूं। तो अगर ऐसा कुछ बहुत डैशिंग काम करना है तो वो इस समय करना होगा जब आपके पास हेल्थ है और दिमाग सिनिकल नहीं हुआ है, राइट? दूसरी चीज़ कहना चाहूँगी कि लोगों को लगता है सोशल सर्विस मतलब ये बहुत पेनफुल होएगा यार, लोग बहुत परेशान करेंगे। नॉट ट्रू, इट इज़ वेरी ब्यूटिफुल एंड हमको रॉक स्टार जैसा फील होता था जब हम वो गांव में घूमते थे। हमको लिटरली लगता था कि हम हीरो हैं किसी एक मूवी में। तो इट इज़ अ स्टोरी ऑफ जॉय एंड आई एम नॉट सेइंग कि आपको पूरी ज़िंदगी गुजारनी है गाँव में। आपको शायद अपनी ज़िंदगी का 1 साल देना है और आप सबको बिहार जाने की भी ज़रूरत नहीं है। आपके आसपास भी बिहार है, आपको उस बिहार को बदलना है और शायद 6 महीने से 1 साल में आप लोग भी वही कर पाएंगे जो हमारी टीम ने कर दिया वहाँ पे। दूसरी चीज़, हमें लगता है रूरल एरियाज़ के लिए पैसे देने हैं। पैसों की, स्कीम्स की कोई कमी नहीं है। हमें चेंज मेकर्स चाहिए, हमें लीडर्स चाहिए। जब मैं वहाँ जाके खड़ी हुई तो सारा बदलाव मैंने नहीं किया, वहीं की टीम के लोगों ने किया, लेकिन क्योंकि मैं खड़ी थी वो मेरे ऊपर देख रहे थे और उन्होंने फिर अपना बेस्ट वर्जन दिखाया, राइट? नेक्स्ट इज़ योर वर्क इज़ योर लेगेसी। आप जो रोज़ कर रहे हो अपने काम के, अपने डेली वर्क में, ये आपकी लेगेसी है। कुछ लोगों की लेगेसी उनके बच्चे होते हैं, कुछ लोगों की लेगेसी उनकी बुक्स होती हैं। मैक्सिमम लोगों की लेगेसी आपका काम है कि आप डेली क्या कर रहे हैं, आप डेली कौन सा बिहार बदल रहे हैं। लास्ट स्लाइड। हाँ, कीमोथेरेपी के दौरान मेरे भैया ने बोला कि ये जो बिहार की स्टोरी है अगर तुम लिखोगी नहीं ना तो ये किसी को पता ही नहीं चलेगा। तो मुझे ध्यान है मेरे जो 12 कीमोज हुई उसके टाइम पे मैंने ये बुक कंप्लीट की और मुझे ये लगा कि मैं भूल जाऊंगी बाद में क्या क्या हुआ है, तो लेट मी राइट डाउन एवरीथिंग एंड आई रोट इट डाउन। मेरी इंग्लिश बुक का नाम है अ डॉक्टर्स एक्सपेरिमेंट्स इन बिहार और उसका मराठी ट्रांसलेशन है हाँ ये मुमकिन है। इस बुक को अभी हमने एक हिंदी मूवी बनाने के लिए राइट्स दिए हैं, तो होपफुली सून इट विल कम आउट एज अ मूवी। तो आज मैं सिर्फ यही कहना चाहूँगी कि आप अपने अंदर के चेंज मेकर को ढूंढिए। बहुत बड़ी चीज़ें नहीं करनी है, अपने आसपास क्या बदलाव हो सकता है, स्पेशली आपके पेशेंट्स की लाइफ्स में, हमें वो देखना है। थैंक यू सो मच। ये बुक अमेज़ॉन पे है, आपको पढ़नी है तो आप ज़रूर पढ़ सकते हैं। थैंक यू।
Now I request our chairperson, Dr. Ravi Rawal sir, to share a few thoughts about it.
Thank you very much for being here today. You have really been an inspiration to all the young budding doctors over here, a real inspiration. And these 2 days, as we conclude these 2 days, I'm very much sure each one of us here is walking out with a flame lit in his mind to do something really, looking at you, a true inspirational story. And I have no words to express your commitment, dedication, and the flame which has been lit in you to live a very magical and inspiring place like Mumbai and go to Bihar. And really, I'm sure words will fall short for the achievement, and thanks for the organizers who have really been instrumental to bring you here and inspire us today.
मैं सिर्फ एक चीज़ कहना चाहती हूँ कि मैंने MBBS के 3rd ईयर से, जब से PSM पढ़ रही थी, मुझे PSM में डिस्टिंक्शन भी मिला था, कि PSM जब से मैं पढ़ रही थी तब से मैंने डिसाइड किया था कि मैं गांव चली जाऊंगी। और उसके बाद और 5-6 साल लगे, और उन 5-6 सालों में मैंने अपने आप को तैयार किया। जब मैं सायन हॉस्पिटल में इमरजेंसी के बाद लोग घर जाते थे सोने के लिए, मैं कैजुअल्टी जाती थी, और कैजुअल्टी में जाके इंट्यूबेशन कैसे करते हैं, एनेस्थीसिया में उस तरफ जाके कैसे एनेस्थीसिया देते हैं, मैंने एनेस्थीसिया, पीडियाट्रिक्स और क्रिटिकल केयर तीनों चीज़ें अपने MD के टाइम पर सीख लिया था, क्योंकि मुझे पता था कि मैं गांव में जाऊंगी तो मुझे हेल्प करने के लिए कोई नहीं होगा। तो अपने आप को, वो बोलते हैं ना शस्त्र, अपने शस्त्र सारे ढूंढ के रखो अभी, राइट।
I would like to invite Dr. Hemant Shintre sir to say few words about it.
Hello. I'm quite honored to be with you on this dais. Actually, I have your book since like 10 years now. And it is in my library. I just wanted to mention this. And we do not need Salman Khan, Amir Khan for us to inspire. We need such heroes who will keep inspiring us by their good work. That's what I wanted to mention for these young budding doctors. We are already inspired, and you be inspired. Thank you. That's what I wanted. I just wanted the autograph of you, ma'am. Yes.
Dr. Ravi Raval sir to present Dr. Tarujindal ma'am with a token of appreciation.
Now I request our hospitality team, Sanju and Ria, to felicitate Dr. Ravi Raval sir.
Thank you ma'am for the truly inspiring session. Your journey reminds us that the art of medicine lies not only in expertise but in courage, resilience and service beyond self. Your story has deeply moved and motivated all of us here today.
We are sincerely grateful for your time, your strength and your guidance. Thank you, ma'am. Now I invite our organizing secretary, Nileshan Srushti, for vote of the thanks.
everyone, respected dignitaries, honorable speakers, respected teachers, and dear delegates. As we come to the end of today's CME session, I would like to express my sincere gratitude to everyone present here.
First of all, I would like to thank our estimated speakers for sharing their valuable knowledge, experience, and their practical insights with us. Your sessions were truly informative and inspiring, and they have helped us understanding the topic in a better way. I would also like to extend heartfelt thanks to our respected dignitaries and teachers constant guidance, encouragement and support. Your presence means a lot to us. A big thank you to all delegates for your active participation, attentiveness and enthusiasm throughout the session. Your involvement made this CME more interactive and meaningful. Thank you all once again for being part of today's academic session.
Now we will be proceeding the debate competition. I kindly request everyone to please remain seated and continue to support and encourage the participation. Thank you.
Check. Hello.
Hello.
hello, 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 hello. Hello. Good evening, everyone. Battle of Brains is the official debate competition of our prestigious academic event MEDICIENCIA, conducted under the banner of STETHOBEATZ.
This intellectual arena brings together some of the brightest undergraduate minds ready to challenge ideas, question perspectives, and defend their stand with logic and conviction.
Today, these young debaters will engage in the thought-provoking discussions on the diverse and relevant topics from the medical field, blending science, ethics, innovation, and critical thinking.
Because medicine is not just about knowledge, it's about perspective. And today, perspective meets passion. Now I request respected moderator and judges to come forward on the stage for felicitation.
Now I request Ashutosh, Head of Debate Committee, and Jagdish to felicitate Dr. Wilson Desai, sir. It is an honor to have with us our moderator, Dr. Wilson Desai, sir, Associate Professor, Department of ENT, GMC Miraj. Known for his vast academic experience and balanced perspective, sir brings clarity, discipline, and insightful guidance to every academic platform he heads.
Now I request Gauri Anuse and Yug Sakshi Jadhav to felicitate Dr. Girish Dhumale, sir. We are privileged to welcome Dr. Girish Dhumale, sir, Professor in the Department of Community Medicine at Bharati Vidyapit. With his profound understanding of public health and analytical approach to societal issues, sir adds depth and broader vision to today's debate.
Now I request Rucha Ahankari and Avantika Mahangre to felicitate Dr. Sanjot Kurne, sir. Sir is Associate Professor in the Department of Surgery at GMC Miraj, known for his sharp clinical judgment and practical wisdom. Sir brings precision, decisiveness, and thoughtful evaluation to this competition.
Now I request all judges to settle down in the front row and I request moderator sir to guide us through the debate.
Hello. Good evening, everybody, and a warm welcome to this debate, which is so far or considered to be the peak, okay, of any event or this special MEDICIENCIA event. Now, I would like to ask all those who are not from Government Medical College Miraj to please stand up. All those who are not from Government Medical College Miraj to please stand up, including the participants for the debate. Let's put our hands together to give them a warm welcome. welcome boys to GMC Miraj. Okay, please sit down. I would like to request you all to please put your hands together for Ashutosh, because it's only he knows at what level I have gone to see that every single detail is actually worked out and planned. Kindly excuse us if we make any mistakes, but they are definitely unintentional. Last year's results, the college who won was actually not Government Medical College Miraj. So I'd like to assure you all that the judgment would always be extremely fair, for which we have two esteemed judges. One is Dr. Dhumale sir, who is a very close friend of mine, my senior from Government Medical College Miraj. Okay, so he's always there to help Government Medical College Miraj. So thank you very much, sir, for accepting this invitation as a judge. Purne sir is one of us, but he's a passionate rider and a driver. Okay, so anybody who does anything besides medicine, as far as me, is the best person to sit in that chair and judge a competition. So thank you very much, sir, for this evening. With this, I would request Ashutosh and the rest to please proceed.
Thank you, sir. Now I request debate head Ashutosh to explain the details about the competition.
Good evening all. Good evening respected moderator sir, and good evening respected judges. Today for this debate competition, that is the battle of brains. After a very thought-provoking sessions, we have come up with 5 topics for this debate, which would be included and given to all the teams to debate on. These topics includes: first, explosion of health information, patient empowerment or clinical confusion. Second, compulsory attendance, professional training or student policing. Third, long resident shifts, clinical necessity or patient risk, simulation-based training, better outcomes, adequate preparation or reduced patient exposure, and investigation over reliance, better outcomes or lost clinical acumen. These debaters will debate on this topic in the screening round, in the semi-final round, and in the final round. Also, there will be a surprise round, which is the surprise for all debater as well as you. Let me guide through the rounds in each debate. Each debates there are 3 rounds. First is opening salvo, in which 2 teams respectively give their opening statements, which would be concluded in 2 minutes. 90-second warning bell will be given to each team, and after 2 minutes a final bell will be given. If they exceed time limit, their mark will be cut. Second is crossfire. Each team will pose the questions for the opposite team. Opposite team will answer the question and give rebuttal and answer a counter question. This question will be related to their topics. Next is Judges' Fury. Our esteemed judges, Dr. Dhumale sir and Dr. Kurne sir, will ask each team the questions and will judge the teams on the basis of the questions asked. Let me guide you through the structure. Our first level is the first stage, that is screening level, in which 6 teams will participate in 3 rounds in 3 debates, and top 3 teams will be qualified. Second is trial by combat, semi-finals, in which 2 teams would be competing in semi-final, before which a surprise round will be taken, and in which one team, which would be a topper of the semi-final round, would be directly proceed to the final. And third is the Iron Throne round, in which the 2 teams, one from semi-final and one from surprise round, will compete, and the team which would be the best will be the winner of this debate competition. Let me remind you on the time limits. For opening statements, you have 2 minutes each. For crossfire round, in the screening level, you have 8 minutes. In semi-final, you have 12 minutes. And in final, you have 15 minutes. In crossfire round, before the time ends, before 1 minute, a bell will be given and all the teams will present their closing statements, and judges' fury round will have no time limit. Regarding rules of this debate, teams must follow the time limit. There will be penalty for exceeding the time limit. Second, there is a leader in each team who will decide who will speak in his team in every turn, in every question, so that the smooth conduction will be done. The debates will be in civilized manner. Participants refrain to use foul words or shouting or anything that creates lack of decorum. Decision of judges and moderator will be final, and use of electronic media and their own notes is allowed, but use of AI platforms will not be tolerated, and it may lead to spot disqualification. So let us begin with our debate.
Thank you, Ashutosh, for all the details. Without any further delay, let's begin what you are eagerly waiting for, the debate. Let's start with the level 1 screening. We begin with the today's first debate. I request Team A and Team B come on the stage and occupy respective places. In Team A, we have Suhana Wagde and Jayant Barnum. And in Team B, we have Apurva Mohite and Mrunmayee Mane. A short introductory clip of topic will be played before, after which the debate will start.
There is explosion of the healthcare information. Patients are digitized through various apps, devices and monitoring technologies. Is this easily available data and technology empowers the patient for a sound decision making, or it creates a clinical confusion due to the hyper-aware patient?
So there will be the first battle. Topic is explosion of health information, patient empowerment or clinical confusion. The team will be in 4 position, that is explosion of health information in patient empowerment, and team B will be in against motion, that is explosion of health information in clinical confusion. So I request team A to start with their opening statement.
Yeah, you are the timekeeper. Yeah. Could you just introduce yourself quickly? Okay, what do you do? What's your name? Which college? And what do you all do? Same here. And then you can start. Your time starts only when you start with your actual introduction.
Hello, good evening. Myself Jayant Barnum, and I am from GMC Miraj. I am a first year student, currently studying.
I am Suhana Wagde. I am also studying in GMC Miraj, and I am also a first year student.
Good evening, everyone. I am Apurva Mohite. I am from batch 2024, and I am from GMC Miraj only.
Good evening, everyone. My name is Mrunmayee Mane. I am from GMC Miraj, and I am in second year.
Good evening, everyone. A generation ago, medicine was paternalistic. The doctor spoke, the patient listened, end of story. The patient today walks in informed, prepared, and ready to engage. That is not a crisis, that is progress. Take the app, Patients Like Me. It has connected millions of patients living with chronic illnesses, from multiple sclerosis to diabetes. Patients don't just share stories, They track symptoms, compare treatment responses, and generate real-world data. In fact, this data has been used in peer-reviewed research and even influenced clinical understanding of disease progression. That is crowdsourced clinical insight. Engaged patients have been shown to have lower hospital readmission rates, better medication adherence, and even lower healthcare costs. Look at the Choosing Wisely campaign in Canada. When patients were educated about long-term benzodiazepine risks, 62% initiated conversations with their physicians and 27% discontinued unnecessary medication after speaking to their doctors as compared to the 5% in the control group. That's not confusion, that's informed action. Consider endometriosis. For decades, women reporting severe pelvic pain were told that it was normal. You're imagining your pain. It can't be that bad. It's part of being a woman. Deal with it. Just take your pain meds and stop whining so much. That is just a handful of the insensitive comments our female patients have had to hear. The average diagnosis delay globally has been 7 to 10 years for endometriosis. It was patient advocacy amplified through social media and online communities that exposed this gender-biased research gap. Research funding increased, clinical guidelines evolved. Information didn't create confusion, it exposed neglect. And here's the truth. An informed patient asks sharper questions. They ask questions they wouldn't have otherwise had the confidence to ask. An engaged patient spots mistakes. That's not confusion, that is evolution. Thank you.
Now I request Team B to start with their opening statement.
Good evening, respected judges, moderator, and all of my peers present here. To begin with, I'd like to quote that half knowledge is more dangerous than having no knowledge at all. To elaborate this, let me remind everyone of a grievous time that we all went through, which is COVID-19 pandemic. During that time, I'm sure we all heard some false information spread on our beloved WhatsApp that COVID-19 is fake, created by pharma companies to generate more profit, or something like COVID-19 can be cured just by doing some morning ritual. But among all of this, there was a claim which was made, which came later but turned out to be more dangerous, that COVID-19 vaccine cannot be trusted. The confusion around the COVID-19 vaccine was just because that internet is a unregulated space. Even now, if I decide that I want to post some blog about a completely ridiculous topic, say that breast cancer is caused by breastfeeding, there is nobody stopping me, or there is nobody who is going to double check information before I post that blog on Blogspot, for example. This misinformation creates a sense of distrust, panic, and anxiety among patients. People start to distrust true information. As we know, breast cancer is not caused by breastfeeding. Then, even simple symptoms, for example, like fever, has been diagnosed, has very grievous diagnosis, like ranging from a migraine to a tumor. This creates a sense of fear in patients. All of this confusion is just because of the fact that internet is an unregulated space. The internet and magazines are also platforms for promotion of marketed esoteric information and unscientific sponsored information.
Now I request both teams to start with the crossfire round. The first rebuttal question will be asked by A team, then it will answered by B team, and a counter question and rebuttal will be asked. So please proceed.
Now, as Team B mentioned, breast cancer. So in 1970s, radical mastectomy was the standard procedure for breast cancer, which could have been treated by less invasive means. Women revealed failure of the system, and wouldn't their condition have improved if they had stayed silent?
I understand that the question you asked referred to the state in the 1970s. So I think what we're talking about is basically overall development in the medical field. What we are trying to say is that there are a lot of false claims on the internet even right now, and not just talking about an urban setup but also in a rural setup where people are more inclined to go to any jhola chhap doctor which is also practicing through these internet medias and blogs. You mentioned that the explosion of information has proved beneficial. How can you ensure that any individual who goes on any platform or any media to search upon these procedures that you mentioned will reach to a correct website and will read correct information? What is the how can you be so sure that he is not going to an unreliable source reading completely false information and believing it?
Did you get the question? Did you get the rebuttal? Please. Could you shorten that question a little bit?
Basically, what I mean to say is, how can you ensure a common man, when he goes onto a media platform and reads an article about something, how can you ensure that that is the correct source and he is not reading something completely untrue?
There are many doctors who are online and they are socially also active and they are degree holders just like us, like MBBS degree holders. You could just search them instead of going for any random person, any doctor. So I would prefer if a common man should have a basic idea of who is an MBBS doctor and who is a normal doctor, like, or is whether the person who is coming and saying in the social media platform, whether he is true or whether whatever has been said by him is actual or not.
That is precisely my question. The topic for the debate is the explosion of health information. So that is exactly my question. The topic for the debate is explosion of health information. So my question was that with so much of health information, how can you ensure? And your answer, which mentioned that a person should be aware, my question was precisely how are you going to make sure that he is aware of the right sources? Because right now 87% of the 87% of
They
the...
got it. You want to say something about the source?
It is true that there are a lot of misleading claims online, as you mentioned in your speech as well. But then there are also a lot of doctors and agencies online that are working really hard to debunk those claims, who are publishing research papers every day for the general public. So it is advisable for the common man to refer to those websites or those doctors instead of other alternate sources that could be dangerous to them. Also, when patients refer online before going for their health appointments, right, they ask better questions. They are more confident. They actively participate in their own decision making, and that is in turn benefiting them only. So that's why we are making the argument that it is better for the patients. They also seek help online from other health support groups, from people who have the same condition as them. So then they feel better about themselves.
Okay, fine. Any other question? This is your turn to throw a question to them.
So as you said about misinformation or the information which is present in social media, is misinformation new or is it just more visible? Like before the internet existed, weren't patients still misinformed just privately?
To counter that question, I'd like to state a fact that a study which was published showed that 55% of the links regarding vaccine danger were inaccurate and still they were debunked and still they were being followed. So this is not a question of whether the information is present, old or new. It is the fact that people go and find that information and believe it. It is possible that people who follow influencers, for example, and there was a case in Kerala where an 18-year-old died due to she followed a high temperature water diet only for 2 months. Which this is a place where people follow blindly people who are publishing misinformation. What can you do right now to ensure that the misinformation can't be present on the internet? Because you can't stop people from believing. There is just misinformation present and people will eventually believe.
Okay. You have a question for them now? It's your turn.
The question is that how will you ensure that the misinformation is not believed by a person? Because however much you make a person aware, the person can still believe that some Ayurvedic treatment is better than antibiotics.
Again, it's coming down to the source. How can you ensure source? So you want to answer that?
With reference to the question also that he posed, and also yes. So you mentioned how we can't control what people believe. It is true that we can't control, but the thing is that used to happen more in the past than it does today. Now that you mentioned vaccine communities, anti-vaccine, right? That is more common in developed countries, if you've noticed, and also developed countries somehow show better patient outcomes than developing countries. So that is a link that we have not studied yet.
Okay. Final comment? In short, final comment?
I'd like to remind the opponent that this study which I took was from National Institution of Health India, which was published recently in 2024 about the Indian people, not of a developed country. It was about India, that people here still believe misinformation. So I'd like to, just to sum up, that misinformation present creates a sense of panic in people. And it can't...
Okay. Last word? Okay. We are coming to the end of this session. That's done with 8 minutes of rebuttal and questions. We now move to the judges.
Now I would ask our respected judges to ask the questions to both the teams.
Can we have that mic, please? Okay, fine. Respected judges, we need to balance these questions between both teams, so we get a fair assessment. Thank you.
Hello. So, for team A, I would like to ask, how will you differentiate between empowerment and misinformation?
Yes, sir. Sir, there are certain apps, like I mentioned in my speech, like Patients Like Me. So the patients who were on that app, right, they claim that 56% of those patients, they felt like they knew more about their health after using the site. 52% felt more informed about their treatment, and 40% felt empowered to ask questions they wouldn't otherwise have asked. So when patients go online and they actively seek information from reputed sites, they are no longer passive recipients of care. Many now learn from others like them, and this brings confident insight into decision making. They no longer blindly believe the doctor. Like now doctors earlier were treated like gods. Like doctor says, patient does. So now patients are questioning the doctors, asking more questions about their treatment, about their disease progression and their symptoms.
That's what, whether it will improve the trust between the patient and doctor or increase confrontation between the doctor and the patient.
Of course, that is going to improve the trust. Like, for example, if we are having a patient with us, like the same disease which we are going through, and someone who is also going through the same disease. So when we meet someone and we get to know about that way of treatment, if the treatment method is similar, then we can also trust the doctor. Like we get a second opinion itself when we go to a second patient or someone who has the same disease. For example, ALS and ADHD. Many people with these diseases are now got together with the help of these social media platforms, especially like the app mentioned, Patients with Me. So Patients Like Me. So basically, this increases the trust between the patient themselves as well as the trust between the patient and the doctor.
what you said, that is between the patients. They have that group, right? That's not the doctor, this one information. And second, this one. What you said that proper websites, okay? There is no definition of proper authenticated website. Google itself, which is the most common search media used, if you type in what is the most common cause for headache, it gives hundreds of causes, out of which one is a brain tumor. Patient comes to you with sir, I have a brain tumor. So you have to sit and
No, of course not, sir.
argue with him. Because internet is in all algorithm. It doesn't have a brain to think.
Do you want them to comment upon that? Because it's a general
Sir.
question that you asked.
So I would like to answer that question. I would like to answer.
You have finished your turn. Let's give them a chance.
Sir, there is no way a common man can actually know a difference unless he is actually trained to know the difference between a WHO website and NHI website and any non-authorized website which is spreading misinformation. Precisely our point, where it is unregulated information, any common man, any jhola chap doctor can publish anything on the internet without anybody objecting or double checking the factual information. So a common man is most likely to be confused when he approaches the internet for any medical advice.
My question is to team A actually. You say that it will empower the patients. Now you tell me what are the different sources from where the patient can be empowered regarding health literacy.
Did you get the question? Is it a common question for both of them?
Yeah.
Can you answer that if you're ready with the answer?
Yes, sir. To prevent misinformation, I think the patient should be going to websites like WHO, NHI, or CDC. Those are the sources which I think would be the most likely places where right information can be spread.
Okay. My second question is to you. How much is the literacy level of India as far as internet is concerned? And then you are always speaking about the people who are using mobile phones, and then you expect that the people should search what problem they have on the internet. And what my colleague Dr. Sanjot said, the very first thing they will Google out, right? Something of that sort. So how much is our literacy rate as far as internet use is concerned? Literacy. I'm not saying they are just scrolling down. So how much is the literacy for that?
So the internet penetration statistics are in rural areas it's 83.3% and in urban areas it is 91.1%.
This is, I am asking you about health literacy. I am not asking you, they are using, see, Google Pay, that doesn't mean that he is this thing. That is totally at the spinal level. Anybody can do that, Google this thing. Even 3-year child can do all those things. I am asking what is the health literacy as far as they are using this for their own self.
Sir, coming to the health related statistics on the internet, it is approximately 40% in the rural areas as opposed to the stark increase in the urban areas of 71% in the areas. So we can expect the urban people to take the help of internet, but in rural areas it is slightly more difficult to get to that point with the population.
Can you tell us from where have you quoted these statistics?
Sir, it is from NHI, National and PubMed.
You want to add anything to this?
Sir, sure, the literacy rate might be low, but the thing is, there are a lot of conditions that when patients come together, whether online, whether offline, there are a lot of conditions that were not discovered in laboratories first. They were recognized in patient communities first. So that exposed a lot of research blind spots when patients did that. It highlighted gender bias gaps forced institutions to revise guidelines and directed funding towards neglected conditions. So even though maybe patients might not be that educated or that literate, but when they did come together, they exposed a lot of blind spots in our research.
My last question to both the teams. How will you bridge the gap between this patient empowerment and clinical confusion?
Sir,
You ready with the answer? Yeah.
sir, only one path I can think of bridging the patient empowerment, clinical confusion is via spreading more awareness that which sources can be trusted. For example, if any common man wants to learn about BLS or about hand hygiene, they should refer to a WHO website instead of any website which pops up first according to the algorithm. So that can be used to bridge the gap.
Do you have anything to
Yes,
say?
sir. Sir, one way to bridge the gap is for our healthcare providers to step up their game. Basically, there's a lot of the young population that are on social media. There's a lot of reels coming on their feed, TikTok videos. So there might be a lot of misleading claims on it. So if we have healthcare providers debunking those claims who are also on those apps, who are working for our vulnerable groups, then that would really bridge the gap for our younger generation.
Okay, I think we have had a fair judgment. I leave it to your best senses. This is the last round, right? So, audience, we have finished with this round. We will know which of them proceed forward a little later when the judges are ready with their marks. So, let's give them a hand up. Thank you.
Thank you, sir.
Thank you.
It was a wonderful debate which set the momentum for our competition. I now request Team C, Neeral Sanklecha and Vedant Vakle, and D, Akhilesh Mupid and Ritesh Guge to come on stage and occupy their position.
Please come. I have just a question. Is it audible at the back? Are we quite clear? Audible? Okay. I request you all to introduce yourself, names, which year, which college, and then proceed.
Good evening. Myself Neeral Sanklecha. I'm from 4th year MBBS, GMC Miraj.
Good evening, everyone. Myself Vedant Vakde. I am final year MBBS student at GMC Miraj.
Good evening, everyone. Myself Ritesh Guge. I am from PMS Uranishwarpur, third year student.
Good evening, everyone. I am Akhilesh Muped. I am from PIMS Uranishwarpur, third year student.
Could you extend that PIMS, please?
Prakash Institute of Medical Science and Research Center, Uranishwarpur.
You can start, please. Yes. Just 1 minute.
Before starting the topic, we would play the introductory clip of topic, and then we will start the battle.
Today, there is increasing trend of using laboratory and radiological investigations. In many outpatients, ordering CTs or USGs is becoming more common. But in search of better outcomes for diagnosis, are the clinicians losing the clinical acumen?
So our topic for this debate is investigation over reliance, better outcomes or lost clinical acumen. So team D will be in the for side, for that is investigation over reliance, better outcomes, and team C will be against side, that is investigation over reliance in lost clinical acumen. So I request team D to start with their opening statement.
Investigation over reliance leads to better outcome. Wide variety of investigations which are performed in day-to-day medical life, for example, in a medical condition like high-grade dysplasia, a precancerous condition, are considered more accurate, more precise, more standardized result as compared to a unassisted, less experienced pathologist. The investigation intervention in the medical procedure has also leads to reduced rate of human misdiagnosis, which can be due to negligence of the doctor or any kind of human error considered or committed by the clinician. The next thing is when we talk about recent pandemic infections like COVID-19. What about this? Over-reliance on investigation has helped us to analyze the large amount of data, which was very tedious and impossible and time-consuming task to be analyzed by a clinician or a doctor. The investigation procedures have given us a particularly more efficient and more proper result in this case, and also requires less time. Next, what about asymptomatic cases? Asymptomatic cases like bloodborne infection, hepatitis B, C, HIV, and also precancerous stages in which early clinical symptoms are not seen. In that case, the general detailed physical examination does not give us the overview about physical examination, does not give us the overview about any kind of signs or symptom. At that time, early diagnosis by intervention of investigation is required so that we can give a proper, more effective, less invasive treatment and a better healthcare. When there will be routine and regular pathology, when there will be routine and regular pathological tests conducted in a population, it can give us idea about origin of a particular disorder, which can lead to a pandemic, and intervention of has lead us to early diagnosis of such condition and from the life-saving hazard. Investigation can also lead to as evidence for a medical negligence case, for as a burden of proof to prove the doctor.
Now I request team C to start with their opening statement.
A pleasant evening, honorable judges, respected moderator sir, and to everyone present here. I, Ms. Neeral Sanklecha, am here to affirm that investigation over reliance has truly led to loss of clinical acumen. Respected panel, while investigations are powerful, over-reliance erodes the very foundation of medicine, that is clinical reasoning. It leads to decline in bedside skills. Studies show that reduced time spent on history and examination. Up to 70 to 80% of diagnosis can be made from history alone. Excessive testing reduces thinking. Also, there are unnecessary tests which cause harm. Overuse leads to false positives too. Harmless incidentalomas are detected which cause anxiety and unnecessary surgeries. CT overuse increases radiation exposure and cancer risk. And the main problem, cost burden. In India, high out-of-pocket expenditure pushes families into poverty. We also have campaigns like Choosing Wisely, which explicitly warn us against unnecessary tests. In India, rural hospitals lack all the advanced machinery. In such settings, clinical skills become crucial. The debate is not investigation versus clinical skill. It is integration versus overdependence. An ideal physician takes thorough history, performs detailed examination, and then orders the target investigations to interpret results in clinical context. Investigation should confirm clinical diagnosis, not replace thinking. Over-reliance creates technicians, not clinicians. Lastly, I would like to conclude by saying it is not anti-investigation, it is anti-overuse. Thank you so much.
Now I request both teams to start with the crossfire round. Team D will ask first question and the round will follow. Team D, for motion.
Yeah, Team D, your question.
Okay. Hello. So my first question is, you mentioned clinical reasoning. There is decreased clinical reasoning. We can use clinical reasoning in cases which show signs and symptoms, right? If there are no signs and symptoms in cases such as asymptomatic diseases, how is it dependent on the doctor to use his clinical ability and then diagnose that patient correctly. I would like to, okay, let's finish the question. Thank you.
So basically, you're asking about asymptomatic cases, right?
Investigations in asymptomatic cases.
See, first of all, if, like, for example, even you have a disease and you don't know about it. So basically you won't even be going to the doctor. Like, there will be some signs, like you mentioned in your speech, like about hepatitis B. Like, the patient will have fever. Like, that will lead him to go to the doctor, right? He won't just go and say that I want to order investigations for hepatitis B. He will have some signs, like, for example, fever. So that will further lead to investigations. It's not just like asymptomatic.
Okay, your question, please.
I would like to ask them, in a country like India, which has one of the highest out-of-pocket expenditure on medical expenditure, so how do you justify a investigation which has low risk, investigation in a low risk patient which has minimal yield, to compare it to a patient which is more, okay, okay, I'll just do it once again. I would like to ask if in a patient which has low risk, you will advise a advanced investigation that will lead them to more depth or more financial crisis for them.
Did you get the question?
Advising a advanced investigation in a low risk patient is particularly related that the doctor has committed a dysfunction in his work, that we will not advise a advanced investigation directly for a low risk. For example, the opponent has say that when the patient will come with a clinical sign and symptoms of fever. Now fever can be of many causes. Now fever can be also a normal fever. It can be also be just by giving paracetamol or any kind of a tablet. But it is a fever of hepatitis B, C, bloodborne infection, which is hazardous, which can be fatal, and that there the intervention of investigations. Over-relying here superior than the clinical signs and symptoms on the investigation procedures, which we will do for the bloodborne infection, give us the early diagnosis. That's we have in the that's we have a concept of lead time, where we can early diagnose diagnose the disorder of the hepatitis B, C, any other symptomatic, and we can get proper care.
Okay, we'll give you, you asked the first question.
I just want to finish it.
Okay.
As the team mentioned, using costly investigations is harmful for the patient. What if the patient has a real condition in which that investigation is needed? The 500 rupees of investigation can save 50,000 of any surgical or medical intervention. Thank you.
Okay, now you can ask a question. Yes.
As we are seeing rapid growth in private diagnostic centers recently, how do we ensure investigations are clinically mediated and not profit driven?
So your question was, why? How can we ensure that there is no exploitation of the patient in cases of investigation? So the simple answer he answered also first was, the doctor is the one who should give that appropriate investigation. We have come across many cases where wrongly investigations were given. These investigations obviously costed a lot just for the monetary gains. So it is not a question how could we ensure, it is a duty of the doctor. I would like to also add this point. If any misconduct or any there is any malpractice in cases of these private labs, we have specialized boards. We have government of India has a Ministry of Health and Welfare, Family Welfare, which we can report these faulty private labs to, which can help us ensure.
We can only put a case against them if it's caused harm to us. It won't cause any harm, but it actually leads to our loss, right? And as you said, like, it's the doctor's responsibility. You're right, but doctors are not they're not following that way, right? Like, a patient comes with headaches, for example, he has tension headaches. He's directly asked to order a CT scan. He's told to do a CT scan. Why? We don't need that, right? So we are not against investigations. We are against overuse. First, if a patient comes, for example, he has a headache, first he should be treated minimally, like by seeing the signs, what kind of headache, what is the like localization and everything. And then you should, like if it's not treated by that, then you should go further ahead for the investigation.
Okay. Do you have a quick question for them?
I want to state that
You can sit down.
I want to state that Press Info Bureau has said that India has crossed a crucial milestone in fight against COVID-19. The landmark achievement was that record number of more than 12 lakh COVID tests has been conducted in a single day. What my question is to opposite team, in such a hazardous pandemic situation in which all doctor has to use personal protective equipment, we have to divide the demographic zone in quarantine zone, green zone, higher risk area. In such cases, the contact of the doctor to reduce the spread of infectious condition was to be reduced. And that's why we apply the investigation procedure. We over-rely on investigation procedure like rapid antigen test, RT-PCR. So why can you say that over-reliance is becoming...
Desperate times call for desperate measures. We are not talking about the desperate times. We are just like debating about the daily patients. Like I agree what you say. Like in pandemics and all, obviously we have to rely because the whole country's economy depends on it. But those are desperate times. Those of course will cause for those measures. But like we are debating on the daily patients, not
Okay.
in pandemic.
Quick question from your side to you. You got 1 minute. Quick question.
How can you justify the de-skilling of How can you justify that investigations are actually causing de-skilling, clinical skills?
We didn't get the question, please.
How can you justify that over-reliance on investigations are actually leading to decline in bedside skills? Like the patient is not even examined like properly, he's just sent to the investigation room before that.
Did you get the question?
Like
We're going to increase 12 seconds, 12 to 15 seconds for the answer.
You meant the patient is directly sent to investigations. But doesn't investigations make the things rapid? It would always, we prefer investigations, not just because it is fast, it is reliable, but also in these modern times, it serves as an evidence. If something wrong happens to the patient, and if the blame is on our doctor, the doctor can prevent the investigations as an evidence that he's at not fault. It was the disease which have any complex, ambiguous outcomes which have caused the pain.
you said,
Okay, I'm sorry. Finished 8 minutes and we go to the judges' query as far as this topic is concerned.
Okay, actually my question was asked. My simple question is, again one more thing, that when we are in a medical sciences, the same question which I am going to ask both this thing, I just want the answer. How will you justify as a doctor which investigation is to be asked for from the pathology or from the radiology or from any other service department? So how will you make sure that which investigation is to be asked?
So we don't want excess. You have a situation, which set of investigations will you ask? So it's pertaining to that particular thing.
So how will you justify this? Okay, I'll give you one simple example. We are in the remotest place, the primary health center. Forget about that, we do not have a Mahal lab facility that this thing is concerned. A lady who comes with the case of anemia. Okay, lady comes with a case of an anemia. Simple, at the very remote place. Now which investigations, how will you know that it is a nutritional anemia or it is something like other cause of anemia?
Can I answer this question?
I get
sir?
your question.
Yeah, 1 minute, 1 minute.
So
Yes, please.
What I feel is every diagnosis starts with the history, meticulous history, then focused examination will give you the 70 to 80% of the correct diagnosis. Then if we need to confirm this diagnosis further, then we order any kind of investigation. If we consider a case of anemia, then it is very in a case of anemia, it will be having very prominent clinical signs. If the patient is coming to us like headache or fatigue or uh, pallor, etc. So what I feel is meticulous history taking and examination will be enough to get our diagnosis in such cases. That's why we say it ki symptomatology is the heart of medicine. Investigation are just to back it up. That's it.
Okay. Could you answer that question?
I agree with the question, sir. In remote places, investigations are obsolete. But when we consider about evidence-based medicine, we have to rely on investigations, sir. Investigations not only confirm the diagnosis, but it also helps the patient to know what his condition is.
Okay, I just want to ask then, when you say the evidence base, I truly agree with all these things. I truly agree with evidence because now the Consumer Protection Act is there. Okay, that act is applicable to the doctors also. So if you make mistake, you are sued in the courts. Okay, now to justify this, you should have a something like evidence to you. Okay, but now if this evidence is not there, can anything will save you?
Sir, I just want to answer here that as the investigation that we are taking is working as a burden of proof for proving a doctor innocence if we get any fake allegation or accuse from a doctor. Sometimes we are seeing in the rural cases that investigations are considered as a sign of reassurance by the families. That if the investigations have shown along with the doctor that the diagnosis is not the patient is being well and the reports are normal, they are reducing their fear, anxiety level, and the patients are also happy. Like we are studied in last time that we have to move with not only AI versus medicine, AI and medicine, investigation and along with clinical acumen. I think investigation serves as a evidence because it gives us a sign that the both sides are working in a balanced way. Not only the doctor has done, doctor has also confirmed with the investigation, not only the investigation failed, investigation has also shown that doctor is true. Now to balance this mnemonic, we need a opposite side, and that opposite side will be gated by a machine, and that is the technological procedure.
Do you have to add anything to this? You didn't get an opportunity. Okay, fine. Judges, any questions?
The problem is over-reliance or poor clinical integration of investigations. See, if there is a patient who has come and on investigation you find a asymptomatic patient, but he has some gallstones or appendix or anything, whether you are going to treat it or you are just going to watch it. So that means what we say is the diagnosis is on investigation, not clinically. How are you going to manage?
So can I answer?
Yes.
So as you said, if a person is asymptomatic and we diagnose something like a gallstone or appendicitis, anything, sir, until and unless the patient, like there are no harmful signs like if there are no signaling signs, we don't need to treat them. We can just call them for follow-up. If there are any red signs or the patient is getting worse, so then we can treat it.
Do you have anything to say about this question?
Sir, sorry sir, but I want the question to be repeated.
Okay. There's a patient who comes to you that may have gallstones but has no symptoms. How will you proceed? Is that the question? Yes.
Incidental findings.
Incidental findings.
Sir, I just mentioned in my opening salvo also that what we have to focus is if there's infection comes with asymptomatic tender. Now the doctor has the clinical skill set. But if the symptoms and signs are not there, what the doctor will be do? The machines were invented by the human technology to assist them. It's like a weapon. Now when the soldier goes into the army, so he needs a weapon to show his skills. It's like the clinical signs and symptoms if are not seen, the asymptomatic cases can be treated by the clinical skill set of the doctor when he has the weapon and assistance of the technology. An unassisted pathologist or unassisted clinician will not get that as a chance to show his or her skill. And clinical acumen to go by hand in hand, we need that assistance with the technology.
Means you will treat or you won't treat.
So can
Will
I
you
add?
treat that patient or not treat that patient?
So that
Who has got chance finding without symptoms, a patient of gallstones, you want to treat him or not treat him?
Sir, if it is a chance finding, I would like to go to the root of the disease. Like, what is the cause of that gallstones? And if that gallstones are harmful, like the size of the gallstones, would it be obstructing the duct?
See, what are you saying? Obstructing the duct or all those, they'll come with a symptom.
They'll become symptomatic, na? What
No,
sir
in
means?
the future, if it will obstruct, that is my
So let's end it here. Will you treat that patient? Yes or no?
I will do further investigations, and if I found it that I have to treat that patient, then I
Then
will.
only. Will you treat that patient? Yes or no?
Sir, if the patient is not presenting with warning signs right now, like he is asymptomatic and there are no warning signs, so I will call him for follow-up, but I will not treat him right now. If on follow-up
Yeah.
I find out that he's getting worse, then I will treat the
Okay.
patient.
Thank you. I think we have ended this round. Thank you very much.
What an expression of views it was. I request team E and D to come on the stage and occupy their positions.
The next two teams,
The team E and team
E and F, right?
sorry, E and F.
E and F.
In team E, we have Krish Gala and Bhumika Srinath.
Yes.
And
Your
team
D.
F.
Your team
Team E.
E, F, F. Yeah. Please sit down. Please sit down.
And team F, we have Poojan Patil and Neha Pandey.
Okay, I would like to request you all your names, which year and which college. And are you from the organizing batch? So we start with minus marks, please. So they are from the organizing batch. Please introduce yourself.
Good evening, sir. My name is Krish Gala and I am from second year in GMC Miraj.
Good evening, I am Bhumika Shirsat and I am from second year GMC Miraj.
Good evening, sir. Good evening, sir, and good evening, everyone. Myself, Poojan Patil, and I'm from third year MBBS, and I'm from GMC Miraj.
Good evening, everyone. Myself, Neha Pandey, a third year medical student from GMC Miraj.
Okay.
So now let's begin the third debate. The topic of this debate will relate to all of the medical students sitting here. We will start with a short introductory clip and then we will reveal the topic.
We all as students have gone to various lengths to complete the required attendance in our colleges. If it is not mandatory, the picture of classrooms would say otherwise. So we have to debate this topic if this attendance is required for a better professional training or it's just a moral policing on the students.
So the topic is compulsory attendance, professional training or student policing. Team F will be in for motion, that is professional training, and Team E will be for against motion, that is student policing. So I request Team F to start with their opening statement.
Hello. A doctor who has freedom to be absent become a danger to the patient who has no freedom to suffer. Respected judges, worthy opponents, and all my dear friends. Myself, Poojan Patil, and I stand here not just to support the motion, but to defend the very foundation of professionalism that compulsory attendance is professional training and not a student policing. Because the moment we chose this profession, we did not choose a career, we accepted a responsibility where absence can cost a life. Attendance is not about obeying authority, it's about preparing for accountability. Is it policing when a pilot must be present before takeoff? Is it policing when a soldier must be present before on the border? Is it policing when a doctor must be present in the emergency room? No, it's called a duty. It's a very good saying that profession that carry lives cannot be trained with optional presence. Medicine is not learned in comfort. It is learned in corridors of hospital, in moment of emergencies, in silent observation of suffering, and in responsibility of action. A textbook will give you information, but attendance will give you transformation. A book will teach you what to do, but your presence will teach you when to do it. Competence is not downloaded. Competence is not downloaded. It is developed through presence. Compulsory attendance builds something far greater than knowledge. It builds discipline when no one is watching. It builds responsibility when no one is forcing. It builds character when comfort is tempting. And let us remember, one day we will not be student marked absent in register. We will be doctors marked absent in someone's moment of survival. And on that day, absence will not be indiscipline. It would be negligence. Attendance builds discipline. Discipline builds responsibility. Responsibility builds trust, and trust builds a doctor. So at last, I would like to conclude by saying compulsory attendance is professional shaping, because when life is waiting, our presence cannot be an option. Thank you.
Now I request Team E to start with their opening statement.
Respected judges, worthy opponents, and everyone present here. Education is meant to liberate minds, not monitor bodies. Yet, when institutions enforce rigid attendance percentages, threaten debarment, and prioritize roll calls over results, we must ask ourselves a serious question. Are we building professionals or policing students? College students are adults. We can make life decisions, and yet inside classrooms, we are told that our maturity is measured by a signature on an attendance sheet. Physical presence has become more important than intellect. Let us be clear, attendance does not equal learning. You may succeed in counting students, but you will fail in cultivating thinkers. A student can sit through every lecture, scroll through their phone, and yet still walk away empty. Meanwhile, another student may explore concepts independently, work on projects, or learn through research and yet still be penalized for not warming a seat. If attendance is the benchmark of success, then I'm sorry to say, but we have set the standards embarrassingly low. Education should inspire presence, not enforce it. Compulsory attendance also ignores individuality, health issues, and personal responsibilities. Instead of fostering self-discipline, it exposes self and external control. And forced discipline is not professionalism, it is obedience. If education truly prepares us for adulthood, it must also treat us like adults. Trust encourages responsibility. Surveillance builds resentment. So today, we stand firm. Compulsory attendance is not professional training. It is policing disguised as discipline.
Now I request both teams to start with the crossfire round. The first question will be posed by 4 team, that is Team F, and subsequent round will follow.
I would like to ask the question to the opposition team that if students skip clinical postings or clinical exposure or theoretical lectures, which are the base for the clinical exposure, so will patient safety not be compromised?
Patient safety does not solely depend on the attendance in the clinical postings, but it depends on the learning in the clinical postings. A person might not attend the clinical postings, but still know the knowledge of clinical postings. And if they don't know the knowledge of clinical postings, they might not pass the examinations, the practical examinations which are held. The practical examinations are held and they have a standard due to having, like, it has a standard because that is necessary. But if the practical knowledge is not present, a person might not pass the practical examination and might not become a doctor as well.
Okay, so you get to rebut a question.
I would like to ask you, if attendance builds professionalism, would you hire someone with 100% attendance but poor performance, over someone with excellent results but poor attendance?
Firstly, telling you that question, that attendance and skill both works hand in hand. There are very rare conditions where a doctor is completely skilled and he is having very poor attendance. And when we are talking about the medical profession is a profession of supervision. As we see that when a JR1 practices in hospital, he is supervised by JR2, he is supervised by JR3, and JR is supervised by SR. So saying this, that the things what we do in a medical field, that we handles the life, it cannot be learned on our soul. The things cannot be learned solely. We need supervision, like the process like intubation, central line. These are need to be supervised, and which are ensured only and only by physical attendance and not by learning it at home.
Okay. Judges, please reduce 1 mark for that voting. I'm joking. Okay. Your question, please.
So how will weak or distracted students stay consistent without enforcement for physical attendance or clinical posting compulsion?
Did you get the question? Yeah. Okay. Quickly.
So when we are talking that there are very less exception students who are performing excellent in their academics. So okay, agreed. This student would be learning on their home by the self-motivation. But what about these students who are weak or distracted, which are common in today's generation? What about them? How would they be consistent without enforcement?
I would like to answer this by saying, if you are telling about students who can study by themselves, they don't actually need any guidance or any other external motivation to study. If they actually had their self-motivation and accountability to study, they would do it by various other ways like digital resources, research, etc. And if you're talking about students who are not going to study, well, they would not even study even if they had 100% attendance. Attendance would just promote mediocrity. People and students would just come for the attendance, come for the marks, and then go away. They would actually not learn anything. So it is built upon self to actually study and become a better version of themselves instead of imposed attendance.
Okay. It's your turn to ask a question.
Okay. I would like to ask you that if your model of professionalism actually collapses the moment attendance becomes optional, then isn't it that you're not building professionals, but you're actually building rule-dependent students?
I think the idea of compulsory attendance inculcated by the authorities was because the main principle of becoming a good doctor or good professional is the discipline. Discipline doesn't come overnight. Discipline is very much required for a responsibility. And the main purpose of compulsory attendance is to get 100% theoretical knowledge, get maximum clinical exposure, which inculcates a very critical clinical knowledge within us. So I think clinical attendance and compulsory attendance is very much critical, very much important. And also there is a fear of enforcement for the students regarding the compulsory attendance. So let me make it very clear that fear is a pre-step to discipline, and responsibility to being a doctor is the very major conclusion, which requires a very major step of discipline.
I would like to reply to this.
You want to rebut that?
Yes.
Yeah, please.
Sir, I would like to say that you talked about discipline. Well, I say that discipline is self-driven. It exists only if it exists only because of enforcement, then it is compliance and not discipline. Adults are to be trusted with responsibility and not to be bound by rules. If discipline disappears the moment attendance becomes optional, then was it ever discipline in the first place?
Answering your question, that the discipline and the enforcement which you are talking about, it's a hereditary. It starts by fear or enforcement, and then fear is followed by discipline, and discipline is followed by responsibility. And when the stage when it is started by fear will make you a responsible doctor. It starts by fear followed by discipline, and then then you would become a responsible doctor. and asking my questions to you, as we all, most of the students here are the budding doctors. So you really feel that is patient safety less important than students' freedom?
Yes, please. Continue.
Is attendance more important than a patient's safety? That is the question. Even if the attendance just builds an eligibility criteria. For example, if a student is attending the lecture, he is gaining no knowledge, and then if attendance was that important, and if attendance was gaining so much knowledge to the students, then why 40 to 50 the graduation rate right now is 40 to 50% in the medical field? Like that, even though they are going to the lectures, they are attending the lectures, still they are failing the examinations, right? So that does not relate to knowledge.
Sir, I would like to add one more point.
10 seconds.
So are you saying that all students, unless they are controlled, are irresponsible? I don't think so. Policies exist in other workplaces too, yet professionals over there are trusted with flexibility.
40 seconds, the stage is yours, and we stop.
Physical attendance does not mean that the students are attending the class and they are not getting any knowledge. Physical attendance is mandatory only because it gives them the exposure of developing the habit of learning. Physical attendance is nothing, but many of the students, they have recently passed the pre-college era and come to the college. Most of the people are in the enjoyment era. So we need to build some enforcement so that the people attend the lectures and at least they get an exposure to the knowledge. And ending this statement that skills, that medicine is not a 9 to 5 job. It's a 24-hour duty. So students should be eligible for working 24 hours. Thank you.
Okay. Yeah. We have finished the rebuttal round, and I would request the judges for their questions, please.
My question will be to both of you, both of the teams. What have you understood by the word professional training?
Sir, according to my understanding, by professional training, we feel that whatever or whichever profession we choose, we give 100% to that profession, and whatever the profession demands, we are able to provide that the profession are 100%. And training, and by profession, and that the word by training, we understand by the initial step for that profession is by compulsory attendance.
Yes. Your answer regarding professional training.
Sir, we believe that professional training is training that builds us for the adult world and for the real world. And we believe that professional training is not just coming in and sitting and warming a seat. We are not here in a cafe. We are not here to book tables or become supervised customers. We are here to become doctors. And I think being a doctor, the first responsibility that you have is to be self-driven, and then know and have responsibility and accountability to show that you can do it even without attending every lecture.
Okay. Second is something like student policing. So it is related with what are the criteria for the students to attend the lectures?
Did you get the question?
What are the criteria? Why do you feel that you should attend the lectures or you should attend the clinical postings?
In short, what would motivate you to attend? Attend.
Sir, I agree that enforcing the attendance sometimes can be a burden to the students. But sir, what I'm saying is that
I just want pinpoint what
is the criteria?
What makes you attend lecture?
What is the motivation for you to attend lectures?
What makes you any motivation to attend any this thing?
Sir, I think it's a sense of responsibility being a medical student or future medical professional which motivates a individual to attend a lecture. It's basically not about only theoretical or it's not only about theoretical knowledge of sitting in classes and doing something. It's about combination of mixing the theoretical knowledge, which is the foundation of clinical knowledge, and by attending both clinical and theoretical knowledge, it's our training. It's our foundation towards becoming a good professional doctor.
Okay, wait 1 minute. You get
Sir,
a chance.
I
No,
would-
1 minute.
Sir, I would like to emphasize on the word that they just said, self. It is about self. If we are responsible ourselves, we don't need attendance to show up every day. I think the most important thing to show up every day in class would be the quality of teaching, and that the teachers actually make you engage in learning what you want to learn and not just sit there and scroll through your phones the entire day.
Yeah. You have question for both of them, please?
Should attendance be linked to competency based or just the percentage of attendance?
Did you get the question? Could you please repeat it?
The attendance, what we say that the compulsory attendance should be based on the competency log or just the percentage like 30%, 40% or 60%.
Okay, so you are attending something. Should it based upon physical presence or a calculation of the competency that you learn out of the lectures? That's the question, right?
Obviously, it should be based on the competency, because at the end, knowledge matters. The percentage of attendance or physical presence doesn't. And a doctor should have proper knowledge to treat a patient, to diagnose a patient. And just physical attendance, physical presence won't do that.
Okay, your last word.
Sir, and regarding the compulsory attendance could also be reformed based on the competency. If the student is attending the lecture and after every lecture, if we allot 10 to 15 minutes for what the student have understood, so also the compulsory attendance can be remolded into checking the competency of the student.
Sir, just a minute.
Yes.
You said that knowledge, just by attending YouTube lectures or the notes or the textbook, can it make you a doctor to work on the ground? Because humans are not machines. Each patient is a different. So you cannot categorize that, okay, I have learned this and every patient will come like that only. Like if you are repairing a mobile, if you learn a mobile how to repair, you can repair all the mobiles. It's not like, humans are not like that. So for that's what I want to say, doctors practice. It's not a job, it's a practice. So how are you going to practice? It's an experience. And how are you going to gain the experience? By attending the clinics or your day-to-day OPD basis practical.
Sir, but the motivation to attend the clinical posting should come from within. Like the motivation should be to become a good doctor. It shouldn't be the compulsory attendance or to meet the eligibility criteria of attendance. I am not against attending the postings or attending the practicals. I am against the compulsory criteria, which makes some doctors irresponsible.
Girl, you had it for your surgery postings. No, I think we'll stop this round now. Okay, and yeah, so we are through this round. But what Dumale sir was saying and what he wanted is, I think it's the responsibility of a teacher also to deliver his topic at that particular level, which will attract students coming in. And let's give a round of applause to Dumale sir, who's always rated as the best teacher at Bharati Vidyapit. Please. Yeah. With this, we finish this particular round. Thank you.
What a great debate to finish this screening level. For this, we conclude the level of screening, and now we request our judges to give us the winner teams from the first level.
Hello. It's always a tough time to announce all these things.
Excuse
but,
me, can we have your attention, please?
It's always a tough time to announce all these things, but every team performed very well. And to be very frank, because though I've done my UG and PG from the same college where you are learning this thing, studying now, GMC Miraj. So, yeah, it's always better to come with you for such good events organized by Wilson. He keeps on calling me, I never say no to him. Because when it comes to coming to GMC back, so it's always feel better, right? Because the days are changing and I know how
It's homecoming. It's homecoming. You're most welcome.
Most of the teams have done very nicely. Because I have learned good things from you. I always compare students from our ages and today's age. Now you have ample of exposure. At the fingertips you have everything, right? And all the topics which were chosen by, I think Wilson sir must have done a spade work like anything for choosing these topics. So every topic was good. And it's a learning phase. Who wins, who loses, that is none of my business. But I am again telling you, what was the first topic? Empowerment. Now when I ask the question, how you bridge the gap, right? Now the patients will come to you because the days are very near, right? Patients will come to you. Now recently we have Consumer Protection Act, right? And we have to write down why it should not be there it should be applied to the doctors. So there are so many reasons. Now in most of the Western countries, now what happens is the literacy level of Western countries is very high, right? They come with the tape recorder to you. They just switch on the tape recorder in front of you, and then they ask you, okay doctor, now you tell me what should be the line of management of my patients and how we are going further to manage my patients. And it is the doctor's responsibility to tell the patients what will be the line of management. What will be the line of management? Now days are not far off that the patients will come to you, and where you will have to empower the patient for how you are going to show them what should be the line of management. But that will be only after when you tell them what is the correct things, and from where the correct things will be there, as somebody said, from WHO, NFHS data, and there are so many sites which will give you or which will protect you, right, from giving the right information to the patients. So that is one. Second topic was something like, what was the second topic? Investigations. Now I am always say, right, I always quote this. Now those who are doing, in your library that book is there, and mind well, I am saying this thing with a lot of lion's heart. In Bharati Vidyapit, in my stack section, that book is not available. That book is available in your library. Somebody said methodology, right? Or something like the symptomatology. Now, can anybody tell me which is the best book for symptomatology which is available in your library, GMC library? I can ready to give you 500 rupees at this time.
Is it Clinical Das?
No. That book is available in your library,
Hutchinson?
but it is not available in my library.
Hutchinson?
No. Symptomatology. Huh? No. I'm going to lose 500 rupees. Is there anybody? Okay, I'll give you one more clue. Not symptomatology, then again, okay, differential diagnosis. Now don't Google it. Please don't Google it, which is available in your library, but it is not available in my library. Bol. Nahin, not PJ Mehta. Okay. Huh? No. I'm saying differential diagnosis. Okay. Without wasting much time, I'll give you this thing. It is the French Index of Differential Diagnosis. It's a huge book. A recent copy has come to your library. I have been to your library. I don't know how many of you have been there. right? So there is a French index of differential diagnosis, what we were discussing about fever. There are plenty of causes of fever. Unless and until you have got a clinical acumen, then and then you can tell the patients which are the supporting investigations. Investigations are for confirmation of your differential diagnosis. When you ask chief complaints, you have 4 or 5 diagnoses in your mind. When you take history of present illness, you rule out one by one, you dissect out one by one, and then personal history, family history, environmental history, all histories. Then at the end you remain with 1 or 2 diagnoses, and to support this or to come out with the diagnosis, you should have a investigation. Investigation should not come first. First should come the clinical acumen. So this topic was really good. And the last topic was this thing, team E and this thing. What was that? Attendance, right? In spite of telling all those things, you know, attendance is poor pan-India. I'm telling you, right? But the one thing what Wilson sir has said, because he understood my question very well, that what makes you attend unless and until, with due respect to all the teachers, with due respect to all the teachers in my era, right? They were making lectures practical so interesting that in my era there was no PowerPoint presentation, remember. No PowerPoint presentation, it was chalk and board. But still, I can still guarantee that I have a good clinical acumen than you fellows. Though I have not this thing, my branch is community medicine as such. But still I can say, because I had best teachers, right? So they used to teach us all those things. So what is more important is not just to attend, but then something lies on us, some responsibility on us as a teacher. We have to make sure my class should be interesting, because you have got ample of things on YouTube, anatomy. You have ample of things. There are 4 cameras, right? And then you can see the radial bone. One camera from this side, one camera from this side, one camera from this side, and the person explains you very nicely. But then that is my competition. YouTube will be my competition, right? A teacher on a YouTube will be my competitor. I have to make my teaching so interesting so that the students will not bunk my classes. It is not for attendance, but they will come for, as the teacher is teaching something different which is not there in the books, right? I'll just give you one example of how the teacher is felicitated. We had this thing, tsunami, way back. When was it? Okay, so one English tourist, British tourist had come to Sri Lanka to explore Sri Lanka. And then they were on the seashore. They were not knowing the tsunami is coming. But then there was a child who was in 7th standard. And then she saw, because the first sign of tsunami, the ocean recedes very back. Right? That was the first sign. The ocean recedes very back. And what happened is, then the girl told the parents, the ocean is receding very back. I think this is the first sign of tsunami. We have to go back to our hotel immediately. And everybody laughed at her because nothing was there. And then what happened is, she literally started crying, and then she took the parents to their hotel. And another after a few hours, the tsunami struck. The student was felicitated when they went back. Many of the lives were saved. The student was felicitated, but above all, the teacher was felicitated, who taught her that what is the first sign of tsunami. So that responsibility lies on us, right? To make you attend the classes, it should be our responsibility. I know how much attendance will be there for your class, right? Thank you so much for giving us. Okay, so the winners are the team B, team C, and team E.
Team B, Team C, and Team E are the winners who go on to the next round. So give the winners a big hand and the people who participated equally a big hand.
Heart, Heartily congratulations to the team B, C, and E, which would proceed to our next round. As I said, next round would be a surprise to all, surprise to the teams, and surprise to the all the.
Request silence, please. Please be silent.
The next round will be surprise to the team and surprise to all the students and dignitaries sitting here. So now we'll proceed to this round. As we have 3 teams and we cannot take for semi-final between 3 teams. So we are going to directly qualify one team from this round into the final. This round will be the ultimate contest of who will be the finalist of this debate. So, topic of this surprise round is telemedicine, greater access or loss of human touch. One member from 3 teams would come forward and speak about the topic. He will decide what he wants to speak in for motion or against motion and will complete his opening statement in 2 minutes. There will be no crossfire and no judges' questions in this round. I request one member from team B, C, and E to come forward.
Please nominate one person amongst yourself, team B, C, and E, right?
Yes, sir.
And quickly come to stage because we are running a little late and we would like to make up time. Timekeeper, could you come here, please? One member representing team B, C, and E. Please come to stage. Dumai sir. You were team E. Please come up. One person from team. You are from B. B and E are here. Who's C? Team C. Somebody from team C. Team C 1. Team C 2. Team C 3. I'm counting. Okay, so once again, I hope you're clear with what's going to select you between being directly a finalist or fighting it out at the semi-final level. Are you clear with this? Are you clear with what he has said? You get 2 minutes on a particular topic to speak. No rebuttals, no questions will be asked. The judges, I request you to judge them on these 2 minutes. Okay? Ashutosh, how do you propose they start? Who's the first person?
It's difficulty to choose one team to start first. So, to not having confusion, we will draw the chits that will decide which team will going to present the first in this debate. So I request all the team members to come forward and draw the chits.
Please draw your chits to decide. Okay, let the timekeeper give her the privilege of drawing the chits. But that's for whom? Okay. Give it to her, don't open it. Who's first? Give it to her. That's your chit. That's second. That's third. So based upon this, it will be the sequence in which you will get your 2 minutes. Own them and deliver at your best. Do you know the topics? Is the topic clear? Is the topic clear? Ashutosh, why don't you declare the topic? The topic.
The topic for this surprise round is telemedicine, greater access or loss of human touch. The team can choose any side which the team wants to And please briefly do it, briefly speak in 120 seconds. There will be warning bell on 90 seconds and final bell on 120 seconds. So I request the first team to start the statement. Please introduce yourself and your team.
Okay. You want to use that? Go and stand there because this may not work in between. You can go and stand there, yeah. So you got the first opportunity for 2 minutes, right? Yes.
Good evening, everyone. I am Runmai from Team B, and I will be sharing my thoughts on how introduction of telemedicine leads to the loss of human touch. Since decades ago, we are all used to seeing a physical doctor in front of us, and the comfort of him being there soothes our mind, psychologically speaking. So when the telemedicine is introduced, it lacks the human touch, the human emotion, the human comforting that a common man generally needs. Not just that, speaking on technical terms, it also reduces or limits us as a physician to do any physical tests. And there is obviously going to be a difference to see someone through a screen and to see someone sitting there physically in front of us. There are a lot of signs that we can observe from a patient just from him being there in front of us, let alone do the other tests like checking the BP or any pallor, which is not very clearly evident in case of a digital screen. Even talking in terms of the patients, as a common man's idea of going to a doctor goes, he is only comforted and his anxiety and panic only subdues when a doctor actually checks him, talks to him, has physical contact with him, tells him everything is going to be all right if you follow this treatment plan. With telemedicine, I think a lot of people would be hesitant with that. And not just that, the connectivity is an issue. Like in the rural areas, not a lot of people have the high-speed internet needed for the telemedicine, not the screens. So this is going to be a huge issue in the rural population, which forms the majority of the population for people like us. Thank you.
Who's second in line, please?
Thank you very much. Now I request second team to present the topic.
You have 2 minutes to deliver.
Please introduce yourself and your team name clearly before starting the topic.
Good evening, everyone. I am Krish Gala from Team E, and I would like to talk in favor of telemedicine being greater access as opposed to lost human touch. I believe that telemedicine can in fact help a lot of doctors reach a lot of patients quicker, deliver treatment quicker, and it can also decrease the time of getting second opinions. I feel if a doctor is stuck or confused in between 2 or 3 diagnoses, if he has live or recorded or any sort of digital acquaintances that he can refer to, he could actually get second opinions way quicker, and that would actually be very beneficial for the patient to get faster treatment. I also believe that telemedicine is the future going ahead. I don't think a lot of coming in the future, I feel that there would be a lot of patients that would increase, and seeing the strength of doctors in our country, I believe that one doctor physically cannot check 100 patients in a day. Whereas if a doctor can actually refer patients based off of whether he feels comfortable or knowledgeable enough to handle that patient, he could switch it to another doctor to get second opinions way quicker. That would help us get treatment a lot faster. Thank you.
Now I request next team to present their views on this topic.
Good evening, everyone. Myself, Neeral Sanklecha. I am from Team C, and I would like to speak in favor of the topic that telemedicine leads to greater access. In recent times, like for example, when we had the COVID-19 pandemic, there were apps like e-Sanjeevani, due to which a lot of patients were diagnosed through those apps. through apps like these. Like due to the high patient crowd in hospital settings, there it's not possible for all the patients to reach there. So apps like these in such times are of great use. Secondarily, like many conditions, it saves times and eases it is in ease for the patient. Like for example, if you want a dermat consultation, you can these days you can just do it through apps. So it's very convenient for the patients. Like instead of standing for long hours and waiting for long hours in hospitals, as we know, like in India, there is the patient. We know the patient load in India. So yeah, I would like to conclude by saying that telemedicine is the future. Thank you.
Okay, so this round was requesting the judges for one winner who would go directly to the finals. The remaining two would be the semi-finalists. Is it clear, Ashutosh? Is it right that way?
Yes, sir. This round was all about conceptual clarity and confidence. The team who has clarity and confidence to directly speak for anything would be a great team for a debate. For this, amongst three teams, one team which has the highest score will go directly in the finals. I request our judges to announce the finalist team.
Okay, are you ready with, give us one team that will go directly to the final.
Hello. So the team E scores most point in this round, so it goes to final.
Okay, team E goes directly to the final. I would request team C and team B. Team C and team B to take stage for the semi-final round.
I request remaining members from team C and team B to please come on the stage.
Could somebody please come up and help him? Come quickly. All that you need to do is stick those things. Ashutosh, you need to learn this art. उद्या बायकोचं साडीला पिन लावायला लागते अशी. And you're taking too much time. You're fired. Okay, could you please introduce, these are two semi-finalists. We all know that one team has already gone to the final. So there's a fight for the semi-finalists between two teams for the second final round, finalist round.
Congratulations to the team E. The two teams which would be in the semi-finals are team B, which participants are Apurva Moite and Mrunmay Mane, and team C, whose participants are Neeraj Sanklecha and Vedant Vakde. Without wasting further time, we'll now proceed to the semi-final round. Similar to all round, we will play an introductory clip for this topic, and then a side will be drawn by the chits.
Training today is increasingly becoming simulation based. Instead of real life cases and procedures, students practice predefined simulations. It may increase some of their skill set, but in this process, are their skills of real life patient exposure decreasing, which is required?
So topic for semi-final is simulation-based training, adequate preparation or reduced patient exposure. I now request the teams to come forward to draw the chits.
These sheets are meant for and against, right? Okay, fine. Could you please pick up the mic and declare, are you for or against simulation-based training?
We are for.
So your team B and you're for simulation-based training, right? Okay. Team C, is it clear? Team C, is it clear that you're against the notion? Okay? You're against the notion. Okay. Fine. Can we start?
Yes. Now, for this session, Team B is debating in for the motion, that is for adequate preparation, and Team C is against the motion, that is reduced patient exposure. I now request Team B to give their opening statement for this topic.
Good evening, everyone. So my notion is for SBT, simulation-based training, which is important for adequate preparation. So I'd like to quote that practice makes perfect. Simulation-based training, the advances in simulation-based training have many benefits. One primary benefit being enhanced skill acquisition. These skills that I'm talking about encompass technical skills such as surgical procedures and clinical intervention, and various non-technical skills including communication, teamwork, and decision making. These skills have to be developed in every medical practitioner, as while practicing on a real human being, there's little to no margin of error. Because during practice on a real human being, we are dealing with life or death. So I or anyone here present would like their doctors to have the adequate skills necessary present in them before they put their hands on real patients. For students like us, many present here, simulation-based training acts as a golden opportunity where we can get hands-on experience over various models, for example, for BLS, for central line preparation, for intubation, and various such, as many of us have seen in the workshops present. And in simulation-based training, the students have a margin for error. Any error that they make can be rectified. So they get more practice and they are more confident and oriented towards the equipment they are going to use while in real life scenarios. So they get more exposure and they get acquainted to every single instrument they are going to use in further practice. And it gets a real life scenario where people can actually try and improve their teamwork and everything. Thank you.
Now I request Team C to start with their opening statement.
Good evening, everyone. I would like to speak against the motion that simulation-based training, it leads to reduced patient exposure. While simulation has educational value, we firmly believe it cannot replace real life situations. Over-reliance on simulation risks under-preparation and under-preparing clinicians for real-life clinical complexities. Simulation cannot replace real patient interaction. Medicine is not just technical skill, it is judgment, empathy, unpredictability, and human variability. Simulation lacks real-world complexity. Mannequins don't show subtle emotional cues, biological variabilities, non-verbal cues, psychological complexity, and diagnostic uncertainty that form the core of clinical reasoning. Real patients present atypically. Over-reliance on controlled environments may reduce adaptability. Real-life pressure is different from stimulated stress. It also lacks communication and professionalism. Breaking bad news or managing angry relatives cannot be fully replicated. Empathy, rapport building, and navigating cultural contexts can't be learned on a mannequin. Resource constraints. Many Indian medical colleges lack high fidelity simulation. Overemphasis on simulation may reduce bedside teaching in already patient heavy hospitals. You also can learn to manage complications when you are operating on real patients. So, also the confidence after operating on real patients is more compared to a mannequin. Lastly, I would like to conclude by saying you don't choose a medical college based on how good its skill lab is. We see how high the patient load is. Thank you so much.
Now I request both teams to start with the crossfire round. Remember, the time limit for crossfire in semi-final is 12 minutes. A bell will be at 11 minutes and you will give the closing statement. I request team B, which is in formation, to start with their question and round will proceed forward.
I would like to begin with reminding my fellow opponents that the topic of the debate is simulation-based training and not treatment. So, my question to you guys is that when there are new doctors which have just entered the actual hospital setting, how are you going to ensure that he or she, if there is any medical complication due to their lack of training beforehand, is being handled properly, and how can you reduce the patient risks involved?
Yes, I would like to answer this question. When a new intern doctor or suppose undergraduates are in the clinics, in the OPDs, they are always guided by their seniors. No undergraduate student will be left alone in an OPD. So if there is any sort of error or any complication, there are their seniors always there to help and manage these kind of treatments, complications. That's it. How will you learn without being on-hand practice on the patients? It is not possible to just study on the mannequins and then apply directly on the real-life patients.
Okay, question from your side. Are you happy with the answer? You want to add something? Very quickly.
I'd like to add something that if in an emergency situations, we as medical healthcare professionals are expected to act on our own in an emergency situation. For example, if a patient is, for example, if an undergraduate has been shown how to do a BLS on a mannequin, they can easily replicate it on a patient who comes to them in an emergency. So it works that way. I'm not.
Okay. You have anything to say? No, I think you had a chance to say. Okay. Okay. So now it's your turn to ask a question.
As you said, I would like to ask you how, in a mannequin setup, how will you tackle real life situations or the real life pressure which is there when the patient actually comes to you, or how will you handle the relatives, or how will you build that communication through mannequins or simulation practices? How will you build that?
The newer simulation-based training has a real-time interaction between the doctor and patient, and this is just about the training part. Obviously, doctors will have to go and attend in the OPD, see patients in real life, but along with that, we just mean to say that simulation-based training will help improve them, because they can repeatedly practice a same maneuver if they are not getting it correctly, and the newly developed simulars, like I said, have a real-time feedback mechanism as well to show where the doctor or the trainee is going wrong in a procedure. That just acts like a level of practice before you go actually and interact with a real human on your table.
You have anything to add to it? You're okay with it? Okay, fine. You get a chance to ask your question.
Without simulation-based training, how do you ensure that the doctor who is going to perform any procedure on a patient has reduced risks, rather than having my point is, after simulation-based training, a doctor going to do the procedures has relatively less risks. How do you ensure that a person who has not gone through simulation-based training has less risks?
I would like to.
You got the question. You got the question. Okay.
Yes. uh, we consider any sort of procedure, there will be related risk related to it, right? There is no procedure without any risk or complication. So it doesn't mean if you have practiced it on a mannequin, but it will not replicate the real human anatomy, because most of the patient will represent you with atypical presentations, with anatomical variations, which cannot be always replicated in a mannequin. Mannequin will give you what only the procedure, how it is done, how like the steps in it and all. But to perfect it, we have to have that clinical or exposure on real patient.
Okay, you want to add something to it?
Obviously, we are not even questioning that it will ever resemble a human completely. We are just asking about the training process. Wouldn't the training part be easier if it is simulation based? Obviously, as a doctors, we do have to operate on humans, not mannequins. But while training, I think mannequin training is going to be much better.
You want to add to that?
I don't feel that way, because at the end, if you have even practice, but it will not give you the same level of confidence, the same level of skill which you acquire through a patient. Our topic is the simulation based training. It gives you either adequate preparation or it is decreasing your patient exposure. So that's it.
Okay, it's your turn to ask a question now.
Sir,
Yes.
it's our turn.
It's your turn?
Yeah, sir.
I'm sorry. It's their turn.
As you said, mannequins, like practicing simulation-based training leads to skill enhancement. Now, can you just tell me, like, if you want to take a blood sample, for example, how will you take, if you go on a mannequin to take it, is there a vein? Do you have to find a vein? No. But if there is a patient, the first thing you have to do is you will have to find the vein, and then you will take the sample. So on mannequins, you cannot say that there is skill enhancement. So I would like to ask, why did you say that?
The simulation-based training we are talking about includes the newer simulation-based training and mannequins, which do resemble the skin texture, the hand texture, and the vein placement in a human body. They are advanced simulation-based, and that is what we are fighting.
You said about this hyper realistic type of mannequins and all. In a country like India, we have like low economical for the medical field. We don't have that sort of mannequins or yeah. So these conditions are mostly in the US or Canada with high medical field, where the medical field is greatly developed. In a setting like India, it is not that economical for us to have that sort of mannequins in the every medical college or hospitals.
Do you have anything to say?
Answer to my dear opponent, I'd like to say that simulation, the training we are talking about is not whether we have it or not. We are talking that, oh, if we do make a reform and we do actually have it, we can get more, we can be more better at treating patients. If there is an hyper-realistic mannequin available to the students, it makes us more acquainted to it.
It would take years for such technology to come in India.
But
So wouldn't it be
we can't-
easier if we practice on patients, because we have them. We have a lot of them.
We are actually fighting for that reform only. Simulation-based training is adequate.
We would want that type of simulation-based training. Obviously, in the future, I really hope that all Indian medical colleges have such type of technology available for the students.
Off the record, off the time, just to get the crowd in. That means you are looking at future mannequins who are going to abuse you if you don't have a first prick. They're going to literally abuse you if you don't prick them or if you don't cannulate them in the first prick in future. Okay, off the record and off the time. Question from your side. Please don't lose valuable time.
I'm just going to ask my dear components that how are you actually going to train the medical students without simulation-based training and not just throw them into a pool where they have to practice on a real human?
there are not going to be any guinea pig humans available. So how else do you plan to train your interns or your residents before coming and operating on real life humans? How else? What other solution do you guys have?
That's I would like to answer it like that's why we have our clinical postings. No, we will go there. First we will see, then read about it, get more knowledge. The more knowledge you have about the topic, the more confident you will feel. And after you have that much confidence, you can always practice it on a patient. And again, we are not alone like that when practicing on our patient. It will always be guided by our seniors or professors in that way.
I would also like to add that real life anatomy cannot be replicated in a mannequin. So when you actually do it on the patient, it is more retaining. You retain it more and it leads to your clinical improvement. Like your skills are improved basically if you actually practice it. And based on personal experience, and like I would like to say I haven't practiced on patients yet, but like when you actually practice on patients, you retain more. That's
Okay, you have last 2 minutes and the question is with you all. Quickly, please. If you don't have a question, I can ask them to ask you. Please, quickly. You're losing precious time.
okay, sir.
Okay. You have last 1 minute remaining for a final comment from both teams. Last 1 minute. Yes. Final comment. You wasted time on a question. Final comment, 1 minute remaining. Okay. Can you start with your final comment? Yes.
Personally speaking, and I think everyone would agree, as a doctor, I would get more confidence if I have practiced that procedure 2-3 times before and then I operate on an actual human being rather than going straight in on an actual human having consequences of life or death.
Yeah. Final comment from your side.
I would like to conclude by saying that not all scenarios are life or death. You can learn a lot more, a lot better on patients than on mannequins. So I would like to stick to my topic that we should be practicing on patients and not mannequins. Thank you.
Okay, we would now request the judges for their questions equally put forward to both teams, please.
I want to know that technically competent doctors, clinical competent doctors, and professional competent doctors, all these terminologies are same, and what does simulation based training will produce? All the three or any one of it for both the groups?
So maybe answer.
Yes, please.
Technically competent doctor, clinically competent doctor, and professionally competent doctors are not the same, but they are steps of the same final shaped doctor who is perfect. And I think a preliminary level of simulation based training will ensure that the doctor who is going into the field, who is operating on actual patient, is well trained, knows his procedure very well before operating on actual humans. They are not the same, but they are steps of a perfect of forming a perfect doctor.
Yes. Your say. Did you get the question?
Yes, sir.
Please.
So what you said, clinically competent, professionally competent, and technically competent, all three will obviously be produced when you have practiced on a patient, because that will give you the confidence. Like you will be sure, like you will be sure on your skills. You will be confident about them. So all these three will for sure be produced when you operate on patients or practice.
Okay. Any questions?
Can you are from which batch? Third MBBS?
So fourth, finally.
Final. Your
Second year, sir.
second years. Have you done your skill labs postings?
So
Have you done your skill labs postings?
So we have
I think
attended skill lab twice.
okay, twice, whatever it is. Now just let me know what will be the procedures which you can learn more in skills labs, and what are all the other procedures which you will learn more in patient direct patient exposure.
Sir,
Yes, it's open for both. Yes.
Sir, there are multiple skills ranging from the basic skills of suturing to advanced skills like cesarean section delivery, vaginal delivery, inserting a central line, all of which we have learned at our level as well, which just shows that if we as second year students know the basic idea of inserting a central line, will ensure that even when we are in final years or when we are residents or interns, we would have a better idea as opposed to somebody who has not attended all these things. My fellow intern who would not have attended a skill lab would not know as much as I do because of the early exposure given to us, which further supports my point that simulation based training is adequate.
Yeah, your take on this.
Sir, I would like to say that procedures like inserting a Foley's catheter or nasogastric tube intubation or an IV line, putting an IV line. So all these procedures like would be better on patients compared to mannequins. They cannot be practiced on mannequins.
Okay, one question. Is there any expiry date for your skills which you have learned in your skill labs?
Sir, that is one of the major advantage that we have, that a lot of the simulators that are there work technically and like on electrically, so they don't really have an expiry date even for.
No, I'm asking about skill.
Yeah,
expiry
even
date
our
on
skills that we develop
Yes.
while practicing on simulation-based training,
Yes.
we can retain them longer, and I don't think they have an expiry date.
What is your say?
I would say if whether it is learned on a mannequin or on a patient, unless and until you practice it a couple of times, you will not be able to retain it or master it unless you have practiced it couple of times and continuously. Yes.
Okay. Okay, fine. Thank you. I think we are through this round after the judges' questions. We will wait for the judges' decision to know who's our second finalist. So thank you very much for participating. Hold your breath as we declare the winner of this round who goes into the final. Yeah, off the record, I do feel very bad for you students now, you know, because during our training, like Dr. Girish would second this. We had wonderful teachers. I'm not saying the teachers now are bad. I still remember Dr. Kakarani sir, Dr. C. Thomas. I was shown a Koplik spot for measles in my second year, which I will never forget. I was asked to auscultate a mid-diastolic murmur for mitral stenosis in my second year. So that was the level of patients we were exposed to. And I feel only one thing makes this big difference is the number of admissions in medical colleges every year. As a teacher, I cannot give justice to more than 100 students. So I think at a given time, that 100 admission during our days made that big difference. So I think it's 200 people coming in, 250 people coming in. There is no personal commit. I had personal commit with every student until it was 100. As of now, I am completely dissociated unless somebody like Ashutosh comes up and pulls me that, sir, let's do it. So I think this is a major issue. Off the record and not to be taken for and against any of this discussion. Are we ready?
Actually, we have a tie.
Okay. So we have a situation where we have two semi-finalists and we have a tie. So we're not clear who's going to go ahead. Now let's listen to what Ashutosh has to say about this.
What an exceptional round with questions and answers and all the statements from all our debaters. Now we are in a fix in case of tie. If there is a tie, we will add the scores of round 1 and round 2 and see which team is the highest scorer. The highest scorer team will proceed to the final round.
Okay, judges, we request you to add the scores from round 1 and round 2 of these teams.
So that second round of 3 to qualifying this one, that won't be added.
Yes, sir. All rounds should be added.
So 20 marks also, like.
Yes,
First
sir.
40,
Yes.
20 and 40.
Yes, sir.
Yes, all
level
rounds.
1, level surprise round, and this round marks should be added to get our finalist team.
Please add all the rounds.
So after adding all the rounds, Team C is winner in this round, sir.
Well performed Team B, and winners that go on to the final is Team C. So now we have the final round. I would request both the finalists to please come forward. Okay, let's hear it for both of them. Come. Let's give a big round of applause to both our finalists, please. Yes, so without wasting time, I request Ashutosh to please proceed with the final, with the rounds between our two finalists, Team C and Team, could somebody change that? Team E, right?
We now arrive at the most anticipated moment of this intellectual battleground, the final round of the debate competition. Let's give a huge round of applause to our two finalists. Let me orient to the final round. First, for the motion, first we will introduce the topic, and then we will draw chits for the sides which are they are going to speak. Teams will get 5 minutes to prepare, and after that we will start with opening statement. So let us start the topic by introducing the introductory clip.
70 to 80 hours a week is 70 to 80 hours a week is reality for most of the resident doctors in India. They say more you learn to perform under stress, better clinician you become. Is it a reality, or it just puts the patient's safety under risk due to burnout of their doctor?
So the topic for our final is long resident shifts, clinical necessity or patient risk. Now we will draw the chits for the side for which the teams are going to speak.
You all are going to be residents soon, so this definitely pertains to you all. Okay, could you please declare? Okay, so it's against the notion. So longer the residents work, it's more risky for the patients, right? You're going to speak against, and you are going to speak for. The more you work, the more you get experience. Are we clear?
So the team C will be for the motion, that is long resident shifts are in clinical necessity, and team E will be against the motion, that is long resident shifts contribute to the patient risk. Teams will have 5 minutes to prepare.
Okay, I request you all to be silent as we go into this finals and final rounds. Please be silent.
If all the teams are ready, then we will begin the awaited final of our debate competition. As we know, the topic is long residentship, clinical necessity and patient risk. So I request the four team to start their opening statement.
Good evening, everyone. I would like to speak for the motion that long residence shifts are a necessity. Medicine is not just a 9 to 5 profession. Hospitals never sleep, emergencies never wait, and patients require continuous care. Long residence shifts are necessary to ensure continuity of care. There are fewer handovers, fewer miscommunications, and fewer medical errors. It prepares doctors for real-life emergency training. In busy hospitals, emergencies come anytime. Preparing residents for real-world stress situations builds clinical stamina. In a country like India, where there is high patient burden and workforce shortage, staff shortage plus high patient load leads to necessary resident shifts rather than a choice. It also builds clinical confidence. Managing multiple cases over long hours improves decision-making speed. Reducing shift without increasing workforce may lead to delayed treatment, longer waiting times, and reduced emergency coverage. Patient safety also means patient access. Indian residency prepares doctors for rural services, disaster situations, and mass casualty events. For example, in pandemics like COVID-19, it was mandatory for the doctors to work long hours. The solution is structured rest during shifts, rotational scheduling, better resilience training, and better staffing. The danger is not structural extended duty. It is unregulated exhaustion. Reform the system, do not weaken training. Thank you so much.
Now I request team speaking against the motion to start their opening statement.
Good evening, everyone. Fatigue is not a badge of honor. It is a clinical liability. We stand here today to challenge the dangerous normalization of exhaustion in medical training. Resident shifts are often defended as tradition, as rigor, as how it has always been. But let us be clear, tradition does not equal safety, and endurance does not equal competence. Medicine demands precision, clarity, and sound judgment. Yet we routinely ask residents to make life-altering decisions after 36 hours without adequate sleep. Research consistently shows that sleep deprivation impairs cognitive function to a degree comparable to legal intoxication. Reaction time slow, memory falters, attention lapses. In any other high-stakes profession, such impairment would be unacceptable. Pilots have mandated rest periods. Truck drivers have RCAPs. Because we recognize one fundamental truth: fatigue kills. Supporters of long shifts argue continuity of care, but continuity is meaningless if the caregiver is cognitively impaired. A tired doctor is more likely to miss subtle signs, miscalculate dosages, overlook critical lab values. These are not theoretical risks. They argue resilience, but resilience is built through structured learning and mentorship, not through physiological breakdown. Sleep deprivation does not strengthen clinical acumen, it erodes it. Long shifts are not a clinical necessity. They are an outdated model born in a different era of medicine, before we fully understood the sign of fatigue and human performance. Today, we know better, and when we know better, we must do better. Because patient safety is not negotiable, and neither is the integrity of the doctor entrusted with that life. Thank you.
Thank you, team. Now, both teams will start with the crossfire round. For team will ask the first question and subsequent round will follow. I want to remind the teams that time limit for crossfire round for this session is 15 minutes. So please use your time carefully.
So we have to ask.
Ashutosh, who's going to start? Who's going to start?
The team in favor of motion. The team going for clinical necessity.
I would like to ask that if doctors are not prepared to work for long hours, how you suppose how will you handle, how will doctors handle pandemics in future? Because the future is unpredictable. There could be disasters, there could be high emergency situations. How do you expect doctors to handle those if they are not resilient enough?
I would like to answer this by saying that there is a thing called as structured handover protocols, which reduces communication errors and faults in such cases. Countries that have capped resident hours like the US or the Europe do not see a collapse of healthcare systems in such pandemics. In fact, they have shown that they can work better than overworked residents or overworked doctors who are cognitively impaired because they cannot see or check for those subtle signs and symptoms when they are made to be awake for 36 hours.
You talked about the US and UK, but bro, we live in India. So as you see the high amount of people or like the population, we have reached I guess 1.4 billion. So with such a large population, you have to have doctors to work for more hours. You don't have an option like the US or the UK.
I would like to tell you that I agree that there in India we do have smaller medical team present. But I would like to ask you that, would you let someone operate on you when you have a life-threatening situation after they've been awake for 36 hours? Or would you rather have a doctor who has had sound sleep operate on you when you are in a life or death situation?
If given an option, obviously I would choose the second one, but we don't have an option.
Yes, we
in
do.
high stress situations,
Yes,
like
we do.
pandemics or disasters.
It's not about just changing the shifts. It's about structured handovers. Like for example, an 8-year-old died in New York City because due to fatigue of the doctor. Or we can see that if a resident is attending more than 24 hours of shift, then 36% more serious medical errors occur, which does not occur in other case. Like for example, if there is fragmented care, then we have a solution to actually make the handovers better and more structured. We don't have a solution for fatigue in that case.
Absolutely no medical care is better than some medical care. Like at least if you have an exhausted doctor, he's better than someone who is not available at the
But
point.
we are not telling you to have no doctor. We are telling you to get a doctor who has had sound sleep instead of a doctor who has been awake for 36 hours, right? That is called as systemic handovers.
But
Okay. Do you want to add to it? You can go ahead.
Even though you talk about the systemic handover, there are still reported errors about miscommunications or other medical errors in patients with the scheduled shifts or the proper routines and all.
That is called a once in a lifetime or once in a majority situation. You cannot just say that if one doctor who has had sound sleep has made a medical error, every doctor who has had sound sleep will make a medical error. It is just pure facts. A doctor who has had sleep will not make as many errors as a doctor who has been awake.
I would say it is not the weakness at the individual level. It is the fault of the system which have no proper scheduling or shifting of the duties and all.
Yeah, so you agree that we should not have long resident hours. The problem is in the system, and we should focus on the system and not on the long resident shifts. You basically agreed to our point right now, na?
What I'm saying is different from your topic. It is a clinical necessity. If we consider in our country with such high patient load, there is need for doctors. If we consider our public health system in the government colleges and all, their patient load is so much high. Even the WHO says that the India ka patient to doctors ratio is 1:1000, which is very low in our rural settings. So without the longer hours in a shift, it is not possible to give the healthcare which we are expecting for the community.
I would like to ask you one simple question. that
Okay,
should-
one sec, one sec. Now, this is your opportunity to ask a question. So you ask the question.
So I would like to ask you one simple question. Would you have a life which is fighting between life and death depend on a doctor who is fighting between being awake and asleep? That is a simple question. If you let the doctor sleep, don't you think that that doctor will have a better chance of saving that patient?
Okay, I got your question. Of course, like sleep is a necessity. I agree. But if there is no option, there are so many patients for you to handle. Of course, like would you like to compromise patient health just for your sleep? What did you say? What do you say while taking the Hippocratic oath? That you will use your clinical skills and abilities to your highest capability as much as you can. So if you actually care about your patients, you should be like you should be like, okay, if I don't sleep it's fine, but I should like help the patient.
Aren't you compromising patient safety even when you are awake for 36 hours and you miss clinical or critical signs and symptoms that will save the patient's life?
You
You are
said that
basically
is-
doing that same thing by not letting that patient sleep. If whatever you just said, you are contradicting yourself right now.
And in addition, the problem is not the long residentship. The problem is inadequate staff. There is the problem. So if there is an adequate staff, the doctor won't be that overloaded. And long resident shifts aren't a choice. They are the last option you have left. So
Yes. Would you like to say something, or you have an opportunity to ask a fresh question? Please don't waste time in asking. You're wasting precious time. I will pass it on to them. Okay? Okay. You have an opportunity to ask a question.
I would also like to ask you one more question, that don't you think that doctors are humans as well? If every human has the right to sleep, then why don't doctors also have the right to be fully alert to do the job that they were meant to do?
As we say, our profession, medical profession, is a noble profession. We knew what it is, not the tea of everyone's cup, right? Like we know what it costs, what sacrifices it is going to ask from us, what we have to give for this patient, this field. That's how it is. Like it comes with some cost, it comes with some sacrifices, and we have to do it.
I would like to tell you that the first key responsibility of a doctor is treating a patient adequately. If you are not able to do that in the first place, then I don't think it is okay to be called a noble profession by you.
I feel the problem is, again, I would like to focus on the same issue, that the problem is not the fragmented care, the problem is the long resident shifts. Like the problem is in the system. If we have an option, we will always choose the fragmented care, where there is, every doctor has adequate sleep, adequate health, so that they can treat a patient in their right mind.
Yes, would you like to rebut, or you want to ask a question? It's your turn to ask a question. Yes, please. Yes, we're waiting. Please ask your question before Christmas. Okay, fine. Do you have a question for them?
I would like to ask you another question, saying that if you say medical profession requires endurance, I don't think endurance should come at the cost of safety of the patient. You are training for crisis management situations, but you are not training in those situations under chronic sleep deprivation. What do you think about whether a patient doesn't the patient have a right to get the best treatment that he should get if he comes to you?
Of course, the patient has his right, but some treatment is better than no treatment. Like as I said before, like if we had a choice, of course, if our system was that strong, we would have had a much more staff, but we do not have it right now. So it is a necessity. Like if we actually had that much staff and if things were that manageable, we wouldn't have had such long residentships. But it is a clinical necessity right now.
I don't see it being a patient's problem. He has the right and he has come to you thinking that he'll get adequate treatment. If you cannot give it to him, that is your problem, not his.
If we consider the real life situation right now, I don't feel there is a single doctor who has not slept continuously for 36.
That is exactly the problem. He has not been able to sleep.
There is no such doctor who hasn't sleep over 36 hours. It is not possible that a single resident is operating whole OPD or the whole IPD of 30 patients
That
or
is
something.
precisely what we are saying. A single resident should not be operating an entire OPD. There should
is
have been
no-
systemic handovers so that multiple residents can adequately
Bro, we
treat
do
the
not
entire
have
OPD.
that much staff. That's what we are
Then
talking
that is a
about.
systemic problem. That is not a patient's problem. He has the right to get good
So
treatment.
you
He'll
are
get
saying
good-
that we shouldn't treat such patients. We
No,
should just go
treat
and
those
go and
patients-
sleep.
We should treat those patients like the patient wanted to
But
be
that
treated.
is not a real life scenario. What you
That
are saying,
is.
that is
It's
very
just not in our
imaginary. That is
country.
an ideal situation in countries like UK or US where there is no population. You see the population in India, bro.
Educate those people, then make more doctors. I don't see that being a problem.
That is in process. The government is increasing PG seats. They are building up more medical colleges, more PG colleges.
So they also agree that doctors should not have 36-hour shifts, right? That is why they're training more professionals.
Right now, it is a clinical necessity in our country.
Okay, I think we are bragging this too far. So I'll give you last comments on either side, even though we have time, but I'm going to cut this session short. 50 minutes, 50 seconds for you to say what you want as the last comment, closing comment. 50 seconds to both.
As the conclusion, I would just like to say that the doctor and the patient both are humans, both deserve sleep and both deserve the best treatment that they can get. I think this is a systemic problem, not a doctor's problem that he is not adequately trained or resilient enough or has the endurance to go through those 36 hours. He has the right, and I think it should be a reform that there should be more doctors who can handle OPDs unlike a single resident that they said.
This long resident shift is not a solution. That is.
Okay, fine. They took 34 seconds. I'm going to give you 34 seconds for your final comments.
I would like to conclude by saying that danger is not structured extended duty, it is unregulated exhaustion. In real life situations, in countries, in a country like India, like the last resort is, it's not even the last resort, like you have to have the resilience to work for long hours shifts, because that is the real life situation right now. And like, yeah, that's it. Thank you.
Fine. So both had 34 seconds for the final comments. I would like to pass on this round to the judges for their questions.
Hello, given a chance, maximum shift duration for a resident should be how many hours? If you want to suggest to the National Medical Council or Medical Council or Government of India.
So this question goes to both teams.
Both the teams.
What would be your ideal shift hours?
8 hours, like it is usually for everyone.
I think it should also rather be as much hours as the doctor seems that he is in his full cognitive ability.
No, then
No.
Fine. Sorry.
I would say कि average of 6 hours of rest or sleep is adequate for any medical professor or in general any person, because there will be some sort of what do we say?
So you're saying an 18-hour shift, 18 hours shift with 6 hours rest, right? So that's exactly what he wants to know. And you're saying an 8-hour shift. Your take, sir.
So considering the the reason for the long shifts, the reason is lack of workforce or it's educational philosophy. Because what we see that during night shifts, most of the cases you get that you won't get in the day shifts. So that's why it will be a subjective that how the fatigue. Fatigue is very subjective. If you get a 8 hours duty and if you are remaining as you are free, so most of the times you are losing on the clinical exposures. Only 8 hours duty is nothing. Okay. And 18 hours also is too much. Okay, only 6 hours is not the duration you have rest. Only sleep is not the part of your life. Other than it's your family, your friends, according to sleep and your daily routine. So it should be in between the both the two. Yeah.
Okay. Any other question?
No, I don't have any question because I'm stunned with this topic as such, because both of them are defending their roles very nicely actually. But to my side, because whenever I quote this in my first MBBS lecture, so there's one more saying that if you cannot work 24 hours, right, as a doctor, then get out of this profession. That's what I say.
Yes.
That is the thing, because that's what I tell, because I always compare other profession with our profession. But nowadays what he says, we have to, because the change is there always.
Yes, yes.
So you have to accept the change. And what he said is again correct, that you need more number of doctors. We need more so that the patients will get a good amount of quality care as such. That is the thing. So whenever there is a change, yes, the change has to be accepted, and then we have to make sure that the patient will get quality care. So both of them are really doing well, but now we will decide what exactly the points are there.
Okay,
But both
so-
of them are really good.
Yeah.
Thank
So
you.
officially we are finished. I would request the judges to give us the final decision as far as the winner of the debate competition for 2026.
What
Off the
was it?
record,
What
off the record as they finalize, you know, back in our undergraduate, PG days, when we were doing a gynac posting, I finished my, I am an obstetrician and gynecian and then an ENT surgeon. There was no time, you know, you stay awake all night. We used to conduct 40 deliveries during the night. And 8 o'clock in the morning, the boss would come for the round. And you had to look fresh. So we used to carry a toothbrush and a toothpaste in our pockets and be there for the rounds. So there was nothing called as time when we were residents. I don't crib about it. It is because of those days that I sit here today. So I don't think, personally, please, it's not against any of y'all. Personally, I feel that we have to slog it out to reach the top. Remember, the people who have reached the top when you people slept. So when you slept, they slogged and they reached the top. So I think as far as I'm concerned, the older version generations, I think there should be no fixed hours for doctors. As a resident, you have to slog. So with this comment, I would request judges, anything else you need to add, Ashutosh?
What an intense round, and there were valuable suggestions from respected judges and moderator. I would request all our respected judges to give us the winner team and also give us the best speaker of this competition.
So you have an additional responsibility to give us a winner and the best speaker, right, Ashutosh? You're looking at two prizes.
Yes, sir.
Hello.
Two prizes, the team as well as the CEO.
So the winner of the today's competition of the debate competition is Team E.
Hello. Okay, and the best speaker is Miss Niral.
Okay, so the audience, we do have a winner and we have the best speaker. The winner is the team on my left, Team E, and we have the best speaker. What's your name? Sorry, I didn't get the name. Neeral. Okay, fine. So,
This thing. Both the teams have done very well in this step. The only thing had decided, the concepts of Team E were more clear than Team C as such. Otherwise, all the points were at the same level, actually.
Now I request the teams to take the stage, to please sit off the stage, and I request our respected judges to please come on the stage. I would like to sincerely appreciate all our participants and all our debaters who have presented their excellent views. Each of one have you displayed the remarkable confidence, clarity of thought and intellectual depth. Debate is not merely about winning, it's about expressing ideas with conviction and respecting diverse perspective. And today, each one of you has done very beautifully. I give a heartfelt thanks to our respected judges and moderator for their valuable time, insights and thoughtful evaluation in this debate competition. Firstly, I request Shweta Tate to present Dr. Wilson Desai sir, moderator of this debate, the certificate of appreciation. Now I request Shruti Dhanekar to present Dr. Girish Dumale sir, the certificate of appreciation. Sir, sir is the judge of this debate competition and have give remarkably exceptional values, insights and knowledge. We are grateful to sir. Now I request Ajit Giri to present our judge Dr. Sanjot Kurne sir, the certificate of appreciation. Sir. No, sir. Now it is the most awaited announcement. Now here is the most awaited announcement. We would like to felicitate the winners of this debate competition, Team E, Krish Gala and Bhumika Shirsat. Give a big round of applause to them.
Please come up.
I request our respected judges to give certificates and prizes to our winning team. And I would like our moderator, Dr. Wilson Desai sir, to felicitate our best speaker, Neeraj Sanklecha. Respected judges, participants, and dear audience, as we are about to conclude this intellectually stimulating debate competition, it's my privilege to propose the vote of thanks. First and foremost, I extend our sincere gratitude to our respected judges, Dr. Dumare sir and Dr. Kurne sir, for their time, fairness, and thoughtful evaluation. And also for moderator, Dr. Wilson Desai sir, in all his help and his guidance for this debate competition. I would also like to appreciate all the participants for their confidence, clarity, thought, and powerful articulation. Your arguments reflected depth, preparation, and true academic spirit. A special thanks to our organizing team and volunteers whose dedicated effort ensured the smooth conduction of today's event. Lastly, but not least, I thank you, all our audience, for your attentive presence and encouragement for all our debaters. With that, we formally conclude today's debate competition. Thank you very much and good night.
I think we would be failing if we don't appreciate Ashutosh. Because, yeah, let's give it. Yeah. We just had a nearly 1.5 hour telephonic discussion late last night. Every single point that happened today was rehearsed on the phone yesterday. So, and I kept asking him cross questions and everything, but he had answers for everything. I think, you know what, it's very simple. I told Ashutosh this, and before we stop, I need to tell you this. Set yourselves high goals. Whenever you need to do anything or perform anything or take a responsibility, it's a simple thing. Do it out of your heart. If you do it out of your heart, you set yourself a different bar. The second time you need to do it, you yourself will always excel that bar. Do you understand how you get better in your own life? So whenever you do something, do it out of your heart. So we had Shariyu, right? Last year. We had Shariyu who did it. So much so that we also happened to be selected by ICMR for a project. She's the only girl who's been selected from this college over a very long time ago. You understand? So that is the level of commitment I am looking out for people who want me to get involved. And I'm sure this guy also will go ahead with something in his life. Thank you very much for Ashu for doing a great job. Thank you for being a wonderful audience. Thank you, judges.
Thank you all. Today's debate competition is over, and you will go. I feel that you will go home with lots of knowledge today. Thank you, everyone. Thank you very much. I request all participants to wait here for 5 minutes, after which we will conclude this wonderful conference we have organized. Please wait.
अरे तो उधर वाजते काय करायचं बोल की डायरेक्ट हे करू घ्या एक एक कमिटीचं डायरेक्ट सत्कार करायचा की चालू करू बोलतोय बोल म्हणतो त्याला बोल की हे बंद आहे रे धावे जरा बंद कर
Behind every successful event stands a team that works with passion and purpose. Now we take a moment to honor efforts of our organizing committee members. May I request each committee member to kindly join us on stage as your name is announced. The student president, Poojan Patil. I request Shrushti Jadhav and Rachana Salvi to felicitate our president, Poojan Patil. Now I request Poojan Patil to felicitate our organizing secretary, Nilesh Pakre. Also the Pranav Kanap, please come on stage. I request Poojan Patil to felicitate Pranav Kanap, our organizing secretary. Now I request Poojan to felicitate Rachana and Shrushti one by one. Shrushti Jadhav. Now I request Pranav Kanap and Nilesh Pakre to felicitate our treasurers, Atharva Shinde and Aditya Pujari. Now I request Nilesh Pakre and Pranav Kanap to felicitate our academic secretaries. Neeraj Patil, please come on stage. Alok Patil, ओमकार वायकसकर, तेजल ठोमके, जानवी पाटील, साक्षी शिंदे. Now I request Rachna and Shrishti to felicitate the food committee. Suresh Pawar. Please come on. Kedar Gaware. Pratidnya Pawar. Sanjana Nandre. Datta. I request Rachna and Shrishti to felicitate creative and decor team. Aditya Panchal, Om Kale, Raghunandan Deshpande, Devashri Moge, Nisha Malpani, Surbhi Snehi. Now, I request our class representative Omkar Vaikaskar to felicitate the Social Media and Technology Committee. Sumit Muneshwar, please come on stage. Aniket Ingale, Yash Ambore, Atharva Edekar, Saloni Sharma, Om Shri Paura, Sonvedi. Now I request our president to felicitate Hospitality Accommodation and Transport Committee. Please come on stage. Sumit Salunke, Kushal Khandalwar, Vaibhav Malge, Soham Sinha, Amruta Patil, Samiksha Pandit, Riyaz Singh, Sanju Hooda. Now I request Nilesh Pakre to felicitate registration committee. Aditya Adsud, Prathamesh Gangadire, Soham Suranshi, Gnaneshwar Godke, Aditya Barve, Priya Gerade, Sadia Hangad, Shruti Deshmukh, Neha Pandey, Anushka Netke, Pranali Sanadi. Please come on stage. आवरा लवकर फ्रेशर्स होणार आहे. Now I request Pranav Konap to felicitate PR and fundraising committee. The special mention Abhijit Raddewad, Samar Damale, Ajit Giri, Sriram Giri, Rushikesh Vibhute, Monesh Jangam, Yug Sakshi Jadhav, Avantika Mahangre, Rutuja Shinde, Sakshi Lengre, Praveen Kadam and legendary Rushikesh Tote. घेतले प्रवीण. बसते मोठी तुला. Now I request our student president Pujan Patil to felicitate the treasurers. Atharva Shinde and Aditya Pujari, one of the hard-working teams. Now I request Rachna Salvi to felicitate magazine committee, Jagdish Pavle, Atharva Jadhav, Shruti Thanekar, Shweta Tate. Now I request Shrushti Jadhav to felicitate quiz and debate committee, Ashutosh Joshi, Rucha Ankari, Gauri. And now the most hard-working committee ever, the anchoring committee.
Now I request President Pujan Patil to felicitate anchoring committee, Poras Parit, Anushka Aute, Avishkar Chigre, Shravani Madi.
सर्वजण एक 2 मिनिटं लक्ष द्या. आता आपण एक 10 ते 15 मिनिटासाठी एक शॉर्ट डीजे सेशन घेतोय. तर पण त्याच्यासाठी पहिले ज्या ज्या खुर्च्या आहेत त्या सगळ्या खुर्च्या बाजूला करा. एक फक्त शेवटचा अर्धा तास आपण करणार आहेत, पण कोणीच मुलं खुर्च्यांना सगळं पहिले बाजूला करा, त्यानंतरच तो डीजे सेशन होणार आहे. म्हणून लवकर सर्व खुर्च्या बाजूला करा. तो हा नाही म्हटलं रे, मला माहिती नव्हतं रे.